Distinguished speakers and valuable participants, for
Kıymetli
104
konuşmacılar,
years, Green Crescent has been tackling
değerli
alcohol,
katılımcılar,
tobacco,
Yeşilay
and
104
gender-based
yıldır
global
iyi ve
initiatives to
sağlıklı bir yaşam
promote
için
good and a healthy life. Today, Green Crescent makes its presence even felt more strongly in the field of intervention with a total of 107 Green Crescent counseling centers and 2 Green Crescent rehabilitation centers in Turkey as all 81 provinces and Turkish Republic of Northern Cyprus. In addition to its addiction prevention activities, especially for youth and children. Moreover, it continues to carry out effective and widespread activities on addictions through its intervention operations, playing a leading role in tackling addictions at national and international level for 104 years. Green Crescent also contributes to the development and dissemination of scientific knowledge in this field through international congresses and symposiums. Today, leading researchers and representatives of organizations and institutions in the field of addiction coming from different parts of the world gather at the International Congress on Psychoactive Substance Use Disorders hosted by Turkish Green Crescent. Throughout the two-day Congress, many remarkable speakers will discuss psychoactive substance use disorders, the addiction, and the current practices and research on drug addiction, prevention, intervention, and advocacy activities, new risks and the threats that emerge during this period, new perspectives and experiences, the lessons learned, innovative policies, action plans, and intervention program suggestions on tackling drug addiction. Before commencing our session, I would like to thank all of our esteemed speakers and the participants on behalf of Turkish Green Crescent for their great contribution and interest to the program. And I would like to make a few announcements and reminders as well. The first one is about the language of the Congress. It will be both in Turkish and English. You can set the language you are aiming to follow the Congress by using the language button on the screen. And the other reminder is about the certificate of participation. Once the Congress ends, you can have the digital certificate of participation via the certificate button on the Congress website. And please do not forget that only registered participants who follow the live broadcast via Zoom link will be able to receive the e-certificate with their registered email. So without further ado, I would like to make the Congress kick off by now leaving the floor to the Turkish Green Crescent President, Associate Professor Mehmet Dinç. I kindly leave the floor to deliver the opening remarks. The floor is yours, dear President.
Merhabalar, kongremize hoş geldiniz. Türkiye Yeşilay Cemiyeti olarak 104 yıldan beri insanımızın
First
ve
of all, I would
insanlığımızın
like to welcome you all to our Congress. As Turkish Green Crescent, we have been tackling with the addictions for 104 years. Addiction may lead to harms that might be irreversible, and the most risky times are the times of childhood and youth, especially the abuse of psychoactive substances cause serious damages to health and well-being, and for that reason we are working hard to see how we can protect our youth, our children. Turkish Green Crescent is carrying out prevention and rehabilitation activities with 120 branches across Turkey, and the addiction prevention program, which is the largest prevention program, is carried out in our country, and we have been conducting this program with nearly 2 million students. If any child is involved in any kind of addiction, then a response is given to such children to help them get rid of such addictions, and also in order to prevent the confusions that might come with teenage years, we provide them with life skill trainings as well as life skill group
Ama şayet bir
therapies,
şekilde
and we implement
herhangi bir
this
insanımız
across
bağımlı oluşursa
Turkey.
da o
If
zaman
any
bize
of our citizens has
gelecekte
become
hiçbir
addicted,
insanımızdan ümidimizi
then
kesmiyoruz.
we never
Onlardan
lose our hope
kurtulacağımıza
on
kesinlikle
them
katılmıyoruz.
and we never get
Türkiye'nin
any
her yerinde,
negative idea
bildiğiniz üzere
about
her
them.
şehirde
At
hizmet veren,
107
tümünü düzgün
different
şekilde hizmet
points
veren
of
ve bize
Turkey,
esaslı olarak
we have
hizmet
our
veren
Green
danışmanlık
Crescent
merkezlerimiz var.
counseling
Bu işlerde
centers that are
yaptığımız faaliyetler
providing
dünyadaki
services
çok
for
iyi
free.
örnekleri göz önünde bulundurarak
And
onların
by
yaşadığı
considering all the
coğrafyada
good
ülkemizdeki
examples and
gibi
making use of
biraz
their
daha toplumsal
experiences,
yapısını
as
gözeterek
well as
ülkelerimizin
considering
kullanarak
the
bu anlamda
cultural
da bu
structure of
projeler
our country,
yenilikçi,
we
adapte
have
bir
an
danışmanlık merkezi
authentic
olarak
and innovative
faaliyetlerini devam ettiriyor.
counseling center.
Psikologlarımızın
Our
psikolog hizmetinin
psychologists
yanında sosyalize
provide
çalışmalarımız yapılıyor.
psychotherapy
Tamamıyla
services,
kapatılmış
and
insanların
also the
hayatını
social
iş
workers
faktörlerinden mümkün olduğu
help
kadar elimine etmesi şeklinde
the
eğitiminin
people
yanında aynı
eliminate
zamanda akademik
such addictions
çalışmalarıyla
from their
hem
lives.
değerlendirmelerine hem de
And this
e,
way,
meslek edinmelerine yardımcı olacak bir
we
sistem söz
help
konusu
them
oluyor.
get
Bu
a
program içerisinde
profession.
zaten kongre içerisinde de
Within
onların
this
gelişmiş
Congress,
olduklarını
you will hear a
görmüş
lot
oluyoruz. Tabii bu
about
modeliyle
our
beraber,
counseling
sayılarla
centers,
beraber çok detaylı
as
bilgiler
well
olacak.
as
İlk
numbers
noktada
will
ifade
be
etmek isterim ki İşlerce
described to
Danışmanlık
you. But I
Merkezimiz
would like
uluslararası
to
yapılan
say
bir
that
büyük
the
ve
Green Crescent
iddialı
Counseling Center
Türkiye İşlerce
is
Danışmanlık
our
Merkezleri
pride,
üzerinden
and
ülkemizde hiçbir bağımlı kardeşimiz bu problemi yaşamayana kadar mücadelemizi
we
sürdüreceğiz.
will
Özellikle
carry out
psikoaktif
our
madde
struggle
kullanım
until no
bozukluklarıyla
citizen
alakalı
is
hem
having
ülkemizde
such
hem
problems.
de dünyada
Especially,
büyük bir gündem olduğunu farkındayız.
we know that the
Dikkatimizi
abuse
büyük
of
oranda bu
psychoactive
konuya
substances is a
çekmemiz
very big matter both in our
gerekiyor.
country and
Çünkü
across the world.
yaptığımız araştırmalar,
Our
dünyadaki
studies
uluslararası kuruluşların bize verdiği bilgiler
indicate
bize açık ve net gösteriyor.
that
Her geçen gün çok daha
every
fazla
other
madde
day
sisteme dahil oluyor.
many more
Sadece
substances
2023 yılında
are entering
37
the
tane
system.
yeni
Only
psikoaktif
in
madde sisteme dahil olmuş
2023,
durumda. Bunlar sarhoşlar
950
ve
new
içecekte
generation
gayet hayatlarına
psychoactive
itibaren
substances
itibariyle tanışmasıyla
were
kullanmaya başlaması
launched to
bizi
the
ciddi
market,
anlamda bu
and
konuda yapılacak
we
çalışmalar
are
konusunda
quite worried
daha
because our
hızımızı
youngsters
artırma noktasına
might be
getiriyor.
involved with such
Dolayısıyla ısrar
substances
ve
at a
dirençle
very
karşı olmak
young
gerekirse
age.
bütün
And for
insanlarımızın,
that
bütün insanlığın
reason,
psikoaktif madde kullanım meselesini ciddi olarak gündemimize
we
almak
take
zorundayız.
the use of
Yine bunun stratejik
psychoactive substances
bazı
very
kullanılması
serious.
ve
It is
bu
also used as a
ciddi anlamda
strategic
ölçekli anlamda
weapon indeed
değerlendirilmesinin
to
çok
affect the communities negatively.
sağlıklı olmayan, doğru olmayan, ahlaki olmayan, etik
And
olmayan bir zemin olarak
we
yerleştiğini
consider
görüyoruz.
it
O
is
yüzden de
as an
bu noktada
unhealthy and
bir
an
çalışma yapmanın
unethical ground.
söz konusu olması
And for
çok
that
önemli olduğunu
reason,
düşünüyoruz. Çünkü
we believe it is very important
bu
to
bağımlılık
discuss this
meselesinde
matter
psikoaktif madde kullanım
because
bozukluklarının çalışılırken
while
meseleyi
studying
sadece
the
fizyolojik
abuse of
açıdan, sadece
psychoactive
psikolojik
substances, we
açıdan
do
değil,
not only take it
sosyolojik
as a
açıdan da,
physical or
coğrafyal açıdan
psychological
da,
matter, but
ekonomik
also
açıdan da
we consider it from
en
a
boyutlu
social
olarak
perspective,
hatta siyasi
economic
açıdan da en
perspective,
boyutlu olarak ele
political
alarak bu
perspective.
problemle
So,
mücadele etmemize
handling it with a
çok daha
multifaceted
önemli.
approach will
Çünkü
be very
yakın
effective in
zamanda
dealing
yapılan
with this
çalışmalar
problem
başta olmak
because the
üzere birçok
recent
faktörde
studies
bağımlılıkla
have
alakalı
shown
risk faktörü
that
yüksek olan gruplar
the groups with a high
sadece
risk
ve
factor
sadece
of
belki de hatta
addiction
genetik yatkınlıktan dolayı
do
böyle bir probleme
not
sahip
only
olabiliyorlar.
have
Böyle bir
this
problemi
problem for
tanısıyla
genetic
olayın çıkması,
disposition,
problemin
but
çok daha boyutlu,
also
çok daha farklı,
the
psikolojik
problem
bir tabanı var.
has
Dolayısıyla bu
a
meseleyi ciddi
sociological
anlamda konuşuyor
ground.
olabilmenin bize
Therefore,
sağladığı hukuki çerçevenin çok hızlı bir şekilde
the
oluşturulması
legal
gerektiğini
framework on this
gerçekten bu
subject
noktada
must be
vurgular
created very
yaparak hızla
quickly,
beraber
and
devam
we are
etmeliyiz.
working
Ancak bu
on
noktada
this now.
altını çizmek istediğim çok önemli bir nokta var.
And
O
there
da
is
şu:
a very
bağımlılık
significant thing that I
endüstrisi
would like to
dediğimiz yapı,
emphasize.
yani
The industry
insanların
of
bağımlılıktan
addictions,
faydalan,
I
para
mean,
kazanan, bir
those
şeyler
who
kazanan
make
bu
money
bağımlı
or who
insanlar
make benefits out
ciddi
of
anlamda
people's
profit
addictions
yapabiliyorlar.
work in an
Dolayısıyla
organized
mutlaka
manner.
bağımlılık karşıtı olan yapılara,
And therefore,
İsrail gibi diğer
the structures that
toplumların
struggle with
temsilcisi olan, bağımsızlığı içeren yapılara
addictions,
mutlaka organize bir şekilde güçlü
such as
mekanizmalar
Turkish Green
geliştirecek,
Crescent and
güçlenecek
other
mekanizmalar
organizations,
beraber
have
hareket
to
etmesi
share their
önemli olduğunu
experience
düşünüyorum.
and their knowledge.
Çünkü bu kadar büyük,
Otherwise,
kapsamlı ve ekonomik siyasi boyutu güçlü olan bir meselenin Küçük çalışmalarla, bağımsız çalışmalarla, tek başına
A
yapılan
subject
çalışmalarla
with a very wide coverage, both in political sense and economic sense, will prevail and we will fail at our operations, our efforts. Therefore, we have to work together and unite. And secondly, the addiction industry is renewing its language and its strategies all the time. Therefore, we have to update our strategies and we need to see how we can work more effectively. Otherwise, carrying on with the strategies that do not work will leave us weak. So we have to work together on this matter as well. Also, when you look at the addiction industry, you can see that they are very stubborn. No matter how much political arrangements are made or no matter how many precautions are taken, they still enter the people's lives in a stubborn way. So we should be more stubborn than them so that we can also enter the people's lives because the addiction industry is doing something very wrong. It is one of the biggest betrayals to the humanity. It's one of the biggest damages possible. And
sivil toplum kuruluşları, bilim insanları olarak
the
bizlerin
NGOs and the scientists that work very hard for the well-being of the people should be more stubborn, should be more hard-working for the good of the people. So we have to be working much more strongly. We should not have any pessimism. Otherwise, it's a very big threat because some studies and some scientists suggest that the precautions are not effective or not sufficient, so they may share such pessimist ideas. But
insanların bağımlılıklardan kurtulmasıyla alakalı ümidimizi ve heyecanımızı
we
kaybetmemeliyiz.
never lose our hope for the independence of the people. And for that reason, I would like to once again reiterate my message to you. We will never give up on our children, our youngsters, and our citizens. And for that reason, such congresses are very significant, I believe, because many studies are being conducted with respect to addictions. However, the studies that are not sustainable might be harmful. And it may lead the people who are suffering from addictions to hopelessness. The motivation for rehabilitation and recovery may not be long lasting. Therefore, when a model that is not sustainable is implemented and fails, then the people suffering from addictions or their relatives may become hopeless and they may give up on their efforts for recovery, and that is the biggest damage to the people indeed. Therefore, we have to be evidence-based, we have to be scientific, and we have to ensure the sustainability, and we have to follow the efficacy of such studies. We will be discussing these matters at length in our Congress. I would like to thank all of our participants, and my biggest gratitude goes to the scientists who are supporting us in our Congress, and it will be hopefully a fruitful Congress for all. Thank you very much.
The
Buyurun Rübeyt.
president of Turkish Green Crescent, Associate Professor Mehmet Dinç, thank you so much for this valuable speech and these strong remarks. With these remarks, we kicked off the International Congress on Psychoactive Substance Use Disorders, and now it's time to hear more from the Director of Public Health, Associate Professor Muhammed Emin Demirkol. I kindly leave the floor to Muhammed Emin Demirkol from the Turkish Republic of Ministry of Health to deliver the second opening remarks of the Congress. The floor is yours.
Evet, kıymetli başkanım, çok değerli Yeşilay
Esteemed
gönüllülerimiz,
President of Green Crescent, distinguished administrators of Green Crescent and dear participants, I'm joining you from Ankara, the Ministry of Health, Department of Public Health, and I wish you all a fruitful Congress.
Bağımlılıkla mücadele ve bu kongre açısından da uyuşturucu mücadele konusunda Yeşilay'ımızla birlikte fazlaca
We have been carrying out a lot of activities along with Turkish Green Crescent to tackle with the addictions, and the General Directorate of Public Health is struggling against the addictions of tobacco, drugs, alcohol, and digital addictions. The Minister, Professor Dr. Memişoğlu, is leading our activities, and the Ministry of Health
koordinasyonunu ve sekreteryasını illerimizde valilerimizin başkanlığında yürütmekte.
coordinating the activities under the chairmanship of our governors, and the activities that are conducted jointly with the Green Crescent are indeed very fruitful and very beneficial for our citizens and our people. The tackle against drugs is highly important, with the technology advancing and the world becoming a global village. We have entertained very good advantages. However, we are also seeing some certain difficulties with respect to the addictions of drugs. As you all know, the drugs are becoming prevalent very easily across the world, and they can be easily accessed nowadays. And with the coordination that we have, and with the Green Crescents, with the Ministry of Health and Ministry of Education, we are working very hard to handle this problem. And these activities with multiple stakeholders is indeed very beneficial, as we can see in our coordination councils under the leadership of Deputy President Cevdet Yılmaz. We have our Addiction Prevention Council, and in this council we are also reiterating our vision for the future. I wish that this Congress will be fruitful for our country, for our state, and accordingly, I would like to thank Turkish Green Crescent for their cooperation. We also have our governors and our provincial directors who are carrying out the prevention activities in our provinces, and I would like to extend my gratitude to them as well. And we have our rehabilitation centers for the people suffering from such addictions, and in these centers we are helping the people for the cleansing part and the rehabilitation activities, and we're contributing to the well-being of the people through our centers as well. And in our country, we have nearly 300 healthy life centers, and our experts are helping the people with their addictions. And I would like to thank all the relevant stakeholders and the organizations, especially Turkish Green Crescent, for their cooperation. because the struggle against the drugs is highly important, and this Congress is a milestone for that. I would like to thank the participants for their participation and greet you all respectfully.
General of Public Health Associate Professor Muhammed Emin Demirkol, thank you so much for your contributions and the strong remarks. And we now actually completed the opening remarks of the Congress. Now it's time for a short break, and we'll continue right after the break. We'll continue with the first keynote speech of the Congress. Hope to see you again in 15 minutes. Esteemed participants, welcome back to the International Congress on Psychoactive Substance Use Disorders. Today's program consists of one keynote speech and 3 sessions. Each session will last 1 hour. Your questions will be answered at the end of the session under the supervision of our session chairs. Please do not hesitate to send your questions to us through the chat section. The Participants International Congress on Psychoactive Substance Use Disorders begins with the first keynote speech. This speech will focus on new risks and dangers on substance abuse. Dr. Kamran Niaz from the United Nations Office on Drugs and Crime will deliver the speech, chaired by Mr. Esbjørn Hornberg, who is Executive Director of Movendi International. Dr. Kamran Niaz will be with us with his speech titled Emerging Issues in Global Drug Use, Findings from the World Drug Report 2024. I would like to welcome our esteemed session chair, Dr. Esbjørn Hornberg, and our keynote speaker, Dr. Kamran Niaz, for being with us in this Congress. Now, I kindly leave the floor to the session chair, Mr. Esbjørn Hornberg, to chair the session, which will last approximately 1 hour. The floor is yours, Mr. Hornberg.
Thank you very much, and good morning from Sweden. It's a pleasure and an honor to be chairing this session together with a good friend from Vienna, Dr. Kamran, and he will go through this World Drug Report 2024, where we can see what has happened since the last century and also all the decades as well, and also give us some impressions of what is the threats to our society. Dr. Kamran, you have the floor.
Ladies and gentlemen, dear participants, good morning and greetings from Vienna. And it's always good to see good old friends, on the screen. And I'm sure there would be many other old friends, colleagues among the participants. So my presentation is based on the findings from the World Drug Report. It's kind of like a reflections from the findings, and I'll try to present some of the emerging issues in global drug use and the health consequences. When we look at the global drug problem, it has to be seen in the local context in which the various drug phenomena are occurring. And therefore, what you see on the screen is that it's quite different. The drug problem, the nature of the drug problem, the extent is quite contextualized and very different in the different parts of the world. And just to give you the rundown, the blue shades that you see on the map are those regarding to either the production, manufacture, trafficking, or use of cocaine. The greenish shade reflects the use, production, or trafficking of opioids. The purplish one is for amphetamine-type substances, and the yellowish hue, wherever you see this, relates to HIV among people who inject and use drugs. So if you see, as I said on this map, the dimensions of the drug problem are quite different across the regions, and each region has its own uniqueness of the drug phenomenon and the threat that emerges from it. Having said that, I'll try to present you some of the major findings across the various regions and what stands out in each one of them. So this is like a figure that you have seen quite commonly, but what we would say is that the inequalities, social and economic disparities continue to drive as well as are driven by the drug phenomenon globally. And what we see is that the extent of drug use continues to increase, and it's still higher than what we had seen a decade ago. And we see nearly a 20% increase of the number of people who had used any drugs in the past year, over the past 10 years. And so, I mean, the number is like 292 people who had used any drug. The most important thing in there is that cannabis remains the most prevalent substance among these drugs. When along with the number of people who use drugs, there's also an increase in the number of, rather the proportion of people who use drugs and suffer from drug use disorders. And the number that currently you see stands at 64 million. So nearly 1 in 5 people who use drugs are currently suffering from drug use disorders. And when we look at how many people among these who are suffering from drug use disorders have access to any structured treatment, the figure is appalling, and it stands at 1 in 11 people with drug use disorders have had access to any drug treatment. And when we look at women, the disparity becomes much wider, and nearly 1 in 18 women with drug use disorders have access to or were in treatment. Overall, when we look at the numbers, we see there are more men than women who use drugs, and that stands quite true when we look at the use of opioids, cocaine, or cannabis. But when we look at the non-medical use of pharmaceutical substances such as pharmaceutical stimulants, non-medical use of pharmaceutical opioids, non-medical use of sedatives and tranquilizers, we see that the gender gap between men and women using those substances much narrower than what you see with regard to opioids, cocaine, and cannabis. Young people also remain more vulnerable to drug use and drug use disorders. That also affects their development as adults. And this is a figure for past year use of cannabis among adolescents versus the general population. And you see on the left-hand graph, the past year prevalence of cannabis use across all the region is quite higher than the rates among the general population or the adults. An additional challenge to use of cannabis is the vaping of cannabis among adolescents that is spreading with its own health consequences. And when you look at the proportion of young people in treatment, that again is something very striking because from nearly 1/4 of people in Southeastern Europe, for instance, to nearly half of people in South America who are in treatment for drug use disorders are young people who are under the age of 25. So, I mean, as the research has shown, the early initiation of substance use is more likely to result in harmful use, development of drug use disorders, but also of, it hampers the socioeconomic development and the opportunities for the person in the adult life. Moving on, people who inject drugs as the other key populations continue to be the population that drive the global HIV and hepatitis C epidemic and infections. People who use drugs or inject drugs are 14 times at 14 times higher risk than the general population in acquiring HIV. And if you look at the global figure, we estimate that there are nearly 14 million people who inject drugs. The number of people who inject and the prevalence remains quite high in North America as well as Eastern Europe. And as I said, people who inject drugs continue to drive the HIV epidemic, and nearly 1.6 million people who inject drugs are living with HIV. And if you look at the prevalence of HIV, you see quite high numbers, higher than the global prevalence in Eastern Europe as well as in Southwest Asia, among the other regions. Again, hepatitis C, a global epidemic of or global infections of hepatitis C are also driven by essentially by people who inject drugs, and nearly half of people who inject drugs are also infected with or living with hepatitis C. So that's one of the major health consequences, and hepatitis C and associated liver diseases are one of the leading cause of death among people who use and inject drugs. I'd given you the numbers on the access to treatment now, where we said that nearly 1 in 11 people with drug use disorders have access to treatment. If you look at the type of substances for which people are in treatment for their drug use disorders, cannabis and opioids stand out as the two main drugs reported among people in treatment. But you also see methamphetamine predominating treatment demand in some parts of Asia and Oceania. And again, as I've repeated, women continue to be underrepresented in drug treatment. And when we look at some of the reasons why women are unable to access drug treatment, even where their rates of drug use are even at comparable level with men. It's the social stigma, the lower economic power of women. You have the patriarchal societal arrangement that give rise to a host of negative repercussions for women who use drugs, which also results in the social and structural as well as interpersonal factors that affect genders differently in terms of their vulnerability to health risks and then in seeking health care. And as we have seen, social stigma, but also violence and physical abuse, also in and around the community, drug services affect accessing services, especially for women. And most importantly, what we have seen in most part of the world is that there is a lack of gender-specific facilities and services that would, for instance, address the specific needs of women with drug use disorders. Moving on, I mean, I've shown this slide that cannabis remains one of the substances with where people in drug treatment. Overall, what we have seen that there has been an increase in global increase in cannabis use, especially among young adults. And it's not just the increase in the number of people using, but it's also an increase in the frequency and the quantities of cannabis use. And we see there are more people who are using daily or near daily use of cannabis. To go along with that, the cannabis products that you see in most of the markets globally are with very high THC contents and low CBD, which means that they are more potent, have more psychoactive contents than the cannabis products that used to go around in the 70s or 80s. And all of this has then, resulted in increase in cannabis use disorders and treatment demand across all the regions. And if you look at the bottom right corner, that's the treatment demand for various substances in some countries in Africa. And the green color represents the demand for treatment for cannabis use disorders. And you can see how it predominates people in treatment in some of the countries in Africa from where data was available. If you remember the first slide I'd shown, there are nearly 60 million people who use opioids for non-medical purposes globally. Out of those, more than half of the people who use opioids are in Asia. Opioids, along with cannabis, are one of the major substances that you see in drug treatment, but opioids also contribute to most of the burden of disease that is attributed to drug use. Again, when you see the distribution of the various kinds of opioids, you see a very distinct picture on the map on the right-hand side, where you see that in parts of Asia and Eastern Europe, you see a predominance of heroin use, whereas when you look at North America, parts of South America, you see a more predominance of non-medical use of pharmaceutical opioids. And then when you look at parts of North Africa and Western Africa, there is more a predominance of non-medical use of tramadol. So even when you look at one particular group of substance or class of substances, even the substances that are used are also quite different globally. One other element with regard to opioid use is that a threat that we need to look for is that following the ban of opium production in Afghanistan, there has been a drastic decrease in opium production in Afghanistan as well as in Myanmar, resulting in a fall of production by 74% in 2023. Now that will result in heroin availability declining in many of the markets where heroin is the predominant opioid that's used. And what we see is that the demand in those markets may adjust differently in different ways depending on national circumstances. And what we see is that there might be a trend with spread of synthetic opioids, especially the various analogs of fentanyls and nitazines that may, spread out and kind of like, meet the demand where heroin is not available. Moving on from opioids, if you look at amphetamines, and that would mean the non-medical use of methamphetamine as well as amphetamine or amphetamine type substances. And in general, what you see is that the use of amphetamines is quite high in Southeast Asia and North America, but then it's also increasing and expanding in other regions, as you can see from the graph on the right-hand side, which shows how the seizures are increasing in the various regions outside East and Southeast Asia, as well as North America. And the center graph that you see over here is that there's also an increasing trend, both in treatment for amphetamine use disorders, as well as an increasing trend in their use across the various regions. Ketamine is another substance. It's one of those substances that is not under international control, but is used as an anesthetic. That's its medical use. And it is also now being tried, there are clinical trials of ketamine use for treatment of various mental health disorders as well as treatment for substance use disorders. But what we see is that ketamine has become a mainstream drug in some population groups in East and Southeast Asia, but then it is also increasing in other regions, which is also reflected in the increasing seizures of ketamine, the prevalence of ketamine use in various countries outside Southeast Asia, the increase in the number of people who are accessing treatment for ketamine use disorders. So all the indicators are using the spread of ketamine across the globe, but keeping in mind that ketamine is not one of those substances that is under international control as the other substances are. Moving on to cocaine, what we see is that the world is currently experiencing a prolonged surge in both the supply and demand of cocaine, which is, as I said, driven by high production of cocaine in South America. But you also see an increasing use that we have observed over the past years. And we also see an increasing number of people accessing treatment in the Americas and in Europe for cocaine-related problems. And what we see is that there is also a growth in cocaine use as well as cocaine seizures in places that were not considered as the traditional markets of cocaine. So you see quite some increase in Asia and as well also in parts of Africa. The new psychoactive substances are kind of substances that are also not under international control, and they essentially come out of all the various research chemicals. And we see that the number of new psychoactive substances that are coming on the market appears to be stabilizing. But what you see is that there are still high proportions of stimulants, such as catenones and synthetic cannabinoids that seem to predominate the number of NPS that you see coming on in the market. But now you also see an increasing group of synthetic or research opioids, such as nitazines, that are coming up in the market. And nitazines are the kind of opioids that are, or at least some of the nitazine analogs are more potent than even the fentanyls. And another group of substances that of NPS that we see emerging are the benzodiazepines, and one of the example is of xylazine. Moving on to the digital markets, what we see is that the digital interconnectivity has also brought innovations in the way that drugs are bought and sold, making the drug supply chains shorter, reducing the cost, and increasing the accessibility of various drugs. And different platforms on the darknet, but also on the clear web, make the drug supply more varied in terms of the user groups. And I think one more issue of concern is the increasing use of social media platforms as well as the gaming platforms that are used by young people for low-level drug transactions. So that's an area which essentially there are no controls on who uses them and how those transactions might be happening across those various digital platforms. When we look at the availability of controlled substances for medical purposes, especially the availability of opioids for palliative care and pain management. Again, we see a large inequality and large disparity in access to those various opioids. And essentially what we see is that 86% of the global population have access to very little amounts of opioids globally, and the 20% of the population in high-income countries have access to the majority of opioids for pain management and palliative care. Although there has been an increase in the availability of opioids, especially for opioid agonist medications in low and middle-income countries, but the disparity in the availability and access for opioids still remains dismal in most parts of those countries. Moving on to another area, that is of the medical use of cannabis. What we see is that as of 2021, there were 64 countries that had provision in their national legislation or had developed guidelines allowing the medical use of cannabinoid pharmaceutical preparations for medical purposes. If you look at the scientific evidence, cannabinoids are typically recommended for use after a patient has failed to respond to conventional treatment for those conditions or as an adjunctive therapy. So in most of the literature, there is conclusive or at least substantial evidence that cannabis and cannabinoids are effective for the treatment of chronic pain in adults. It's effective in the treatment of chemotherapy-induced nausea and vomiting, and it's also effective in mitigating patient-reported multiple sclerosis type symptoms in epilepsy. Beyond these conditions, the evidence of the effectiveness of cannabis in the treatment of other conditions is either moderate, insufficient, or inconclusive. So we cannot say that cannabinoids can be used for all kind of treatments. But what we see is that the regulation of medical cannabis remains quite varied across the various countries that have provisions for medical use of cannabis. And what we see is that the availability of medical products quite varies, where some countries may only allow those medical cannabinoids that have the marketing authorization, that is, that they are standardized cannabinoids produced through the pharmaceutical industry. The example being Nabilone or Dronabinol or Nabiximols, which are standardized cannabinoid products. And then beyond those, you see a wide range of different standardized or unstandardized cannabis products, as well as magistral preparations of cannabinoids that are available for medical use in the different countries. So if you see on this infograph over here, it goes from the very standardized to uncontrolled type of substances that are available for medical use of cannabinoids. The same goes with the patient access, where there is a limited access, where there is access to medical grade and herbal products through a general practitioner or a range of predefined conditions, to the wider access where there is limited medical oversight of medical use with access through a dispensary or just a medical recommendation, and you can use cannabis for whatever perceived purposes. The same goes with the supply of those cannabinoids or cannabis products, where it varies from being very centralized and controlled production schemes to very decentralized, where anyone can produce whatever cannabis products and to be sold in the market. So this is the the variation in how medical cannabis is being rolled out in the different countries, with varying degrees of success or issues that arise from those. Some of the issues with regard to the regulation of medical cannabis is that there has been a false perception of the health and safety of some of those cannabinoids. In the absence of clinical guidelines on specific medical conditions for which they can be used, health practitioners are often uncomfortable speaking to patients about the medical use of cannabis. Friends, family, often social media become the source of information for people for cannabis for medical purposes. The perception that herbal cannabis and cannabis products are just a natural remedy of natural origin of cannabis plant would be just like natural products, so there should be no safety concerns for those, which lead to the reduced perceptions of harm, in addition to the increasing non-medical use of those cannabis, as well as, sorry, as well as the marketing of CBD-based products as health and wellness products, often labeled as cannabis, amplifies the perception of no harm and all good from use of cannabis. And to top all of that, there are commercial interests, industry-led diversification of products with high levels of THC and dosage of cannabis products that are often the same as those sold in the non-medical market with high THC and low CBD. But all of this is leading to an increasing use of cannabis, increasing cannabis use disorders and treatment demand, as we have seen, as I've shown you in the earlier slides. One final area is the developments in psychedelics and the research, which is now raising new questions. Essentially, what we see is that there is a resurgence of interest in use of psychedelics in treatment of various psychiatric disorders, mental health disorders that had not responded to conventional therapies. So we have at the center, there are clinical trials. Some of them have promising results for the use of psychedelics or psychedelic assisted psychotherapy for treatment of some of the major psychiatric disorders such as major depression, PTSD, and so on. But then there are also other developments that are led by commercial interest and advocacy groups that seem to be unprecedented. And what you see is that there is a boom in microdosing communities. There is psychedelic-led tourism. There are psychedelic communities that are, kind of like promoting a perception of no harm and safety that may even encourage more unsupervised and non-medical use of psychedelics. So the most important thing that I want to highlight over here is that prioritizing public health challenge in the face of that growing commercial interest in developing and profiting from the new legal markets such as cannabis is becoming quite an issue for the global policymakers. And what we need to really look at is how we can have that public health, that balance of ensuring the public health needs to and the non-medical use of those substances and the associated harms. And I end with this final slide where, we need, in order to address the global drug problem with the local dimensions, we need to look at the whole drug problem from the context of the right to health, which essentially means that You have to ensure access to internationally controlled drugs for medical purposes, including for pain management and palliative care. We have to have um, um, scientific, evidence-based, gender-appropriate drug prevention interventions, as well as addressing the underlying social and commercial determinants of health. We have to have we have to have scientific, evidence-based, quality, age and gender appropriate drug treatment and care services, including measures that reduce the harm for people who use drugs. But most importantly, we also have to ensure the equity and the non-discrimination in the realization of the right to health of the people, ensuring meaningful participation in all health-related decisions to address the problems related to use of drugs. And with this, I conclude, and thank you very much for your attention and giving me the opportunity and the time to present this. Thank you very much. Over to you.
Thank you very much, Dr. Kamran. It was so interesting. And usually, when you are listening to some of the presentations in this area, you have put up your questions first, so there will be some kind of a communication. But this time, I must say, out of the close to 400 participants who have followed your session here, there is a number of very good questions, and I will run into them just now. The first one, you mentioned that the gender gap in cocaine and cannabis use is closing. What do you think is the reason for this increase among the women?
I think it more has to do with the opportunities to use. Like if you look at in general, cocaine and cannabis use has been more associated with cocaine use has been more associated with the recreational use in recreational settings, and it seems that in where there are more opportunities for women to participate in various activities outside, they also have more access to drugs. The same as the women, you saw that the level of use between men and women for pharmaceutical substances was always quite low. So I guess one of the, I mean, there can be many reasons to that, but one very main reason is that the opportunities to use and to be in that environment where those substances are also readily available and accessible to women than it choose to be for men in most of outside the Western world, I would say.
Okay. Thank you very much. Why do you think non-medical opioid use is so high in Asia?
That's a very interesting question and something that makes me think as well. I think if you look at the South Asia, for instance, they've had a um, more long-standing tradition of opium use, opium smoking, and that has moved on to a higher use of heroin. And then when there are more pharmaceutical opioids available of the use of those opioids. So I guess it comes from it's the same question as you ask why there is more cocaine use in South America, because South America has a tradition of coca use and coca cultivation. So I would put it in that perspective that you have to look at the historical aspects where, I mean, in the earlier 20th century, there were even like opium wars as well, for production of opium, cultivation and production of opium in those regions, by the colonizers. So those regions have a long-standing history of opium and opioids use, which has moved on to the opioids.
Thank you. I have a question by myself here because
Okay.
I've been engaged in Southeast Asia for quite a long time, and I can understand that the growing opium in Myanmar is very hard to combat in a way because of the situation, the political and military situation in the country. But can you explain why Lao PDR is growing so much?
I think, well, most of these areas, wherever there was, I mean, Laos has like quite low opium cultivation at this stage than it used to be before. But I guess it still has to do with that in most of the areas where you have cultivation and production of opium, or even for cultivation and production of cocaine, those are areas that are like in general, that are are less within the control of the governments, but kind of like troubled areas where there is kind of more of a the rule of law is in general absent. So those areas tend to be the places where you see most of that cultivation happening, and that could also try hold true for Laos, where the production is happening in places that may not be really within the control of the government forces, and some tribal groups might be involved, or they may have linkages with the cultivation groups in some of the states in Myanmar.
Mm. Okay, thank you very much. And now a question from the audience here. Does the legislation of cannabis in countries have an impact on the increase in prevalence on the cannabis use?
Yeah, that's very okay. Yes, in nearly all the jurisdictions, as well as globally, because of the lowering perception of harm from cannabis use, there is an increase in cannabis use, and the prevalence of cannabis use, as well as more frequent daily cannabis use among young adults. Um, um, and what we see is that, for now, at least in most of those jurisdictions, you don't see that kind of corresponding high increase in cannabis use among adolescents. But having said that, if you look at the prevalence of cannabis use among the successive cohorts of adolescents, it still remains very high. So it may not be increasing, but still is at very high levels compared to those places that have not legalized cannabis. So but if you look at the general population, especially the young adults, there's definitely an increase and more regular and frequent use, nearly daily use of cannabis, with the associated, cannabis use disorders that you see in different parts.
And to follow up that, because the gender gap when it comes to most of the drugs are quite big, and even so when it comes to cannabis. But do you think when it was prescription drugs, it was more similar between men and women? Do you think the gap when it comes to cannabis will decrease when
Yes.
it's legalized?
I mean, yeah, exactly. I mean, also, if you look at, for instance, in North America, the gender gap between the use in the use of cannabis is quite narrowing. So that's definitely there. And one of the issues that you see, for instance, is in the US, for instance, is cannabis use among pregnant women with its own associated problems that is being observed. Also because I mean, not the physicians, but they get the information that using cannabis can help with the nausea that usually is associated with the first trimester of pregnancy. So some people may suggest, if you use cannabis, it can help deal with nausea and vomiting for the earlier periods of the pregnancy. And you see lots of pregnant women on the advices of whosoever are using cannabis even during pregnancy.
Then we have a question on ketamine. Do you expect an audit on ketamine like the other substances?
Yeah, there have been quite a few assessments of ketamine, but the issue remains that it is in many parts of low and low income countries, especially where ketamine appears to be one of the safest anesthetic substance available that can be used as an anesthesia for children. So there have been those concerns that if ketamine is put under control, the same as with morphine, the accessibility will become so low that in places where ketamine is the only anesthetic available, population would not even have access to that. So that has been one of the driving concerns for not putting ketamine under international control. Also, it's also driven by the clinical trials that are happening on use of ketamine for treatment of different mental health disorders as well as substance use disorders.
Thank you. I think we are running out of time, but there is still one question, and that is, what are the negative effects of the dark web and deep web on young people, and how much has it increased the prevalence of use? How can we protect young people from the dark, deep web? And I can also include this big alcohol, big tobacco, and the big marijuana businesses in it. Is there a way for civil society, because I do believe that most of the people following this session comes from civil society or academia. How can we work in the future? Have you any ideas that you can give us? Thank you.
Yeah, I mean, see, it's the uncontrolled access to the internet. So, I mean, parents may not really be aware of, how much and what their children are browsing. But more than the dark web, I think the main issue or main concern from my perspective is because not all young people may be looking into the dark web because it requires a bit of a more technological understanding, but it's the social media and mostly the gaming platforms. There are chat functions in many of the gaming platforms where you can have. There are issues of grooming of children by pedophiles in those gaming platforms. There are sales of drugs and all those things. So I guess one of the issue is the awareness, working with the civil society, working with parents and community groups in promoting that there should be, parental control and access of what the children and young people and how they are accessing the social media, how they're using social media. Um, I mean, as there's been questions being raised that should people younger than 18 be allowed to have social media accounts, for instance, you know? So those are the kind of things that are being, questioned at the moment. And I think this is what we need to look at, how we can manage and control that access to the internet for good purposes and somehow prevent the misuse of, and control, what kind of like games the children are playing about and how they are interacting on the various social media platforms. So it comes down to that, working with parents and, somehow addressing that issue of, of parental controls, you know.
So in the end, you are coming back to the importance of the parents taking control of
Yeah.
the life.
Prevention. Prevention.
Yeah, prevention is the key word there.
Yeah.
Dr. Kamran, thank you very, very much for this very interesting and lecture, I must say. And when you have gone through the World Drug Report, we are looking forward for the next one and hopefully the increase of the civil society impact during the Commission of the Narcotic Drugs in Vienna. Thank you, and good luck to all of you in Istanbul and around the world who are watching this. And now back to the organizers.
Thank you very much. Yeah. Thank you very much. Yeah.
Dr. Kamran Niaz and the Esbjørn Hormark, thank you so much for joining us, and thank you so much for sharing your professional insights regarding the most pressing issues that almost the whole countries in the world have currently been suffering from. It was really great to hear from you. And now it's time for a 15-minute break. Right after break, we'll continue with the first session of the Congress. Hope to see you again in 15 minutes.
So we are going to start the first session of our Congress. The focus of our session will be about prevention, intervention, and advocacy activities of the substance abuse. And our session chair will be Professor Dr. Murat Şentürk from Istanbul University, faculty member, Deputy Secretary General of Green Crescent and the chairman of scientific committee, and we are going to have speakers, valuable speakers. International Commissioner of Recto Hombre Association and coordinator of the declaration, Dr. Oriol Escolies, Global Initiative for the Prevention of Drug Abuse, and this ASL 270's Department of Mental Health and Addiction, Dr. Raquel Donini, and Sakarya University lecturer Abdullah Uçar, and Academy Director of the Green Crescent Society, Mr. Hakan Çetin. We would like to welcome our esteemed session chairs and our three distinguished speakers. In our session, which will last approximately 75 minutes, Dr. Oriol Escolies will be talking about Oviedo Declaration of the Global Initiative on Drug Abuse Prevention, and esteemed Dr. Raquel Donini will be with us with her speech titled Prevention is a Science and the Importance of Advocate Evidence-Based Prevention. And Dr. Abdullah Uçar and Hakan Çetin will be with us about the speech, The Importance of Prevention in Public Health and the Role of the Turkish Green Crescent Society. Now I would like to give floor to Professor Dr. Murat Şentürk to conduct the session. Thank you very much. Hello. Today, we are here for the International Congress on Psychoactive Substance Use Disorders, and this will be the first session, and we are going to have three esteemed speakers. First of all, we are going to have the first speaker, Dr. Oriol Escolies, and he is going to talk about the Oviedo Declaration. And I will, before moving to the presentation, I would like to make a brief introduction. Psychologist Dr. Oriol Escolies. He has been working in Spain for the last 28 years for prevention, rehabilitation, and social integration for drug abuse addiction, and also working in the association in Proyecto Hambre. Dr. Esculias is also working with various associations, unions, and also the commission member of the society, and also the member of the NGOs. Generally, in terms of prevention, once again, there is the Oviedo Declaration and also coordinating this Oviedo Declaration. Now we are going to list. Actually, he won't be able to be with us, and there will be a video recording. Now I would like to give floor to him, Dr. Oriol Ascules.
Good day. Thank you so much for this opportunity to present at this very important conference organized by Turkish Green Crescent Society. Greetings also to all the Yesilay or Green Crescent chapters. I'm speaking from my hometown, Barcelona, Spain, representing the Association Proyecto Hombre. Today I will speak on behalf and as coordinator of the global task force of this global initiative on drug use prevention called the Declaration of Oviedo. I will present the scope and the developments of this mobilization, and then the 10 proposals of this declaration. Let me share my screen. This is a picture that we took in March at the United Nations Commission on Narcotic Drugs, where we launched this declaration that it officially started January 1st this year. It's called Oviedo because it stems from an in-person consultation of international experts on drug use prevention that we held in the city of Oviedo last year in Spain, and we are also undertaking a very important longitudinal assessment of a school and family-based prevention program called Juego de Llaves. That means key set in English, by Proyecto Hombre, that we are implementing in many primary and secondary schools with the collaboration of the government of Spain, UNODC, and Oviedo University. That's why we held this meeting there to discuss about how to scale up evidence-based prevention in drug policy. Then we started to draft the Declaration of Oviedo with more than 200 experts collaborating. It had to be a concise text, but also understandable by all stakeholders and acceptable as well by all cultures from all regions across the world. Then we set up a global task force, which is an international committee responsible for coordinating at international and regional level by very great experts on prevention, but also leaders regionally represented. This is probably one of the main strengths of this action, what we call country focal points. More than 160 already, more are coming. Reliable organizations working on the ground, responsible for giving insights about the specific needs of the populations and from their countries, and also promoting the messages and the proposals of this declaration within their countries. You see from many countries. Also from Turkey, we have, of course, two great representatives from Turkish Green Crescent Society. A very good asset as well. We decided to translate as much as we can this text to the languages people speak. We started with the 6 UN languages, then many others, also Turkish, as you can see. Now we are translating into minority languages, indigenous languages too. This is an up-to-date picture. Already 2,580 supporting organizations in more than 150 countries. You can see in green, roughly 35% belong to Africa, 25 America, 20 Asia Pacific, 20 Europe. It's not only, but basically civil society organizations, but increasingly academia, universities, community-based organizations, and also governments. If you want more information, we have a website, oviedodeclaration.org. Okay, there are also observers like Spain, the government, UNODC, Council of Europe, 2 universities from Spain, and the Vienna NGO Committee on Drugs. At the website, and also we have a QR code on the right, you see. You can view the list of supporting organizations by countries, sign the declaration. We really need more organizations from Turkish and of course all over the world. It is so essential to count on you just 10-20 seconds to sign the website of videodeclaration.org. You will find further information about the country focal points, and if you are interested in downloading the declaration in your languages, so you can also find it there. We are now promoting over the last month at international level, UN bodies, forests, also regionally. This is an example. We are organizing what we call hearings on drug use prevention by continents. Some of you have already participated. Also nationwide and locally, hundreds of activities, most of them undertaken by the focal points. These are just few examples: Nigeria, Bangladesh, Pakistan, Portugal, Ecuador, Colombia, India, Brazil, and the last one is Spain, my president, presenting the Declaration of Oviedo at the Spanish Parliament. And then I'm going to focus on the 10 proposals. This is the first one: no more words but facts. Call for countries to dedicate at least 25% of their drug demand reduction strategy and policy budget on prevention by 2030. Considering existing evidence on effective and cost-effective prevention, we urge countries to achieve a national consensus by 2030, committing to allocate and sustain at least a quarter of the total demand policy budget to drug prevention. Furthermore, we reiterate that policies should be proportionally balanced between drug demand and drug supply reduction measures. Secondly, promote an approach to prevention targeting all ages of development and favoring early prevention. Prevention should start as early as possible and consider the periods starting from pregnancy, neonatal, childhood, and adolescence by identifying priority family, school, and community intervention areas, and continuing in adulthood. Effective prevention focuses on strengthening protective factors and empowering individuals throughout their lives on personal, emotional, and social levels. Third, foster research and evaluation to avoid ineffective or counterproductive prevention strategies. Prevention is a science. As such, formulating and implementing prevention policies should incorporate evidence-based, data-driven interventions and systematic assessment mechanisms guided by international standards in a strong collaboration with academia and civil society organizations. This approach is essential to refrain from drug policies based on misperceptions and misbeliefs. Furthermore, investing in research transferability is of high importance to ensure the implementation of effective prevention in different social, economical, political, and cultural contexts. Fourth, broaden the vision of prevention responses to shift the focus from drugs to the individual and the community. By focusing on the person rather than drugs, prevention strategies take into consideration vulnerabilities at the individual level and the potential protective effect of the social structures and the legislative framework surrounding the person. This approach prevents not only the use of illicit drugs, but all drugs in general, including tobacco, alcohol, cannabis, prescription drugs, or new synthetic substances that are highly prevalent. This would also encompass prevention of non-substance addictions, such as gambling and digital gaming disorder. Fifth, mainstream intersectional approaches in prevention for all populations at risk. The impact of drugs is inequitable and highly dependent on social determinants of health that are influenced by several factors, including identities related to gender, ethnicity, age, sexual orientation, and location of residence, among others. Therefore, prevention strategies must incorporate a holistic intersectional approach addressing different vulnerabilities to allow for the cover and prioritize to allow for the establishment of more equitable and fair policies. Prevention services should make all efforts to cover and prioritize the most excluded and stigmatized groups. Sixth, boost multi-stakeholder prevention systems and documenting effectiveness and cost-effectiveness when implemented globally. Systems of prevention should bring together diverse measures and coordinate efforts from multiple governmental, non-governmental, and community-based sectors to provide services at scale for children, youth, and at different ages of development. Countries should benefit from available prevention systems at national and local levels when aligned them to international scientific standards. Therefore, more should be invested to replicate prevention models that have proven their effectiveness and cost-effectiveness at the international level. Seventh, provide universal coverage in a continuum of care. In line with a public health approach, countries should provide drug prevention that is accessible and affordable for all individuals everywhere, globally and locally, and intertwined with the provision of health promotion, early detection and intervention, harm reduction, addiction treatment, recovery, and social integration in a logic of a continuum of care. Eighth, prioritize action in low and middle income countries. In low and middle income countries and regions experiencing humanitarian crisis, basic social and health care infrastructure may be lacking. In this context, investing in prevention should be a key priority. Ninth, empower current and future generations of prevention professionals, recognizing here the key role of professionals in implementing effective prevention. We urge the educational community to incorporate the science of prevention of risk behaviors in core and compulsory curriculum of health education and social science teaching. We also stress the need to provide certification processes and continuous training for prevention practitioners throughout their working careers and ensuring supporting conditions to avoid burnout. And finally, 10th, monitor the status of prevention policies through accountable surveillance. We invite countries, the Commission on Narcotic Drugs, the United Nations Office on Drugs and Crime, the World Health Organization, and related organizations to adequately assess the coverage, relevance, implementation, investment, and effectiveness of drug prevention policies in their jurisdiction throughout ongoing surveillance and data reporting systems of international, national, and local monitoring drug reports. Well, I know the time is very limited, so I just wanted to share with you the current situation of this global initiative that we really want to stress for scaling up and incorporating science-based prevention in drug policies at all levels by also these 10 guiding proposals that might be useful for stakeholders, policymakers, and civil society organizations to
live now.
Evet, Oviedo Deklarasyonu için Oriol
I would like to
Asculas
thank Oriol Asculas for the Oviedo Declaration and for his presentation. The global initiatives are highly important for prevention of the addictions, and we have listened to him talking to us about the importance of the networks and the connections. I would like to underline this once more. The prevention activities of the countries must have an agreement with respect to prevention activities, and their activities should be supported by all. Before moving to our next speaker, I would like to remind you that you can ask your questions through the chat section. We will have a Q&A part at the end of the session. It will take 15 minutes, and if you have any questions or any comments with respect to the presentations delivered, please make sure that you ask them in the chat section. The next speaker is Raquel Tonini from Italy, and she will talk to us about the prevention as a science and the importance to advocate for evidence-based prevention. I would like to introduce her. She is a psychologist and psychotherapist, and since 1995, she has been working in the Department of Mental Health and Addictions, and she has vast experience in the clinic area. And in the last 16 years, she has worked in various European projects to improve advocacy, and she is a member of the Prevention Council curriculum of EMCODA, and she was rewarded as the leader practitioner, and since 2001 she has been providing trainings for developing prevention courses. She is a very valuable scientist, and we would like to extend our gratitude to her for being here with us, and the floor is yours.
Thank you very much, Murat. I'm so honored to be invited by the Green Crescent Society. So thank you very much, and good morning, good afternoon, and good evening to all the people attending the conference. And because it is an international conference, there are different time zones. So welcome, everybody. Yes, I will be speaking about prevention as a science. And thank you also to Orio for his presentation, because many things that are listed in the Declaration of Oviedo, you will also find in my presentation. And here I'm speaking about the importance of advocacy, and the Declaration of Oviedo, of course, is a declaration. It is an advocacy action towards all the states in the world, across the world. And it also underlines the importance to shift the focus on individual and community and not on drugs. And this is also something I am going to speak about. So, prevention is a science, and the importance to advocate for evidence-based prevention. So, my presentation will try to explain why prevention is a science, what is the focus of this science, and the importance to advocate for evidence-based prevention. Then I'll dedicate a few moments to the conclusions for some takeaway messages. So why is prevention a science? Of course, not a hard science. According to what we see here, it's not, of course, about hard sciences, but it is about psychosocial sciences. So it is a science because it identifies the determinants of substance use behaviors and identifies the risk and protective factors. It refers to theories on human behavior. It has its own language. It offers specific approaches, and it is based on evidence of effectiveness. So the determinants of substance use behaviors, here I rely on the etiology model presented by the United Nations Office on Drugs and Crime. And here we see which are the main determinants of human behavior. It is an interaction of different aspects. As you can see at the center, we have the personal characteristics that are made of genetics, of the temperament of each individual, of his or her physiology. And these personal aspects and characteristics interact with the micro and macro level environment. So as the micro, we consider families, for example, where the individual is born and grows up, the school, the workplace, the peer group. So these are the micro level environments that shape the behavior of the individual. And also the macro level that comprises the micro level environments. And as macro level, we consider the culture where we live in, the society, the media. So all these aspects interact with the personal characteristics and, of course, exit in different beliefs, attitude, and behaviors. But here, the focus is on the fact that it is not just about the individual, it is about the environment, the individual, and the interaction between the individual and the environment. And to remain on the substance use behavior, here is the pathway that shows how the individual can get and can have this behavior of substance use. As you can see, at the beginning, at the initiation of substance use, the personal characteristics are there, but are not as important as the environmental factors. The environmental factors are the most influential factors at the beginning. So it depends on the family where the individual was raised. It depends on the peers that are around. It depends on the school. It depends on the environment. So the personal characteristics, of course, have an important decision-making factor, but it's not the only one. The environmental factors are even more important. So one person can start using substances and may not have the need to keep on using. It might discontinue the use. If the person decides to continue use, at that point, the personal characteristics become more evident and more important because it is the interaction between the pharmacological factor given by the substance and the personal characteristics that might in some way make it more interesting for that individual to keep on continuing use. At that point, the environmental factors are still important, but as you can see, less than the personal characteristics. Continuing use can have no problems, but if the use keeps on going, it can produce problems at different levels, health problems, emotional and psychological problems, and social problems. At that point, when these problems start to develop, what we see is that the main factor is not the personal characteristics anymore. It is the pharmacological factors. So it's the typical and specific ingredient of the substance that the person is using that makes the difference. So for some reason, maybe the use of MDMA, for example, might have brought the person to experiment an easier way to get in contact with others. So because of, for example, a person being shy, he or she found out that using MDMA was making his life easier. He was able to approach people with not so much stress. So the use of substance in some way becomes a way to live better from his perspective. And that's why the use is continued. But of course, after a long time or a short time, health, emotional, social problems start to develop. Another reason why we talk and think about prevention as a science is because we have theories on human behaviors. We know theories are important because in some way they simplify complex problems, complex phenomena, as substance use is a very complex phenomenon. So the way how we approach the phenomenon is made easier according to theories. And theories, in this case, are especially theories, psychosocial theories. So, for example, we have the social learning theory from Bandura, or the problem behavior theory from Gesor, or the human development theory from Bronfenbrenner, or the agents theory of planet behavior. So we have theories that explain why an individual has a specific behavior. And these theories in some way can help us to understand the behavior of people, and they help us also to intervene with the right intervention. And going on, sorry, okay. Can you still see my presentation? Can you see my presentation?
Yes.
Okay,
Yes.
thank you. So to go on, we have theories, but we also have specific approaches. These are the BCT, behavior change techniques, that are used to address substance use. According to the European Drug Agency, these are the 6 different techniques that can be used in prevention interventions. So environmental restructuring, norm setting, education, training, offering incentives, information. And here on the side, you see the evidence and how these interventions can be effective. So we have a good evidence for environmental restructuring and norm setting. These show to work. There's an unclear evidence about education, training, and provision of incentives. We have no evidence about information. This is very important. So offering only information shows to not be effective. Sometimes it can be harmful. Prevention has its own language. So we speak about, for example, universal, selective, or indicated prevention, depending and according to the target we are addressing. So universal, we are addressing the full population without any distinction if there are people that have already used the drugs in that population or not. Selective, we are addressing vulnerable groups, vulnerable because maybe they are children of people that are already using substances, or because they live in environments that are poor environments. Indicated prevention, which is addressing vulnerable individuals. So these are a few words about prevention, best practice, vulnerability matrix, prevention systems. We've heard from the Declaration of Oviedo the importance of prevention system, and so on, and evidence-based. What do we mean with evidence-based? Why do we speak about evidence-based prevention? This means that an intervention or a policy is evidence-based because it has been tested and evaluated through the scientific method. So with different evaluation designs that have shown positive effects on relevant outcomes. That at that point we can speak about based on evidence. And the evidence that we rely on are the international standards on drug use prevention from the first edition, 2013, and the update, 2018. Then we have the European Drug Prevention Quality Standards from the European Drug Agency, and the European Prevention Curriculum, which is the finding and the result of a European project that has been taken and revised by the EUDA, the European Drug Agency. So what does the international standards tell us about what works and what does not work about prevention? Here in this table, you can see the importance of addressing interventions according to the different developmental stages. You can see on the higher row, prenatal and infancy, early childhood, middle childhood, early adolescence, adolescence, and adulthood. This shows the importance to target our interventions, taking into account the specific tasks of each developmental stage. And on the side, the different settings, family, school, community, workplace, and health sector. And in the green boxes, the interventions that are universal interventions, in the yellow, the selective interventions, in the red, the indicated prevention. As you can see, for each stage, we have different interventions that show to be effective. For example, you can see that parenting skills, so empowering skills to be a good parent, shows to be very effective if addressed to parents that have children in middle childhood and early adolescence. For adolescents, for example, very effective is to have alcohol and tobacco policies in place. That's also very effective for adolescence and adulthood. Also mentoring, which is a selective intervention, shows to be effective in adolescence. And I don't have that much time to explain this table, but I really encourage you to take this table into account, because it's also very interesting if you need to take any advocacy action to show policymakers what works. In this table, you have an overview of what works. This is the updated table from the UNODC that shows new evidence has been accumulated along the years, and we see that also school policies and policies to retain students at school shows to be very protective towards developing substance use in adolescence. Addressing mental health disorders also shows to be very effective. Interventions for pregnant women, this is also very important and protective against developing for the newborn substance use disorders in adolescence. And these are the European standards. These standards, and this is the project cycle, shows the different steps that should be undertaken to plan a prevention intervention. As you can see, we have 8 steps. These steps have been identified through a consultation with many people across Europe and with a systematic review of literature. So these are the main aspects that we have to take into account when we want to plan or to evaluate a prevention intervention. So the focus of prevention, as we have seen from the international standards, is on the development of the individual. And it is about restructuring the environment to make environments where it's easier to make healthier decisions. And it is about the relationship between the individual and the environment. And as also Oriel in the Declaration of Oviedo has said, it is not about the substance. The focus is on the development of the individual and on the environment where the individual lives, because sometimes it's not always a free choice that leads to using drugs. Sometimes it's also the environment where the individual grows, which is an environment that in some way pushes to use substances. So we need to intervene on the individual, but also on the environment and on the relationship. So this is why we have to address our interventions to the specific target group that has a specific task, developmental task. This means that one intervention can't fit all. One size does not fit all in this case. And we need to restructure the environment. Remember the etiology model, the attitudes, beliefs, and behaviors are the intersection and the result of the personal characteristic with what happens in the environment. And this is also the relationship between the individual and the environment. Recall the pathway to substance use. We've seen how the use and discontinued use or continuity of use depends, first of all, from the environmental factors, then on the personal characteristics, and then, but for the last, on the pharmacological factor. So the focus of prevention is on sustaining and supporting personal and societal growth. For this reason, the importance to advocate for evidence-based prevention. Why is it important? And first of all, what do we mean by advocacy? Pelosa explains advocacy as a political process by an individual or a group which aims to influence public policy and resource allocation decisions within political and social systems and institutes. So it can be an individual action, or mainly it is a group action. And why do we want to advocate for evidence-based prevention? Because we want to influence policy and decision-making processes, because we would like these processes to be addressed on those interventions that show to work. So we need to emphasize and to bring in, to show the importance to take decisions and to allocate resources on what shows to be effective. This is why we need to advocate for evidence-based prevention. We need to increase the visibility and recognition of evidence-based prevention, to forge stronger relationships with policy and decision makers, and to allocate resources to what is effective, to dismiss interventions that show to be ineffective or iatrogenic. So these are my takeaway messages. Prevention is a science. We've seen why. And mainly because it is evidence-based. It benefits individuals and societies. And as also in the Declaration of Oviedo, it requires a professionalized workforce. So we need people that are trained on prevention interventions and policies. And it needs to be disseminated among decision, opinion, and policymakers in order to allocate resources and make better decisions according to what shows to work. And thank you very much.
Teşekkür ediyoruz Raquel Donini'ye.
Thank you, Raquel, for this great presentation. First of all, we understand that prevention is actually highly important and it has to be central to our activities. And thank you very much for handling the subject from a scientific perspective, and also your emphasis on restructuring the environment and carrying out the prevention activities with a scientific basis is highly important. We also understand that mentoring is also highly important, especially for the youngsters, and you have also shown us with an example. Another subject that I would like to underline is the indispensable connection between prevention and the relevant interventions. We have several questions for Raquel, but I would like to listen to the next presentation and then we will move to the questions part. I would like to give the floor to two important researchers and academics from Turkey for the last presentation, Dr. Abdullah Uçar and Hakan Çetin, and they will talk to us about the prevention in public health and the role of Turkish Green Crescent. I would like to introduce them. Dr. Abdullah Uçar was graduated from Istanbul University and then he held his PhD degree in the public health. And since 2001, he has been a lecturer at the Department of Public Health at Sakarya University. His academic studies are on planning human resource in healthcare, spatial epidemiology, epidemic modeling, and he was involved in the project of Turkey COVID-19 pandemic monitoring window, and he is also engaged with Turkish Green Crescent and acts an advisor. He's also very active in many NGOs. And I would like to introduce Hakan Çetin as well. He is a specialist psychologist and consultant at Marmara University Department of Psychological Counseling. He completed the university education in 2003 and then he had his master's degree in Istanbul University and he is now in his dissertation stage at the PhD degree at Ege University. As for his scientific studies, cognitive behavioral therapy, EMDR therapy, Gestalt therapy, multifaceted leadership training. So he has received trainings in different areas, also addiction, human behavior, teaching techniques, traumas are among the areas he studies, and he has works with Erenköy Mental Institution, various public schools, and he acted as a psychologist and advisor in many different institutions and organizations, and he's also an academic member of the Scientific Council at Turkish Green Crescent, and he is a planner and organizer many different events, so he contributes to the area. Without further ado, I would like to give the floor to Abdullah Uçar for his presentation.
Thank you for your nice and kind introduction, Mr. Şentürk. Hello, everyone. Hello, ladies and gentlemen. It's an honor to be here with you today with the distinguished speakers, and it's an honor to be here with this horizon broadening presentations. And Mr. Çetin and me will talk on the prevention and the Green Crescent's efforts. So let me start with my presentation. Yes, here I'm sharing. Do you see my presentation?
Yes.
Is it visible for you? Okay.
Yeah.
Okay, thank you. Yeah, my topic is the context of the prevention in addiction from the public health perspective. As Ms. Donini emphasized the science dimension of the prevention, I will talk on the context of the prevention. What is prevention? What its importance? Why it's important for us? In the first, we have these questions. What is health? And what is the social determinants of health? As the Donini mentioned about the determinants of the prevention, we have a concept, social determinants of health. And the second question, what health issues are important? What is the determinant of this importance? Is addiction a major problem, for example? What is prevention and its stages? And what do we have and what do we need? As you know, in 1948, WHO defined the health concept as physical, mental, and social well-being. And we know health is not just the absence of disease. And the social determinants of health teach us the health is not just related to the professional health care services. It is related with this network of determinants. And in 1991, two researchers, Dahlgren and Whitehead, defined these concepts, and they categorized these five-stage figure. At the center it is not social determinant, the age, sex, and genetics, the biological determinant, in fact, but at second level, individual lifestyle factors. After that, social and community networks, and the agriculture, food safety, education level, workplace environment, unemployment status, water sanitation, and the healthcare services and housing. And at the global level, general socioeconomic, cultural, and environmental conditions are determining our health. And according to the CDC's work at the US, the healthcare services contributes to our health approximately 20%. The 80% of our health is coming from these determinants. So is substance and alcohol abuse, I will say it SAA, a really significant problem? What is the important problem? Which health problems are important? According to the public health approach, if an health situation, a health issue is most common, most killing, most disabling, or most causing labor loss, the diseases are important diseases for us. And when we look at the SAA, it accounts for 6.5% of the global burden of disease and causes 5 million deaths per year. As you know, the total deaths of the COVID-19 for 2 years was 7 million deaths. And this problem, this issue, results in 5 million deaths per year. Its effect is similar to the COVID-19 effect. Worldwide, 3 million deaths every year result from the harmful use of alcohol, and this represents the 5.3% of all deaths. And as we know, the percentage of alcohol attributable deaths among men amounts to 7.7 and of all global deaths compared to the 2.6% of all deaths among women. And let's look at the economic dimension. This is an important note coming from the SAMHSA, the Department of the U.S. Health System is reporting this. According to the study of this U.S. Department of Health, the annual cost of the SAA, substance and alcohol use, to the U.S. economy in 1999 is $510 billion. It, as I calculated, it equals to 5.3% of the GDP. It is a huge amount of economy, as you know. In Turkey, our expenditure on the health system at all is the 4.5% of the GDP. The US is spending the 5.3% of the GDP just to alcohol and substance use, abuse. Among three most costly diseases in the US, alcohol ranks second, tobacco use is sixth, and substance abuse is seventh. The cost-benefit ratio, this is so important, the cost-benefit ratio of the effective programs in substance and alcohol use, according to the public health economy, it is the ratio is 1 to 18. It is so cost-effective, as you see here. For example, in general, at the health systems, the most cost-benefit ratios are in the vaccination file. About vaccines, the cost-benefit ratio reaches to 1 to 34, for example. 1 to 34 at vaccination file. And this file is 1 to 18. There's so huge cost-benefit ratios. And I want to talk on prevention levels. Generally, we know primary prevention, secondary prevention, tertiary prevention, but let me to explain a little bit about these concepts. Primary prevention is a level at prevention levels. It means there's no problem yet, but individuals at risk. At this stage, we have to take action against determinants, especially in risk factors of the problem. For example, I'd rather to use immunization concept. Immunization associated against infection disease. As in infection disease, we need to immunize the community about the with education about the alcohol and substance use. If we failed in primary prevention, people will get sick or they will be addicted, for example. So what will we do? The second preventions. In second prevention, people who have disease, but disability or medical complications, addictions, there's no addictions yet. There's no complications here. So we have to take action against disabilities and complications due to disease. For example, screening programs, mammography, etc. Mammography screening, etc. And the third level, tertiary prevention. Here, there are people who have disabilities and complications. So we have to take actions to slow or stop the progression of the disabilities and complications, rehabilitate the medical and social effects, rehabilitate the addicts. Chemotherapy, rehabilitation, screening for complications, not screening for just the diseases, screening for complications at this stage. And we have two extra concepts, primordial prevention and quaternary prevention. Primordial prevention means to reduce the amount of the risk factors, to battle with risk factors. For example, for cardiovascular health, hypertension is a risk factor, but the salt use in community is the cause of the hypertension. So if you battle with the salt use in community, it's a primordial prevention. In the concept of addictions, for example, banning advertisements of addictive substances in media or giving a student the ability to say no to peer pressure. This is primordial prevention. Quaternary prevention is so important also. This is the protection of the patient from over-medication. When we are trying to educate people or advocating, we are trying to advocate the efforts about these addictions, maybe we can give harm to community. It is so important not to harm. Not explaining it's an example, not explaining the pleasurable or stimulating aspects of substances in the addiction prevention education program is an quaternary prevention example. Here, what we have and what we need. As I tried to summarize here, we have a good, we have a strong institution in Turkey, the Turkish Green Crescent. But we need more support at international and national level to enhance capacity. and promote social marketing. Social marketing is a concept defined in 1970s. It means to market not just the tradable goods. It means to market the ideas, to the behaviors. And we have well-studied global scientific literature. Yes, this topic is so studied. And what we need is we need research that reveal the dynamics specific to each local community. It means precision public health, individualized or personalized public health. And we have well-structured training materials. But we need crowdsourced content and mass education digital tools because the dimension of the problem is widening exponentially. It is hard for us to race with this exponential growth. We need crowdsourcing. We need people to produce contents about advocating. We have wide range volunteers across Turkey, but we need to expand volunteer network around the world. And we have worldwide emerging AI technologies, as you know. It is so popular now. So if we use the AI, we need to train the machine rapidly to prepare it to fight addiction. It's a so useful tool for us. In the efforts of the Turkish Green Crescent is focused on especially to primordial and primary prevention levels. So in this point, I will give the microphone to my colleague, Mr. Çetin. Thank you for your attention until here.
Teşekkür ederim Abdullah Hocam.
Ben
Thank
teşekkür
you,
ederim.
my dear colleague, Mr. Abdullah.
Önceki konuşmacıların aslında olgunlaştırdığı bir
Actually,
konuyu devam ettireceğim.
this topic is matured with the previous presenters. Now, I would like to talk about prevention activities carried out by Turkish Green Crescent Society. Before talking about those, I would like to highlight something. So, the previous speakers always highlighted evidence-based content, the importance of developing such context, evidence-based activities, and then supporting them, supporting advocacy, including environmental factors. So they all talk about ecological, holistic model, and they highlighted the importance of that. And Turkish Green Crescent prepares programs, context, and of course they are all related to worldwide global literature. They are all examined and they are all evidence-based. So of course they are trying to be much more wide and disseminated. After this explanation, I'm going to talk about the primary, secondary, tertiary preventions, which are already applied by the societies. There could be different activities, training events, competitions, etc. Now I'm going to share my presentation.
Paylaşabildim sanıyorum.
Can you see my slides?
Evet hocam, görüyoruz.
As we can see.
Ekran yaparsanız hocam.
Full screen, please.
Tamam. Şu anda yansımış olması
Now
lazım.
you
Evet
are
hocam, buyurun.
going to see it as full screen. All right then.
Aslında Abdullah Hoca'nın da vurguladığı
As
üzere
my colleague Mr. Abdullah
birinci
mentioned,
önleme, ikinci önleme,
first,
üçüncü
there are
önleme
different
perspektifleri var.
levels. Primary,
Bunlar
secondary, tertiary prevention for addiction. And of course, these are all depending on the development of the levels of addiction. So they are presented to the users. Of course, Green Crescent have different training programs for addiction prevention. Of course, first of all, there are some groups, for example, students are focused who have not initiated any addiction substance. For example, first of all, we have addiction prevention training program, school-based. And of course, according to the and development of those individuals, according to the level, of course, the content will be at the level and there will be interaction. This is a kind of program. And of course, this is not only about awareness raising. This will not be sufficient. For this reason, of course, before being an addict and before having an addiction, we would like to increase their resilience. That's why we have also life skills training program. And this is at the level of secondary school students. So there are research, so we pay attention to such research. What kind of life skills will be for which age group? So we pay attention to that, we identify that, and we implement life skill training program. And this is the primary prevention for non-users. However, as we all know, in the education system, some of the students have some addictions related to tobacco, drug, etc. So they try them. Actually, they do not have the risk factors already, but they are at the level of using. However, they are going to be addicted in the future. So we would like to prevent those users not to be addicted. So we call it school-based intervention program. This is a short secondary prevention for users. So we have individual interviews. We are talking about a short-term intervention, and we are trying to do those. We are trying to prevent those users not to be addicts. And of course, psychosocial support service is also given in our counseling centers, YEDAM. So in these Green Crescent counseling centers, they are receiving psychosocial support in the tertiary prevention program. Now, I would like to elaborate more on this slide. In Turkey, there is a program which is Turkey's most widespread and comprehensive addiction prevention program. It is a very effective trained educational program. And for 10 years, it has been implemented together with the Ministry of National Education. Of course, there are different cooperation, and this is implemented in all schools, so it is widespread, and we contact to those students. We're talking about nearly 10 million students we have reached so far within the scope of this program. So this is a very significant, widespread program. As I mentioned, for addiction prevention program, there are various modules. For example, healthy living, technology, tobacco, gambling, alcohol, drug addiction. They are all included. And according to the age level, of course, there are different categories. And which age group, especially for Turkey, which age group is going to be critical? Then we would like to initiate the planning beforehand, and this is the modular system for that. And therefore, for all the addictions, we would like to raise awareness for children, for adolescents. As I've stated, this is school-based prevention program. Together with the Ministry of National Education, within the curriculum, it is integrated. And the accreditation is obtained in Turkey, and it is going to be disseminated more. Of course, it is evidence-based, standard, and of course, this will not traumatize the children. When you check the scope, there is no factors which are going to be interesting or attracting attention for addiction. Of course, we're talking about volunteers, a very crowded group of volunteers, trainers, together with the Ministry of National Education, together with the NGOs. We have cooperation, so we have a very wide trainer pool for this. And after providing training for those trainers, then they go back to their own institutions and they try to disseminate them in their own institutions. So this is the dissemination model that we are able to reach them. Of course, as I've stated, together with the Ministry of National Education, the Ministry of Youth and Sports, we are in cooperation together with various institutions. This is our website, and of course, there are various materials that can be followed, and we share them together with some of the users, implementers, parents, families, so they are able to access those content.
Materyalimizin örneğini gösteriyorum. Hikaye kitapları.
You can see the examples of some materials. We have the storybooks, videos, workbooks. In short, we have all the materials that are attractive to the children and to the youth. Also, this is important. It's a new project for us. We worked on accessibility, our entire website.
Tüm farklı gelişen bireylerle ilgili bir erişilebilir
was made accessible to the visually impaired and hearing impaired people, so they will not have any issues with respect to access, and this way we will be able to propagate the information to the disability groups as well. Within the scope of Zero project, we also made an application, and our project was shortlisted by them as of 2024. As said earlier, we have distant education in integration with the Ministry of National Education. The children can enter our website, play the games, and watch the videos. We are also now propagating abroad. We have translated our contents into Russian, Arabic, French, Serbian, Bosnian, and this way they are now being implemented across the world now. We have our effectiveness and efficiency analysis as well. We started a pilot study back in 2016, and then we had another analysis across Turkey to see the efficiency of our program, and we find that a positive change was observed in the level of knowledge and awareness in the group in which TBM was applied. As said earlier, raising awareness is not enough on its own. The former speakers also emphasized the skills. It is not enough to raise awareness of the people because there are still question marks whether or not they bring about the change. Therefore, life skills education program was put into practice. And this is a 7-week long program to train the elementary school kids with respect to life skills so that they could say no to addictions and they can emotionally regulate themselves. And we also conducted the efficiency analysis of this one, and both in short-term program and in the long-term program, we found a positive increase in saying no and also dealing with the addictions. I said earlier, we also have our school-based program for the kids who have tried these substances, and we are working with them to help them quit smoking or drinking. And so far, we have helped nearly 7,000 students. And also we supported many students in reducing their use. On the other hand, we're not only limited to the schools. Training programs were also conducted for the people in corporate companies. We know that there are risks for people to engage with drug abuse, and also we know some companies are having issues with online gambling. Therefore, we actually created some training programs for the businesses, and it might be a mining company or it might be a heavy industry company. And this way, we are trying to reach out to as many people as possible through different ways. We also have our school academy, family academy, and we created some contents for the families, and the families can receive such trainings along with their children or on their own. We created a guide and it was also translated into 4 languages. And we are now propagating that through the country Green Crescents. Emphasizing the risk factors about addictions is not enough. Positive alternatives should also be provided to the children, and they should be provided with the settings to improve their life skills. And we have our cartoon competitions. Also, we have Healthy Generation, Healthy Future competition. And we have different categories like the visuals, painting, poems.
Öte yandan 3 yıldır yürüttüğümüz ama geçmişimizde de Yeşilay'ın geçmişinde de bulunan bir
We
münazara
also have our discussion tournaments that we have been organizing for 3 years now. And instead of telling things to the high school students, we are actually helping them discuss different subjects like politics, women's rights, healthy life, addictions.
Türkiye'nin iyi okullarında okuyan, liselerinde
The
okuyan öğrenciler bu
students
tartışmaları gerçekleştiriyor. Bizim ev
join
sahibimiz
us from
ve 10.000'i aşkın
different high schools of Turkey, and every year more than 10,000 students are joining this tournament. And this way they are able to raise their awareness on addictions and they can propagate the information to their peers. And we are also providing the youngsters with a positive alternative.
bilimsel kongreye ev
And
sahipliği
also we are hosting different scientific congresses.
Kongresi adıyla 6.sını gerçekleştireceğiz.
We will have our 6th conference on technology addiction in 2025, and we have so far organized very different congresses, and we have brought together the scientific world. We also have our Addicta journal, in which articles on addiction are published. This journal also contains international articles, and the journal is published on different scientific areas, and it is actually improving day by day. We do not only organize trainings or different organizations, we also would like to support the scientists as well as master's and PhD degree students for their activities. So far, 103 students have been granted a scholarship, and their studies on addiction have been supported. These people are working on addiction, and this is a great benefit for us and for the community. So this is it. Thank you very much for your kind attention. Thank you, Hakan, and thank you, Abdullah Uçar, for your presentation.
Sorularla devam edeceğiz.
We will now
Birlikte
continue with our questions. We have received many different questions, but we have a limited time. Therefore, I will try to keep the Q&A part as short as possible. I will start with Raquel first. There are two questions for her, and I will ask her to answer the questions in 3 minutes. The first question is as follows.
2024 yılı itibariyle
As of
Almanya,
2024, Germany has legalized the sale of cannabis for recreational usage by adults, similar to Netherlands. So how do you evaluate this situation, and what kind of problems can the society face in the future? This is the first question.
bağımlılıkta bilime dayalı önleme yöntemlerinin toplum düzeyinde etkisini artırmak için bireysel farkındalığı güçlendirme
So you said,
konusunda hangi stratejilere öncelik?
which strategies should be prioritized in order to promote individual awareness, and how can the psychologists play an effective role in this process? The questions are for Raquel, and I'll ask her to answer the questions in 3 minutes, please.
Okay, thank you, Murat, and thank you for people asking this question. So about the first one, about the legalization of cannabis, it is a very complex issue. I would just say this, that whether a government decides to legalize or not cannabis, from my perspective as a prevention worker, I think it is important not just to legalize, but also to put in action prevention interventions about the use of cannabis. And this has to be done both if it is legalized or if it is not legalized. Of course, if it is legalized, we need to really take care of all the prevention issues, because as alcohol and tobacco, which are legalized substances, we need to really understand that these kind of consumptions have an impact on everyday life when we drive, when we study, when we interact with others. So we really need to put in place prevention actions, even if it is decided to legalize. I don't want to get engaged in the discussion now whether it's good or not. I want to really underline the importance to take prevention measures at an environmental level about prices, for example, about when, in the case it is legal to use, when it is not. So this is my answer to the first question. To the second, which strategies to prioritize for individual development. So we've heard from the Green Crescent Society the importance of life skills. Life skills development, a life skills program show to be most effective in developing the individual, not just to reinforce the individual against drugs, but to empower as a health promotion strategy, which I think is really important. And then we also have to bring attention also to the environment that surrounds the individual. And as a psychologist, of course, psychologists can help on an individual aspect, on an individual level, but also social psychologists, for example, can be employed to draft and to design also messages, for example, of media campaigns. Media campaigns sometimes, I think at Italy, for example, are not very well designed because they don't have a clear impact on the final recipients. We needed to build a workforce within the graphics, the people who design from a design point of view, the campaign, but also with the professionals that can offer their advice on how is the best way to address the message. Thank you.
Biz teşekkür ederiz. Çok kısa
Thank you for the answers.
doyurucu cevaplar için.
That was
Şimdi
a great answer.
Hoca'ya iki soru yöneltmek istiyorum.
And two questions for Abdullah.
Halk sağlığındaki yeri ve Türkiye'de bu
The
alandaki
place of tertiary prevention in public health and whether or not such activities are sufficient in Turkey. The second question is when you consider the burden of the disease, do you think the prevention works are sufficient? And what studies do you prioritize in this regard?
Teşekkür ederim. Müsaadenizle Türkçe cevaplamak istiyorum.
I would like to answer the question in Turkish if you allow me.
Kısmından İngilizceyi mi seçmeliyim acaba?
Evet.
Do I need to choose English for that? Yes.
Türkçe.
Sorry, you need to choose Turkish for that.
Teşekkür ederim.
Thank you very much for the questions. The first question was about the tertiary prevention activities. In the Ministry of Health, we have Amatem, Çematem, and also we have our organizations providing services to the people suffering from addictions, and we have qualified and trained workforce for that. However, carrying out tertiary prevention is not really cost effective because as far as we know, the treatment is not really possible in addiction. We know that only treatment is the prevention actually. Therefore, the tertiary prevention strategies should be supportive preventions. The Ministry of Health of Turkey is working hard for that, but it is needed to be positioned as a supportive activity. And the attention and the resources should be allocated to primary and secondary prevention. Can you please ask the second question again?
İkinci soru şöyleydi. Hastalık yükü ele alındığında madde
Considering
bağımlılığı
the burden of the disease, do you think that the activities on substance abuse are sufficient, and what would you prioritize? Well, the burden of disease is increasing day by day, and the States is a typical example. It corresponds to a very high burden of disease. It is like a tsunami that awaits us, and the mental health problems are increasing day by day. And in Turkey, we can observe an increase in the last 3 decades, according to the statistics, and we have to be prepared for this tsunami, and the existing resources should be allocated to primary and secondary prevention as well as primordial prevention, just like the doctors prescribing to their patients. The public health and the people working in the prevention areas need to prescribe prevention recipes to the people, and they have to be based on a strategy. This is the only way of tackling. Otherwise, it will be just temporary measures that we take. And
Ben teşekkür ederim.
Cevaplar için.
thank
Ve
you very
son
much, Abdullah, for your answers. And we have one question for Hakan Çetin, a question from our participants. In the last session, Kamran Diaz underlined the importance of the role of the parents in prevention, and you also told us about the activities carried out by Turkish Green Crescent and what activities are conducted by Turkish Green Crescent for the parents. Let me tell you a few things. Turkish Green Crescent is aiming at the families through different activities, and one of them is about the training on protection from the addictions for the families. And with this program, we are actually informing the parents to notice some warning signs at an early age. And this is a training package for the families. And we are also supporting this training with a guide. And the guideline is translated into various languages, as I described in my presentation. And this guideline categorizes how the parents should treat their kids at different ages. We know that the approach should be different based on the kind of addiction, and depending on the addiction, the families are informed what they should be doing. But we do not only suffice with that, we also have some different activities for the families. And this is the way we choose to raise awareness among the parents. And on the other hand, we have regular webinars for the families. We have the adult and the parent modules in our trainings, and this is also provided by the Ministry of National Education, and the contents are propagated to the families by the psychologists at the different units. Thank you very much, distinguished presenters. Before adjourning, I would like to underline a few things. If I should give you a summary, in this session, we have talked about the importance of prevention in tackling with the addictions. And the highlights of this session are the importance of the networks and connections among the actors and stakeholders of the field for advocacy. We understand that It starts at the neighborhood level and goes all the way to the global level. And also, prevention should be considered as a science, although the industry and the legal decisions lead to certain developments in the field. The science-based prevention has a very strategic role, and also
hem Avrupa'dan hem de aslında Türkiye'den Türkiye İşçiler Cemiyeti olarak yaptığımız faaliyetlerin, çalışmaların
our
ve aynı zamanda
activities
halk sağlığı açısından yapılan
as Turkish
çalışmaların
Green Crescent and
bu
also
konudaki katkısını
carried out by the public health have a contribution for prevention, as indicated by our speakers, developing the networks of volunteers and propagating those trainings are highly important. Psychologists, social workers, and other experts of the field should interact with one another, and while doing all of them, as indicated by each speaker, the scientific studies should be the basis. Due to a technical issue, we have slightly delayed. I would like to say that I'm sorry. We had many other questions, but we could ask only part of them. So now I would like to adjourn this session and thank you all for your kind patience, for your participation. And I would like to extend my gratitude to Oriole and Rakele, Abdullah Uçar, and Hakan Çetin. We are really thankful to you for your contributions, for your presentation. Have a great day ahead. Thank you.
Thank you.
Thank you a lot
Yes.
for presentations.
Buyurun Ömer
Saygıdeğer
Hanım.
oturum başkanımıza ve kıymetli
I
konuşmacılarımıza
would like
bu
to
değerli
thank the
bilgilerle
speakers
paylaşımlarını
and the chair for
teşekkür ediyoruz. Soru ve cevap
their
kısmının
presentations.
tamamlanmasının ardından
So with the Q&A session completed, we have come to the end of the first part of our Congress. We will now have a lunch break and then we will continue with our second session. Thank you.
Merhaba, Uluslararası Psikoaktif Madde Kullanım Kongresi'ne hoş geldiniz.
Hello, first of all, welcome to Congress. And of course, first of all, we would like to talk about the therapeutic therapy. And the first speaker is going to be Federn Kalataris. He is the Managing Director of World Federation of Therapeutic Communities and also Ketya Itaki, working in Ketya Itaki. As of 1980, he has been working actively in this field. And of course, he also worked in the California University Police Academy, and also he was giving courses. And he is also the member of the country in Greece. And also he had international certificates, and also
Uluslararası Yayın Danışma Grubu gibi
he is
çeşitli
also working in various institutions, and now still working for the World Federation Therapeutic Communities as the Managing Director, and now he is going to talk about the importance of therapeutic communities.
Thank you, Dr. Chipsi. Merhaba. Merhaba to everybody. Thank you for your kind words. I would like to thank also Green Crescent. I'm always happy to collaborate with Green Crescent for many years now. We've been collaborating, and it's very beneficial to me, and hopefully to others, and hopefully to you who will be listening and you will be part of this webinar. Okay, why therapeutic communities are relevant today? This is my talk. Next, please. Is this a way to deal with addiction? With a group hug? We will see. Next. I will talk to you about therapeutic communities and their part in the continuum of care, but also I will present an example from the organization that I used to work in Greece called Kethia, with research too. But we want to start with this. In 2016, something very important happened. the United Nations General Assembly special session was held in New York, and for the very first time, a unanimous decision by all 193 member states was taken that addiction to substances, but I would say addiction in general as a behavior, addiction is mainly a health issue. This is a big change. It might sound a little hypocritical because still in some countries, drugs and addiction is under the Ministry of Justice or the Ministry of Homeland Security, and people are punished by the death penalty. So, okay, but it is a big step for humanity, I think, to realize and to recognize with a unanimous voice that addiction is mainly a health issue. Next, please. Next. Yes, thank you. It is a disease, but it is preventable also. But here you can see this slide. There is a continuum of care. We're not talking about treatment alone. We cannot talk about therapeutic communities out of the blue. So we have prevention. We have harm reduction. We have rehabilitation. And we have also treatment and recovery. But all this have to be based on evidence. So we need research, and that's why I will present to you a research project in a few minutes. Next. It is a multifaceted phenomenon, addiction. It has many dimensions. It has an economical dimension, a legal dimension, a spiritual dimension, a political dimension. But the three dimensions that we focus when we come to treatment are these: the biological, the psychological, and the social. Next, please. The therapeutic communities as a model have this Declaration of Mallorca, next, where it is stated that therapeutic communities require interdisciplinary professional teams, including experts by experience. And with this, we mean people who had the experience of addiction and they have recovered and they have been trained, academically trained, and now they can work as professionals alongside psychiatrists, psychologists, sociologists, or social workers. And this all is dealt in a biopsychosocial framework. So I'm going to explain a little bit more about these three dimensions. It is obviously that addiction has a biological side to it. It is also a disease of the brain. It's not a brain disease, but it has to do with how our brain functions. And the more we scan our brain, the more we can see this with dopamine and the receptors and all this. So we know that has a strong biological, there is a strong biological element there. But there is also a psychological element. Usually people get addicted as a way of self-therapy to deal with the trauma that they have. The pain, the emotional pain, the psychological pain is immense. So when you're addicted, when you take substances, or when you gamble, it doesn't make a big difference anyway. But when you're addicted, you don't feel the pain. You feel good because you don't feel the pain. So it's one way of treating, of providing therapy to yourself. So this is a very strong dimension, and we'll talk about this also later. And there is also a very strong social element into addiction, because when we come to substances, and substances is a good example, they've been there for ages. Most ancient civilizations used substances. And they use substances, though, in a very specific framework, mainly as part of religious rituals. So there was a beginning and an end. For a couple of days, for one day, they would do this, and then they will go on with their lives. What really changed dramatically, it was when we had what we call the Industrial Revolution. The discovery of using steam as a source of energy changed everything. We have trains, so we have people commuting from one place to another in masses. But mostly we have factories. People leave their villages, leave the countryside, and they go to the big cities. Just think of London and Charles Dickens, Oliver Twist, David Copperfield, Christmas Story, all these books produced by Dickens. They give this picture of a city, a mega city with thousands of people, millions of people there, kids everywhere, diseases everywhere, a lot of crime, a lot of juvenile delinquency, and people feel alienated from themselves. They feel very lonely, but also from their natural environment. They're in a big city. They're not in their village anymore. And what do? They start taking substances to feel okay. They drink alcohol in Central and North Europe, and also in North America. In China, they use opium. So it's because of the social revolution of the industrial revolution. So this is a big social change. There is a strong social element, as I said. It has to do with the way we live together as people. That's why some of us go to addiction, choose to addiction as a behavior. Next, please. This is how the therapeutic community started. Most people think that therapeutic community started in America in the 50s, last century, I mean. This is not true. We have the very first therapeutic communities in England. They're not for addiction. They're not to treat addiction, but they have to do with what I mentioned, the juvenile delinquency, adolescents, teenagers who are committing crimes and they're out of control. They don't live with their families. For example, we have people like Baden-Powell, who was a former officer of the British Army, and he established the Boy Scouts, dress all these boys and later girls with a uniform, with a military structure, in order to give them meaning and to give them some order and some structure also. But from the more leftist, let's say, political sector of British society, we had people like Anna Freud, Sigmund Freud's daughter, who created therapeutic communities like the Boys' Republic, the Little Commonwealth, and they had the same rules, very similar to the therapeutic communities of today. Of course, their goal was not to treat addiction, although there was a problem with the use of alcohol, obviously, but it was more to give a structure and to give meaning to these teenagers. And then during World War II and a little bit after World War II, we have therapeutic communities in the military hospitals. People come back from work traumatized. People defect also. And the British put them in psychiatric hospitals, in psychiatric units. And they're a team led by Maxwell Jones at the Northfield Military Neurosis Center, developed a therapeutic community with similar rules, again, to treat mental health issues, not addiction. It included addiction, but not necessarily addiction. And then we go to the United States, to America in the 50s, and out of the self-help groups, the Alcoholic Anonymous, the Narcotic Anonymous, we have the very first therapeutic community in Santa Monica in California, in North California, in late 50s, and the name of that therapeutic community is Synanon. And this therapeutic community is specifically for people who have substance abuse problems. Now, all these people, this is amazing, they meet for the very first time. Maxwell Jones and his team from England, and other social workers from England working with teenagers, and also people from America. They meet together in Sweden, in North Shopping, in 1975, and we have the first international conference of therapeutic communities. So that's how the therapeutic communities came to be. It's a model which I will explain right now. Next, please. And this is a definition that I like. It comes from Australia. A therapeutic community is a treatment facility in which the community itself, through self-help and mutual support, is the principal means for promoting personal change. This is really the magic of the therapeutic community. The community brings the healing. It is not us, the professionals. It is not me, the psychotherapist. It is not us. It is all of us together, because we also, as staff, are members of the community, senior members, not junior members, but nevertheless members. So it is the group that brings the healing, because, as I said, there is a strong social element. So the group was part of the problem, society was part of the problem. So the group, society, community brings the solution. Next. In a therapeutic community, residents and staff participate in the management and operation of the community, contributing to a psychologically and physically safe learning environment where change can occur. So it's not the specialists giving orders or writing recipes. I mean, writing, giving, all the medication or whatever. There is no medication involved. It is together, staff and residents, creating this healing environment, and that's why we also need some time. Next, please. What I mean by this is, the longer someone stays in a therapeutic community, the more the chances that he or she will not relapse. Now, this fellow, Chuck Dederich, is the founder of the very first therapeutic community, Synanon, in Santa Monica, as I mentioned. And he said this, which I think is really important to hear. Synanon is not a drug treatment. It's a school where people learn to live right. Stopping shooting dope is just a side effect. What we have here is that addiction is not really the root of the problem. Addiction is a symptom. It's like the fever. It's not the virus that causes the fever. So we have to address the virus, not just the fever. There are other reasons why people get addicted, why people choose this behavior, because addiction is not a disease that you get, it has also this element of choice. And I emphasize choice because you can choose to stop being addicted. Addiction is enslavement, is a form of slavery. So you can choose to be free. You can choose your freedom. So what we do in a therapeutic community is people learn there together, staff and residents, how to live right. They learn how to love themselves first and respect themselves, starting with their bodies. And then they learn to love as a choice, right? I want your good. I want you to do the best. Loving others, being together with others. And when you do this, when you develop a value system, when you learn to live with others, automatically you don't need a pateritza, a crutch, You don't need anything. You can be free. So that takes care of the addiction. Next. Now, the example that I promised you. I worked in this organization for 35 years until last year. It's one of the largest organizations in Europe. Next. You see, it does many things. It does prevention. It has a very strong research department, education department. People go to school while in the therapeutic community, and they graduate from elementary school and high school, and they even take the exams to go to the university while they're in treatment. We have many programs in prisons. We do harm reduction, or Kethea does harm reduction. I'm not any longer with Kethea. They work with specialized populations, telephone helpline, and they just don't treat drug addiction, but alcohol addiction, gambling, internet, and other behavioral, let's say, addictions. So it's a very holistic approach. Next. Now, 20 years ago, the National School of Public Health of Greece carried out a massive research program. It tracked down 551 people out of 766 clients who were in treatment in 94 and 95. It tracked them down 5 years later to see what they're doing. So they used instruments like ASI, Addiction Severity Index, but also urine testing and also interviews. So it was a face-to-face approach. It was a big endeavor, a very big research project. Next. As you can see, the target sample was 551. 388 interviews were completed. The response rate is very high, 77.1. Next. You can see in comparison with other studies is the highest. Okay, the other studies are the most known studies in our field. Next. Now here are the results. You can see the time in treatment. So there were people who interviewed that even for a day were there. Okay, and at the end we have 35% retain rate after a year. Next. You can see now the difference. So 96% were using heroin. 5 years later, 58%. Intravenous use, and then they were convicted 37%, only 17% 5 years later. They were in prison. We had 32%, only 14%. Unemployed 64%, and only 36% 5 years later. And the next slide, please, which is probably the most important. Can I have the next slide, please? Thank you. Now, this is very interesting. The first column, or the first three columns, have to do with drug use. So people who stayed at least for a year in a therapeutic community in Greece, in Kethia, 73.5%, 5 years later, were not using any substances whatsoever. 73.5, 5 years later, but again, from the people who stayed for 360 days, for more than a year. Then the second column has to do with people having trouble with the law. 5 years later, only 14.58% had trouble with the law out of these people who stayed at least for a year in a therapeutic community. And the last one has to do with employment. Only 18.75% 5 years later were unemployed. Again, we're talking about people who stayed even for a year. So the numbers are there. The evidence is there. Next, please. Next. Okay, next. These are just pictures of the therapeutic, what happens in a therapeutic community. Yes. Next one. We have a big printing factory. You can see farm. Yes. Next. Yes. And they sell their stuff in fancy restaurants. And as you can see, next. This is a good reference book. It's 5 years old, but it's probably the best that describes therapeutic communities. It's a very recent publication, and it talks a lot about San Patrignano, what you're going to hear from Monica. So it was a collaborative effort of San Patrignano with Springer Publishing Company. I also contributed a chapter, but it's the most recent one concerning therapeutic communities. Next. I'm running out of time. Okay, many words in English come from the Greek, okay, and I'm going to share two of them for the finale, for the end. Please, next one. The first one is the word idiot. You have it in Turkish, you have it in many languages. It means stupid, but in Greek, it really means private. Even now, even today, even in modern Greek, it means private. It's the person who keeps to himself or to herself. Eventually, that person is stupid, is an idiot. What I'm trying to say is that we all need each other. And I commend Green Crescent for what Green Crescent is doing, bringing people together. We need each other. We need people from prevention. We need people from harm reduction. We need people from rehabilitation and treatment and recovery. We need everybody in this. And the last word, next, please, is the word therapon. Oh, no, before. Okay, thank you. But before that, please, thank you. The word therapist appears for the very first time in Greek literature in Homer. The Trojan War, in Asia Minor, very well where Tria is, if you're from Turkey. You probably live there also. Supposedly it was for beautiful Helen. That's nonsense. But the word therapist, therapon, appears there for the very first time. So it's a Greek word. And what it means is amazing. Therapon is a servant who assists the warrior to put his armor on so that he can go and fight the battle. And this is a reminder to all of us, no matter where we work, to all of us in the health sector, that that's all we are. We are servants. We cannot play gods. We cannot save anybody. We can hardly save ourselves. But what we can do is that we can provide people with the weapons to go and fight their own battle for their own life. We are there. We make ourselves available to serve people who are in need. Thank you very much. That's all. Thank you. I will be glad to discuss at the end, and also you can see in the next slide, you can see my email if you want to write to me and communicate with me as well. Thank you.
Çok teşekkür ederiz Fedon Bey. Soruları panelin sonunda alalım isterseniz.
We would like to thank you. And so we are going to receive the questions at the end. This was a great presentation. Thank you very much. Therapeutic communities, yes, they are very important.
Yes, therapeutic communities are highly important, and you have described it very well with evidence basis. The next speaker is Monica Berzanti. St. Patrick Nano is the dream of all of us. It's a beautiful village, and she will tell us about this village. She's the head of the international affairs of St. Patrick Nano, and she started working there as a trainer, and she acted as a mentor for the young girls for recovery, and she then joined the team of international relations, and she
politika yapıcılar, akademisyenler ve bağımlılık alanında çalışan kişiler için topluluğa yönelik çalışma ziyaretleri ve atölyeleri koordine ederek bu çalışmaları
and coordinated workshops for the people and acted as a guide in those workshops. And also she is in charge of designing master's degree and contributing to the contents of the master's degree. Since 2016, she has been also representing St. Patrick Nano in UN events. Now we would like to hear St. Patrick Nano from her.
So thank you so much. Thank you to Green Crescent for organizing this event, because it is always important, as Fedon said, to learn from each other, to exchange experiences, because it is possible in this way to do our job, which is helping people who need help in a better way, always better. There is always something to learn, something more to know. And thank you, Fedon, for your inspiring presentation. I can't say anything else for what you said, but I tried my best to bring my contribute to this discussion. I'll share my presentation without further ado. So my presentation is about the fact that there is the temptation of looking for quick solution, for quick fix for substance use disorder, but unfortunately, there are no magic medication that can cure substance use disorder. Substance use disorder is a very complex issue, and it is necessary to implement a very complex approach in order to be able to offer an opportunity to people who need help. So in my presentation, I will discuss what substance use disorder is, the complexity of the problem and the complexity of the necessary approach, and St. Patrick Nano, which is a biopsychosocial recovery model as described by Fedon, some data about St. Patrick Nano, and the many stakeholders that we work with, which account for the complexity of the problem. Well, in the 70s, when St. Patrick Nano started, there was a misconception of substance use disorder. It was seen as a bad behavior, a moral failure, or at the best, a weak of the will of the personality. Then in the 70s, in the 90s, in an attempt to lessen stigma that was cast on people with substance use disorder, the medical model was pushed. But unfortunately, substance use disorder is not a strictly medical problem. It is an health issue also, but it also implies many other perspectives, many other issues that enter into the game. Also, the idea of the brain disease, considering substance use disorder exclusively a brain disease, robs people that might have the idea of changing their life of the hope. If they think they are chronically diseased people, they might think that they won't be able to recover. And also general population have this idea that they can't recover from substance use disorder. Nowadays, however, the shared opinion, the shared idea about substance use disorder is that a complex cultural, social, biopsychological phenomenon, as much as it is also a biological phenomenon. And not embracing this complexity prevents effective approach. So let's see, for example, the drug use determinants that might be many. That might be the teenage with all this impulsivity, novelty seeking, the self-medication, as it was mentioned by Fedon, the brain which is still developing, so the frontal cortex is not ready to refrain from impulsive behavior. Then we have the drug availability and the social approval of some kind of drugs such as cannabis and alcohol, which has approved socially. The low cost, the low risk of harm perception. And also it is important to consider the microenvironment, the families, and the macro environment, peers, neighborhoods, schools, city, which is the environment in which people live that might affect their quality of life. So these determinants that might be many, as you can see, and their intersection can create and push toward drug use and then developing a substance use disorder. Because actually substance use disorder follow a trajectory. It's not a status. It is something that happens over time. People start with drug experimentation in their teens. And in this situation, it is important to work in the area of prevention, prevent the first use, but also prevent the development in mild or moderate use, instrumental use. But there are people that stop in the first experimentation. Other people stop in the second phase and stop using drugs also in an instrumental way and continue with their life. But other people, and it is difficult to say who and why, probably is the intersection between the many vulnerabilities they have that bring them to severe substance use disorder. In this case, it is necessary to apply harm reduction, treatment, and recovery options. So to comprehend, to understand better the problem of substance use disorder, we have to have a wider perspective. Of course, it is important to consider the addictive potential of drugs, but there are dependencies without substances, as Fedon mentioned also, such as gambling. Of course, we have to consider that these dependencies with or without substances can cause brain mechanism modifications, such as impaired response inhibition, changes in the dopamine circuitry, delayed discounting, impulsive to compulsive shift. So all these mechanisms are actually a disease of the brain, but they are also an adaptation to the use of substances, which means that the brain is plastic. The plasticity of the brain can bring to new modification when persons start to have healthy behavior. So what it is necessary to do to address the individual vulnerability that brought to substance use disorder, to addiction, that, however, might be also the tools to foster recovery, to foster the therapeutic approach to people who need help. So we need to address the age of first use, if there are psychiatric disorder, if there could be also some genetic predisposition that anyway have a very low percentage of influence on the development of addiction, it is of the utmost importance to identify ACEs childhood traumas, to identify and address them, and all the social and economic background of the person that might cause the addiction itself, unemployment, lack of alternative source of reward, people that live in an environment in which there are no choices, no different choice. So at San Patrignano, we decided to base our intervention from a basis of an educational approach, which means that we think that people that start using drugs miss the growing part of their life. I mean, during adolescence, they don't grow up, they don't mature out, they don't grow in responsibility, awareness of the consequence of their action. So they need a path of education in order to start again their growing up and mature out their personality. We approach this educational offer to our people with a peer-to-peer educational. No blame, because all people are in the same situation. They all know that they have to respect each other. There is not a hierarchical therapist-patient relationship, but rather a peer-to-peer approach that increases hope, because you see people that are in the same situation that you are, but they are going on, they are developing a good path to recovery, and you can be inspired by their action. Residents are fully involved, encouraged to take responsibility, so they are active participants into the program. They are not passive receptor of the therapy by someone that from beyond gives them the therapy. They are actively participating in their recovery themselves. The rules that are present in a therapeutic community are ethical and universal shared values, such as respect for each other, solidarity. This love, which is a choice of respecting the other person, loving and wanting the best for him. So it is important to create this environment in which the education progress into the maturity of the individual. We also offer in this education approach a broad range of rewarding opportunities in order to help the brain to find rewards in other things rather than drugs. This helps, of course, to address the biological aspect, which means that in a therapeutic community, there are no drugs, there are no drug-related cues, and this helps lessening the cravings, gradually eliminating it. Also, it is necessary to diagnose and treat the possible psychiatric comorbidity, because underlying the addiction, there are often also some psychiatric comorbidities that need to be treated. The residential therapeutic community allow people enough time to remain in the program and also be able to allow their brain to regain its normal functioning. The dysfunction of the brain caused by drugs, thanks to neuroplasticity of the brains, can go back to the normal, let's say, functioning. It is a learning process, actually. Cognitive, emotional, and all of that is able to restore a safe reward system. People start to learn that they can be rewarded by the simple things in life, such as hugging another person, giving him some love, some advice, being together, having sport, doing the good things that in life exist, and thus relearning to enjoy this thing. Then, of course, it is important, as Fedon underlined very well, the fact that many people with substance use disorder have suffered in the childhood some trauma, abuse, neglect, bullying, physical or psychological violence. Recognition, this must be recognized and treated. We use normally EMDR and cognitive behavioral therapy. Also, it is important in the narrative, in the conversation between the resident, this self-biography, personal history retrieval, because this way you can learn what happened in your life and start to address all the issue, all the sufferings in a different way. In this way, you can change your identity that was identified with addicted personality that mostly come from stigma and internalized stigma. People identify you as an addicted person, and you, over time, you finish in identifying yourself with this addicted identity that they give you. But it is important to change and go and become aware that you are a person and you can reach your goal. It is important to address also the social and economic roots of the addiction, because people that have this issue have had some difficulties in the past in the relation with other people. So it is important for them to learn social skill, to learn the ethical rules, to be able to learn a job also, to restore family ties, to go to school, especially if they are young, in order to be able to reach their goal in life, to access those resources that in the past they were unable to access. This gives them an empowerment, gives them the possibility to face their life with the armor that Fedon talked about a few minutes before. So that's why at San Patrignano, the length of stay is around 3 years. During these 3 years, we are able not only in the first part of the program to reestablish a general well-being, but also to offer them opportunity to go to school, to be trained in a specific job, and to get all the instruments, all the tools that can allow them to go into the society as free and contributing individual. The program is free of charge, and of course the question is, how do we sustain ourselves? San Patrignano is a social enterprise where we can have food production, artistic craft, design object. You can see the many areas in which we can train our people on one side, but also produce part of our revenues. We provide to the 65% of our needs with the earnings from our activities. In each of these departments, of course, there are employees and people that take care of the continuity of the production. This is an important element because in many nations, also developed nations, but also in developing nations, the cost of recovery might be overwhelming, and it is impossible to face it, and the national health system can cover this cost. So this is important to think about the fact that one organization that takes care of recovery is self-sustainable. This is good for the developed country, but also in developing country. And also it is an important educational value. People that think that they are providing to their own needs increase in their responsibility, awareness, and also self-esteem that they are doing something good for themselves and for society. It is on 300 hectares. We have schooling and vocational training opportunities. It has always been gender inclusive. Of course, it is important to provide gender-specific program to women, to girls. We only think about the fact that women have the higher percentage of childhood trauma. Women and girls have a very high percentage of sexual abuse in their childhood, and this caused them substance use disorder. In addition, women also suffer more from this trauma and carry on with them these sufferings for a longer period of time than men. So we need to address specific intervention for women, considering all the gender dimension. We welcome also adolescents under 18 years old and people with health issues. During the HIV crisis, we had a lot of patients with this problem. Unfortunately, before 1995, many people, many friends died, but not later because of the developing of good medication. Also, we provide psychotherapy and psychological support for those trauma, for those mental health conditions that might affect the continuation of the program, that might affect the person recovery and might cause relapse if not correctly addressed. This chart is to show you how many are the stakeholders we work with in order to provide all the necessary complexity to this complex issue. So we have the resident and the member of the cooperative, because San Patrignano is a social cooperative. There are employees, there are volunteers, collaboration, the families of the resident, the external supporting organization, institution, and public services, of course, companies and commercial sector that allow us to have these commercial activities that provide and account for our sustainability. But of course, we have donors and media, foundation, and people that from outside continue to ask for help and their family. We also involve young people with our prevention activity and many other NGOs at a national and international level, because as I said at the beginning of my presentation, there is always room for improving, for learning, for exchanging experience. And I want to thank Fedon because he really was a great inspiration for me since the beginning. And also Green Crescent, because I've worked with Green Crescent for many years now, and they are so committed to improve their work that are of inspiration for me. So thank you.
Sevgili Monica,
Thank you, Monica, for your presentation. You have shortly told us about the journey to developing an addiction. I have been acting as an advisor for founding of the rehabilitation centers in Turkish Green Crescent, and I've been working in the area of addiction for 15 years. I started with the children and the adolescents. I'm actually an adult psychiatrist, but then we started working in the rehabilitation centers with wider audience. And I would like to thank Fedon and Monica. As I understand from what you are saying, we are actually on the right way. The target is not elimination of the addiction, but improving or recovering the soul. And I would like to tell you about the Turkish model that is carried out by Turkish Green Crescent.
Aslında Yeşilay önleme ve koruyucu faktörler üzerine kurulmuş 100 yıllık bir kuruluş, bir STK.
First of all, we are talking about Turkish Green Crescent Society.
Madde kullanım oranları oldukça yükseldiği için Yeşilay aynı zamanda yakın danışmanlık, ayaktan rehabilitasyon ve yataklı kurumlar açmak üzerine de kurumsal bir görev üstlendi.
And of course, it has different roles and responsibilities related to preventive and protective activities. So there are two different centers. One of them is in Diyarbakır and the other one is in Bursa. What is the purpose of the rehabilitation? As my colleague stated, first of all, of course, we are trying to restructure the living structure of all those individuals. In 24 hours, we are trying to restoration of the living organism. So we cannot call it as therapeutic community because we are all professionals, but together with our counselors, we are trying to enable that platform. So all together with the clients and all together with the staff, we are focusing on equality. And of course, the purpose of the rehabilitation is to enjoy life, to have a social environment, to reorganize family relations, and also trying to struggle with some other problems in their life. Actually, we're talking about a kind of new life formation. This is our objective. And of course, this is 24/7 program. First 6 months program at the beginning. It's a very intensive program, and of course, they do not have too much personal time. There are different rules and based on equality. And the main motivation is to have a reliable, compassionate, and warm platform for everyone. And of course, they can have a trauma in their past or during their drug use, maybe they could have some losses. So we're talking about those individuals having trauma. So they are in need of compassion, love, and a reliable platform. So you are going to get the response. And of course, there is a system, and we are giving scores to the behaviors of our individuals, clients, and there is a rewarding system according to those scores. And first of all, we can only accept male patients, accepting male patients over the age of 15. They are able to understand the rehabilitation system, so they are in the phase of well-being. And of course, we do not have any toxification. For this reason, the toxification is going to be completed before coming here for those patients. What about the activities? First of all, of course, there are different activities in our center. First, individualized implementation plan. We have a social service, social worker, and also there could be some family interviews. There could be some other activities like getting certificates and psycho training, group works. And of course, in the future, there could be some activities together with Turkish Employment Agency. And in various fields, we are working together with our patients. We have a very strong team in these rehabilitation centers. Of course, we are an NGO, but all those services are provided free of charge. We are talking about a very strong team, but of course it's costly because we have more than 50 personnel in each center. And of course, there are staff accompanying all those patients. For example, we have a psychiatrist, psychotherapist, social worker, nurses, ergotherapists.
İşte ortaokul, lise diplomasını almak isteyen danışanlarımıza
And sometimes, for example, once again, some of the clients would like to go back to their employment. So we are trying to provide all kinds of support within the scope of rules. So we are talking about restoring of their lives. In addition to that, of course, education support, and we have some other course programs, workshop activities, extracurricular activities. We can have outdoor activities, and we have some behavioral activities. So we are trying to do everything where they can enjoy life once again. And in the morning time and sometimes in the daytime, we have sport activities. And of course, we're trying to use the power of knowledge. For all fields, we would like to educate our patients because we know that then they are going to be much stronger in their life. Art, music, sports, in every field, even
hem
uh,
danışanlarımıza seminerler
so
hazırlatıyoruz
we
hem
have
de
different
biz tarafından
seminars and we provide different
aile tabii ki
presentations.
olmazsa olmaz.
Family,
Türk
family is
ailesi
inevitable, and you
oldukça
know,
iç içe
Turkish
geçmiş,
family, they
sınırları
are
çok
all
mümkün olmayan
interrelated, and there are
aileleriz.
no
O yüzden
borders
aile bizim
mostly.
için çok çok
For
önemli.
this reason, family is very important for
Ailelerle
us.
birlikte çalışmazsak maalesef
If
ne
we can,
yaparsak
we
yapalım
do not
bir
work
ayak
together
eksik
with the
kalmış
families,
oluyor.
then one of the pillars will
Bu
be
merkezimizin
lost. This
dışarıdan
is
görüntüsü.
Bursa
Bir
Rehabilitation
başka bir
Center.
merkez Diyarbakır
This is
burası.
Diyarbakır Rehabilitation
Bir
Center,
davranış çizelgesi
and
geliştiriyoruz.
we
Şöyle
have
bir
a
mantıkla
behavioral
bütün danışanlarımızın tam
template.
puan aldığını düşünüyoruz.
We
Ve
first imagine
davranış
all those
çizelgesindeki
clients get
puanlardan
full
başlıyoruz
score,
ve
and then
yukarıdan
we
aşağıya
try to
doğru da
decrease those
en yüksek
scores.
puandan aşağıya doğru
And
gidecek ödüller
then
veriyoruz.
we have different rewards
Merkezimizin
for scores.
fotoğrafları
And
bunlar.
these are some of the photographs from our centers.
Maalesef şimdilik 6 aylık bir iletişimimiz var.
Unfortunately, now we have 6 months
Ama
of
Fedon Bey'in sunduğu
uh,
bir yıl aşan
staying in this center,
başarı inanılmaz.
but Mr. Fedon
Biz henüz yeni
emphasized
olduğumuz
on
için
that
istatistiklerimiz
success
henüz yok.
rate, and it was very
Ama
unbelievable. It was great.
umarım
We
biz
did
de
not have any
San
statistics
Patrick'in
so
ya da
far,
diğer
but I
terapötik
hope in the
gruplar gibi
future
daha uzun
we
süre
can have
danışanlarımızı
some
tutup daha iyi
statistics.
sonuçlar
We can
alabiliriz.
keep our clients for a longer
Birlikte
time.
işte sosyal aktiviteler
So we have
yapıyoruz.
different social
Birlikte meslek
activities.
edindirme
We
kursları
have
var.
different activities in
Bizim
order to
olmazsa olmazlarımız.
have some
Sanat
hobbies.
tabii ki çok
Sports
önemli.
is a
Bir sergi
must.
açtık
Art. We
danışanlarımızla
had an
birlikte
exhibition,
geçen
art
sene.
exhibition yesterday together with our
Yaşam
clients.
becerileri kazandırmak için
And
evde basit onarım
living
vermediğimiz
skills.
bir
For example, we
kursumuz
have
var.
some minor
Bütün
repair
danışanlarımıza
maintenance
ütü
platform. I
yapmaktan
mean, for example, we're
dikiş dikmeye
teaching
kadar
how to iron,
her
how to
konuda
sew,
basit
how
evde
to do
kendilerine
some
yetecek
repairing. These are
eğitimler
very
veriyoruz.
simple things, so we provide
Kendi
training for
sorumlulukları,
those.
kendileri
And of course, they
yapabiliyorlar ve
have their own
ortak yaşam
responsibilities
içerisinde hem
where
çevrelerini hem
they
kişisel
stay,
bakımlarını kendileri
both
sağlıyorlar.
for their own personal hygiene, also for their
Bu da
environmental cleaning.
programlarımızdan bir
These are programs, some of the examples.
Can you repeat it, please? I'm not sure I understood what.
Maneviyat temelli bağımlılık tedavilerini terapötik yaklaşımlar
For
çerçevesinde
addiction
değerlendirebilir misiniz?
treatment, could you please elaborate on that within the scope of therapeutic communities?
Okay, all right, yes, thank you. That
Teşekkürler.
I think I understood. Yeah, okay. Okay, therapeutic community is one model of treatment. I don't like comparisons, so I don't want to say it is the best model, but it is a very good model because it's a very efficient model. And it is a model that gets rid of stigma because it brings equality to everybody. All the people who come there, they take their lives into their own hands. That's the secret. That's the magic of it. So when you really fall in love with life and you take your life into your own hands, then you don't have to be addicted to carry on and to deal with your pain, with your emotional pain. So this leads you to recovery. Eventually, you don't need not only substances, you don't need addictive relationships because many relationships are quite addictive. You learn how to live, and it is my understanding that although addiction might be considered a curse, when someone goes through this, through recovery, especially if with a model like the therapeutic community, and what Monica presented and what you, Arzu, presented are very similar to what we all presented. Okay, eventually, at the end, this curse becomes a blessing, because I see people who have graduated from these programs 20 years down the road, they're better parents than most. They're better citizens than most because they know what really counts in life, what are the important things in life. So you cannot ask for more. And I think that's what a therapeutic community can provide for people. I hope I answered the question, if I understood it well. Again, I apologize for my voice. I'm sick. That's why I sound funny.
Çok geçmiş olsun. Tekrar size
Get
sorulmuş.
well
Terapötik
soon. Once again, another question for you. Of course, we can see the effect of therapeutic communities, and what is the dissemination? What is the dissemination in worldwide?
Okay. If you want a very sophisticated answer, just go to the WFTC, World Federation of Therapeutic Communities, the WFTC site. There is a world report. Every year we produce a world report. And again, they're not all the therapeutic communities, but the therapeutic communities who send us their data. And you will see amazing stuff. So there are thousands of therapeutic communities all over the world. 2 weeks ago, I was in Brazil. In Brazil alone, there are 3,000 therapeutic communities. So, and especially now, there are many in South America. I think most therapeutic communities are in South America. But we have in North America, of course, we have in Europe, in Asia. Only in Africa, we don't have many therapeutic communities. In Australia, we have many as well, in Oceania. But go to the site and you will have all the details and all the data there.
Sevgili Fedon, tekrar bir kıyaslama sorusu
Thank
gelmiş.
you. Once again, there is a comparison. Therapeutic community models comparison mentioned in the US and the UK. So similarities, differences can be considered. Which one is having much more universal approach? Which one is much more acceptable for Europe region?
Okay, this is also a good question. I'm also the president of the European Federation of Therapeutic Communities, so I have to be very diplomatic about it. But therapeutic communities in England, in Great Britain, are very good ones. To me, the problem today is the economics of it. So because of lack of financial support, many therapeutic communities are shorter. I'm really happy that San Patrignano lasts for 3 years. This is a guarantee that people will really get out of addiction. So the longer they stay in a therapeutic community, the better the results. So I'm answering in a diplomatic way, I think. So the ones who have longer programs are the best, no matter whether they're in England or in other parts of Europe or in Asia or wherever they are. Yeah. But one thing that I would like to add, now the big thing as far as substances is concerned is synthetic drugs. Everybody's talking about synthetic drugs. And with opioids, we had harm reduction was very strong because we had methadone, we could provide methadone and buprenorphine. With synthetic drugs, there is no substitution. So in many ways, therapeutic communities have a revival. There is a resurgence of therapeutic communities. They're coming up front because they can provide a solution and they can give their life back to the people who suffer because they take synthetic drugs. So let's keep this in mind. We need therapeutic communities everywhere, I guess, even more so now.
If I can add something, I would like to say that the longer the period you stay in the program, the better the outcome. It has a scientific base. I mean, you allow the brain to change the mechanism so that you can reward your prefrontal cortex and all the rest go back to their functioning and rewire of the brain allow a better life in the future. So that's why we decided to be self-sustainable, because it is necessary a long period of time. And this is impossible to have this long period of time paid by the governments. There is no government that can pay for this length of time. In Italy, we have 1,000 therapeutic communities and accredited with the national health system. And the national health system paid for 1.5 years at maximum for the recovery process, and it is not enough. We have 100 beds accredited with the national service, and they pay for 1 year, 1.5 years, but the people remain longer until they complete the program, because 1.5 years is not enough. I mean, it can work for someone. There are people that get better in 1 year or less, but people might need more. And it is important to give them more opportunity.
Also, if I may, I mean, even a year and a half is a lot. In many states in the United States, you know this very well. It's 28 days only. The government subsidizes only 1 month. So
And this is the reason why there is a general idea that the disease is chronic.
Yes.
And
yes.
relapsing. Of course, if you have a 1 month program, it is impossible not to relapse. I wonder who really can recover in just 1 month. It's a miracle. It's I don't know what. But 95% of relapse, it's of course the norm if you provide a 1 month, or also 6 months is
little.
Is little, of course. But it might work if it is intensive. It might provide some more help, of course. The longer, the better, anyway, as you suggested.
Biz tabii Türkiye olarak daha yeni başladık.
Of course, we have just started in Turkey, and I hope we can keep our patients for longer period of time. We have very intensive programs, as you have stated. Of course, economic dimension, economic factor is also very essential. And for therapeutic communities, of course, we would like to have training. We do not have any users they are able to pay. So we would like to see the government support, state support. And we cannot say, okay, you are done. You are going to leave after 6 months. After 2 months, maybe they can go back to their families. They can try themselves. They can see what kind of things are challenging for them. So we are trying to have a kind of transition. So we have some outer, external internships. We are trying our patients, maybe sometimes they're in need of such drugs, substance. We have such opportunities. For example, the patient can say, I am not ready. And then we have the opportunity to say, okay, you're going to stay for a longer time. All right.
Dear Fedon, what would you suggest to the young psychologists and social workers?
This is a disappointing question because it suggests that I'm old and I need to give advice to younger people. But it is true in a way. It is true. It is true. Being in this position, I interviewed thousands, literally thousands of people looking for work for the organization I used to work. We had committees and people would come and apply. So I would see many people, and now I see people who are really very well educated with master's degrees, even PhDs in the addictions, which is really amazing. It's great. But to me, the most important ingredient is your heart. To have a heart for this, to be a giving person. If you're not a giving person, you're not fit for this job, even if you have two PhDs or postdoc or whatever. Okay, so this has to come from the heart, and also to be humble enough to unlearn things. I learned many things from the clients and from their families, not from my university studies. That's why I talk about therapists being a servant. We are servants. We are there to serve and equip people. It's their lives. It's not our lives. We just make ourselves available. So these two things, I think, to have a positive heart, a heart of giving, a giving heart, and also to be humble enough to learn from others, including your clients. That would be it, I guess. I don't know if it makes sense, but
Thank you very much. We have limited time left, so I have to pick some questions. Dear Monica, there are 3 questions. I will try to merge them. In the treatment of the addictions, when you consider the genetic disposition and trauma, how do you treat them? What is your approach to treatment? And do you have any measurements that you do in between the therapies? How do you follow the course of treatment and in terms of measuring how the recovery is progressing?
Well, the trauma sometimes are hidden in the sufferings. People try to forget them. And mostly it happens that after a while, the person become aware of the trauma that he or she suffered in childhood. And the first talk is with some peers and remind of this, what happened in their childhood, and then the peers help this person to have a contact with the psychotherapist, with the person that can give a professional help to address this trauma, which is treated in parallel to the educational program, which is part of the program that everyone receives. I mean, not all people go to the psychologist. Only those who find in themselves something that needs to be addressed by a professional. All the others are taken care by educators. Most of them are former residents of the community that gained some academic title, some academic education in order to be able to complete their personal experience with some study in order to be able to offer a wide range of help and support to the people who need help. How do we always check the progress into the recovery process? Is a daily attention. I mean, San Patrignano is very big. We have currently 900 people, but they are included into smaller departments in which they have their job training, their sport activity, and they also do things together with the other group. But these smaller departments are taken care by some educators that are always there with our people, with our residents, and can see how they progress into the recovery process. If they have bad reaction, if they have a good attitude towards other people, they are given progressive, small, and gradually bigger responsibilities. For example, one of the most important steps is when someone is given a newcomer to mentor him. I mean, you have been there for 8 months, 10 months, and then a newcomer arrives and you are asked to take care of this newcomer. This is a very crucial step in people's recovery path, because at that moment they stop thinking only about themselves and they open to give, as Fennel said, to give their support and help to another person. This is crucial because it is the moment in which the narcissism, egoism of people who use drugs start to change and really create these differences. You learn that you can stay well, you can be rewarded by giving help to another person. This is magic, you know, because it is something totally different with what you experienced in your period of addiction. So this is the way in which we follow the progress of people, how they react in acting in their new responsibility they have. They take care of a person, they might take care of a group of people, but always they serve. They are not leaders that take other people what they have to do, but they show what to do, and there are people that follow. This is a real leader, this is real making a group to stay together and help each other and support each other. I hope I answered the questions.
Zaten insan ruhu için başkasına yardım etmek de bir üst ihtiyaç. Değil mi?
Actually,
Kendinizi
it is a need for the human soul to help the others because helping others makes us feel really good, and our clients are able to taste this feeling as well.
Sağlıklı bir şekilde ayrılan bir danışan ile daha sonra takip görüşmeleri yapıyor musunuz?
Do you
Evet,
have
yapıyoruz.
follow-up sessions with a client who lives in a healthy way? Yes, we have some follow-up sessions, but we are an intermediate institution indeed. The clients come to us from Green Crescent counseling centers and they're referred back to those centers so that the therapeutic relation is sustained, and also we would like to see how they are doing, and we're giving them calls at times. How do you ensure security in rehab centers? We have our private security officers.
İyi eğitim almış.
They are well educated, they have their security certificates, and they are in charge of ensuring the security of our clients and our workers. I think now we can adjourn this session. Thank you very much for joining me in this session, and have a great day ahead. Thank you.
Our distinguished session chair and the esteemed speakers, thank you so much for being with
Thank
us
you.
in this Congress and sharing
you.
your valuable insights and for your contributions. Now we'll continue with the 15-minute break. Right after the break, we'll continue with the third and the last session of the first day of the Congress. Hope to see you again in 15 minutes.
Değerli katılımcılar, kongremizin 3. oturumuna geçiyoruz. Bu oturumda uyuşturucu bağımlılığı ile ilgili yeni risk ve tehlikeler konusu ele alınacak. Oturum başkanımız İstinye Üniversitesi öğretim üyesi ve Türkiye Yeşil Ay Cemiyeti Bilim Kurulu üyesi Sayın Peyami Çelikcan olur.
Our speakers who will be with us in this session with their valuable speeches are Associate Professor Hande Çelikay, who is faculty member at Near East University, Professor Derek Haim from Edge Hill University, and dear Pujana Sharma, who is board member at Green Crescent, Nepal. I'd like to welcome our esteemed session chair and the distinguished speakers for joining us in this session. And this session will last approximately 75 minutes. Associate Professor Hande Çelikay will be with us with her speech entitled Methamphetamine Use in Turkey, while Professor Derek Haim will be with us with his speech towards the contextualized in understanding of substance use, and Ms. Pujan Sharma will be with us by a pre-recorded video with her speech entitled The Changing Face of Psychoactive Substance Use in Nepal, Trends, Challenges, and Solutions. And now I kindly leave the floor to the session chair, Professor Peyami Çelikcan. The floor is yours, Professor.
Thank you very much, Rumeysa Jodar. You make everything easier for me. You explained everything. So I will just introduce our respectful speakers. The first one is Hande Çelikay Söyler. As Rumeysa stated, he is a faculty member at Near East University. Let me briefly introduce you Hande Çelikay Söyler. She is associate professor, completed her undergraduate and master's and doctoral studies at Ege University in the fields of psychology, psychometry, and substance abuse and toxicology. She holds an associate professorship in clinical psychology and is certified as a practitioner of cognitive behavioral therapy. Shortly, CBT certificate she has. Dr. Çelikay Söyler also conducts a variety of assessments, including personality tests, intelligence tests for both adults and children, and neuropsychological evaluation. Through the cigarette alcohol substance addiction treatment program, shortly SAMBA, she provides psychoeducational support for the families and individuals dealing with addiction. Floor is yours, dear Hande Çelikay Söyler.
Teşekkür ediyorum. Thank you very much. Today I will be talking to you about the use of methamphetamine in Turkey, but I will first tell you about a case. I solved this client nearly 1 year ago, and I will be going on with my presentation based on this client, and I will tell you how much we're experiencing these issues in Turkey. My client was also mentioned in our methamphetamine stories that we published 1 year ago. It's a 23-year-old male patient, and there were some withdrawal symptoms, and he started using drugs when he was 14 years old. He smoked weed for 5 years, and then he started using Lyrica and methamphetamine. His father had bipolar disorder and alcohol use disorder. He had difficulty in breathing, and he also had anger issues. He doesn't have a girlfriend. He says his inner voice was talking to him, and he thinks there is a device installed in his chest or in his throat, and he thinks his mimics are being controlled through this device. And he declines to use any medication. In order to prove this device, he went to ENT experts and emergency units as well as psychiatrists. He applied for imaging, and he thinks that the images were distorted. The device was hidden from him, and he was forcibly hospitalized in the addiction inpatient unit. And during a havoc in the emergency unit, he was not able to control it, and he attacked his mother. He hasn't seen anyone for a year now. He doesn't have any social life. And when he wants to stop using methamphetamine, he was socially withdrawn and he did not contact anyone. When we had an interview with the mother, she said she noticed weird behaviors back in 2019. The son was a forklift operator, and he was working back then, and he also noticed that the son was staying in the bathroom for a long time. When he opened the door of the bathroom, he found smokes inside, and then she noticed what he was using. The client had a poor communication with the mother, and because the mother was in charge of the money, he wanted money from the mother all the time, and when the mother could not give, he discussed and he attacked the mother. And recently, he started to consume all the savings of the family, sold all the commodities of the family, and paid the money for the drugs. He was hospitalized for 20 days before. Then he started using drug again, and he was hospitalized for 4 days in the next second hospitalization. Due to the father's problems, he visited his hometown, and he sold the items in the house. And after selling the items at home, the mother did not compromise, and she stopped giving him any more money. And then the son attacked the mother physically, and one day he was again trying to sell the items in the house, and he started to throw the items in the house on the top of the cars from the balcony because he thought that someone was trying to communicate with him through the television. And the police came to the house, and the neighbors complained. He promised to quit using drugs, and he didn't leave house for 6 months, and he didn't communicate with anyone. And in the meantime, it was found that the father has COPD, and he was expected to die any moment. And when he was alone at home with the mother, he had a nervous breakdown, and the mother asked for help from the police, and the police tried to stop him from attacking. In this most recent incident, he said he will cut his throat and he will take out the device in his throat. And the mother called 191 for help because he didn't have anyone to ask for help. And sometimes he was telling the mother, "Wish you died," and she was sleeping with her daughter because she was afraid of being attacked. He was very fond of his uncle, and the uncle was speaking to him all the time, and he was sharing his theory of this device in the throat so that he will take his medication. And the uncle asked for the custodian to become his custody, and he had his physical problem as well. He had to have a knee operation, but the mother could not take care of her own problems. And at the end of the sessions, she was saying, "If I'm lucky, I will go to the hospital, otherwise, my son will kill me." And 15 days later, the intern in our unit told me that she saw the news, and nearly 20 days after our session, he attacked the mother with a hard object on the father and he killed the mother. And then he went to the father's workplace. I told you about this incident because there are so many negativities, many problematic incidents associated with the use of drugs. And I will tell you some clinical studies. The first study was conducted by using the biochemistry data from Kayseri University, and the incidents, the applications to the hospital were analyzed, and more than 90% of the people who gave samples were found to be male, and the highest rate is between 20 and 30 years old. And also methamphetamine is now very common in the patients, and multiple drug use is amphetamine, methamphetamine, and the second one is amphetamine and opioid. And four different sources were used to get samples. One of them was Amatem, and the samples from four different resources indicates that the use of methamphetamine is increasing. Amphetamine positivity was 16% in 2014. It was 51% in 2015. In 26, it was 65%. Another study on substance use in children, adolescents, and forensic toxicological analysis. As we know, the substance can be tested in blood, urine, mouth fluids, hairs, sweat, and nails. I wanted to mention about this study because recently we see that the children are also subject to drugs, especially methamphetamine, and also the women are using drugs during their pregnancy. Meconium is a good source of analysis because starting from week 12 and 16, metabolites are engaged in fetal production, and we can actually see the exposure to this substance. As for the general trend, the ages between 10 and 20 are at high risk for developing alcohol and drug abuse, and in 30% of 96 million people between the ages of 15 and 64 in EU were found to have tested substance for at least once in their life, and first comes weed and MDMA, and ecstasy and cocaine are following. And this trend has now changed. The The aggression at the childhood period is considered to be a risk factor. Also, parental control shortcoming is another problem. And as protective factors, self-sufficiency, parental monitoring and support are suggested. Easy access to substance in the school is another risk factor, and school policies must be developed for that. And for poverty, the social resources should be developed.
Geriye dönelik analiz sonucu şekilde de gördüğünüz gibi saç gene mekanyumunda anne karnındaki maruziyeti ve verebilmesi açısından da önemi var. Yakın süreli kullanımlar için işte nefes, kan, ağız sıvısı, idrar,
And of
ter
course, there are different tests that can be performed, like urine, blood. First of all, this is about the investigation of socio-demographic and substance use characteristics of cases applied to child and adolescent substance addiction treatment center. What attracted my attention is in this study, and as expected, and of course, when we have a look at the results, generally female, number of school dropouts, 73.6, average duration of education, once again, low academic achievement, disciplinary action at school, self-harming behavior, 48%, suicide attempt, 20%, forensic history, 52.8, and these are all very high percentages. And of course, we can see different uses. First of all, it starts at the age of 11 for tobacco, ecstasy, 14, synthetic cannabinoid, 15, sedative hypnotics, 15, and alcohol, 14. For example, we can also see the tobacco cigarette use, 97, alcohol, 79, marijuana, 88%, ecstasy, 67, and methamphetamine, 40. This is also another study which was conducted in forensic medicine and DC polyclinics in Adıyaman. Totally 145 participants were included between 2017 and 18, and 142 of those cases were male and 3 of them were female, and age range is between 18 to 56, mean age 27, and 103 cases were from this 18 to 30 age group of young adults, and 62.8 are single. 74 cases have been using substances for 1 to 10 years. The mean age of the first use of the substance was 19.72, and those over the age of 30 started using the substance, 6.6%, 32 cases receiving psychiatric treatment, and there is a family history for the substance use in 25 cases. In 94% of the cases reported using marijuana, 52 ecstasy, 26 bonsai, 21 methamphetamine, 17 heroin, and 10.9 cocaine. And 35% of the cases were related to injury, 23% to theft, 6.7% to threats, unlicensed possessions of weapons, property, damaging, harm, and we can see 5% military crimes. This is another study, and we can see the data from the Turkey's drug report published by the Department of tackling with narcotics. And the majority of the total incidents that occurred nationwide between 2014 to 2018 were related to the use of such drugs, and we can see the number of the cases again. The most seized substance in kilograms was cannabis, and we can see it is noticed that the most seized drug substance after cannabis was heroin, and you can see the kilograms in parentheses. Once again, in the same report, when the number of people in prison for drug crimes was at its highest in 2018, approximately 36% of the total number of people convicted for drug crimes. So every 1 out of 3 individuals. In the same report, once again, this is the number of direct drug-related deaths by year. In 2014, 232 individuals lost their lives directly due to substance addiction, and this number increased in 2015. And of course, reporting and registry systems are now much more developed. Maybe this could be the reason of keeping the records. And this is the Caesar for the amount of methamphetamine in our country. There has been an increase. Once again, we can see this every year between 2016 to 2021. There is a sharpest increase, which was experienced in 2020 when the amount of methamphetamine seizures increased and compared to the previous years. We can also see the same trend once again, but
çalışmanın şöyle bir özelliği var. Polis ya da adli makamlarla yapılan bir çalışma değil, klinik psikologların
this is
yapması
a
gerektiği bir çalışma.
study which is conducted face to face by 125 clinical psychologists between September, October, and of course, the aim is to collect data.
%50'si erkek ve %50'si kadın.
And 50% male, 49% were female, and the participants were between the age of 18 to 81. And once again, the use of substances were examined, and the prevalence of using a single use is for one's lifetime is 4.5, marijuana use is 5.3, heroin is 0.31, and cocaine and methamphetamine is as stated. Of course, there are different interrogations, and we know that maybe some of the individuals were hesitant to share some of the information about using such drugs. This is another study, gender-based analysis, and this is conducted in Canada, Vancouver, a cohort study. First of all, we can see there are blood tests. Some blood samples were collected. We can see the average age, 41. 58% are white females. And of course, the use of crystal is examined. And we can see, once again, the percentages. Between 2006 and 2017, methamphetamine use in the past 6 months increased from 19% to 36%. This increased from 14 to 36 in female and from 22% to 37 in male participants. Daily crystal methamphetamine use in the past 6 months increased from 1 to 12%. And once again, injection use of crystal methamphetamine in the past 6 months increased for all patients from 18 to 28%. And risk factors were examined. What are those risk factors? First of all, long-term use, unemployment, homelessness, drug dealing, injection of heroin and cocaine, and also having unprotected sexual intercourse, and also having a male partner. All those are at risk factors. Duration of substance use, injection, cocaine, high-dose substance sharing, experience of physical and sexual violence. These are all risk factors.
Well, Dr. Çelikay, excuse me, sorry for interruption, but we are running out of time, so you have 1 minute actually, but I will add one more 2 minutes for your conclusion, please.
Tamam, çok hızlıca toparlayacağım. O zaman
I'm
önemli
going
bir
to wrap up rapidly.
psikozun metamfetamin kullanımdaki görülme yaygınlığından bahsedeceğim.
And I'm going to speak about the prevalence. Once again, the continuum. First of all, we can see the group with SUD and the group with schizophrenia. There is no difference significantly in terms of positive symptoms of schizophrenia. And
Geçmiş olan kişilerde
if
pozitif
there is the
belirtiler
psychosis history, there could be positive symptoms and negative symptoms are less. Of course, psychosis can be seen in every patient out of 2 if there is the use of methamphetamine. This is also another study about the methamphetamine-associated psychosis spectrum. There is also another important finding. Together with cognitive disorders, especially for psychotic disorders, there is an increase in terms of cognitive disorders, and these are different categories for non-psychotic symptoms.
Bir de metamfetamin kullanımının sürenin uzun olması ve
And there is also another comparison with the use of illicit drug. So this is also associated with the age groups, and starting using the substance at an early age can have a higher impact. I would like to thank you. Thank you for listening to my presentations. That's all from my side.
Okay, Dr. Çelikay, thank you very much for your presentation. As your numbers proved that methamphetamine use rised up rapidly throughout the years, approximately around 65% a few years ago. So you share with us all the data, but more importantly, you also share the tragic story of a methamphetamine user. As far as I understood, you published as books all these stories. I think these are available for the presenters as well. So at the end, maybe you can give us more information about these books, stories, titled as stories. Thank you very much. And I immediately switch to our second speaker from H. Hill University in the UK, Derek Haim. Derek Haim is a professor of psychology at this university. As a social psychologist with an interest in health behaviors, his primary research areas concern addiction and substance use and health and well-being. In this context, his work focuses on social, cultural, and contextual influences which he investigates. Professor Haim is editor-in-chief of the cross-disciplinary journal Addiction Research and Theory. In 2023, he was appointed as chairperson of Smart Recovery UK, a self-help mutual aid support organization that is active in 28 countries and offers the chance for people to work together or with a therapist to examine and change problem behaviors. I would like to invite Derek Haim for his presentation. Floor is your, dear Dr. Derek.
Thank you very much for the introduction, and thanks very much for having me. Hello, everyone from Lancaster in the northwest of England. It's a bit colder here, I suspect, than in Turkey. Today, I'm going to talk to you about some research we've been doing in the area of alcohol use towards a more contextualized understanding of substance use behaviors. Whilst the research is on alcohol, because that's mainly what our research lab does, I think some of the conclusions might be applicable to other substances as well. So basically, I'm going to, in a nutshell, my argument is that we need to pay more attention to the context in which substance use occurs. And the talk is going to unfold as follows. So I'm going to start talking to you about prevalent approaches to studying alcohol consumption. I'm going to talk to you a little bit about how beliefs and cognitive processes that are associated with alcohol consumption from a psychological perspective are commonly studied. I'm going to raise some potential concerns and issues with dominant approaches, and I'm going to give you just some illustrative examples of how we have been trying to address those limitations and study substance use in context before reaching some conclusions. I think there will be time for questions after the next speaker at the end. Okay,
Yes.
so in terms of alcohol consumption, most prevalent approach to studying alcohol consumption and indeed lots of other types of drugs consumption tend to rely on population level approaches. So we can look at per capita consumption, often through the means of surveys, or we can compare survey responses to what people are drinking to trade to sales data, and we can usually tell that there's a discrepancy between how much alcohol is sold in the country and how much is reported in surveys of alcohol consumption. And I think surveys are very important, so I'm not trying to dismiss the importance of survey work because they're useful in, for example, in identifying risk factors, who might be most at risk for issues with particular substances. They're also important to identify trends. So we know, for example, that in many Western countries, at least, alcohol consumption is declining amongst young people in particular. And there's also been an increase in abstinence, so people refraining from alcohol consumption. And we can also use these kind of population level data to inform alcohol policy, such as minimum unit pricing, which has been implemented in a few countries, and other types of interventions. So turning more to sort of the psychology of substance use. So one of the most dominant ways in which we examine substance use behaviors is via self-report questionnaire measures. So we might measure outcome expectancies, and these are essentially the expectations people have, what will happen, what are the outcomes of them drinking alcohol or taking another substance. They might think, my expectation is, I'll be more social when I drink alcohol or take a substance. I've enhanced sexuality when I take a substance. We also measure something called drinking motives, where we differentiate, broadly speaking, between different types of motivations why people drink. So it might be social motives. I can make friends with people more when I drink alcohol or consume drugs. It might be coping motives, where people think that they can cope better with life problems when they drink, or it might be enhancement motives where people feel better about themselves when they drink alcohol. We can also measure people's self-efficacy. So self-efficacy, we know, is one of the most important determinants of people's ability to change their behavior. And self-efficacy is the belief people have that they are able to change a behavior, or that they are able to refuse, for example, refuse a drink. I can say no to someone offering me a joint or a pill or an alcoholic drink. And finally, we might study normative beliefs, which is basically the beliefs about what do people who are important to us think about alcohol or about other drugs, And we know that people's views of what they think important others think about alcohol are important also for people's individual consumption. We can also look at the cognitive processes experimentally. So, for example, we might use an inhibitory control task, like a go or no-go task, which is essentially just a measure of impulsiveness. And you basically present on a computer screen stimuli, and basically sometimes people have to respond to a stimuli, and sometimes they shouldn't respond to a stimuli. And essentially, so they have to sometimes suppress the dominant response. And people, for example, who are drinkers tend to find it difficult to suppress a response to stimuli that is alcohol. They sort of feel the urge to press the space bar, whatever. Or we might also use eye tracking behavior because, again, that gives us, we can see actually how people process information without relying on the self-report, just by following where they look. Just a very broad overview of some of the things we as psychologists do. And I think, again, these individual level approaches are important because we can potentially use them to develop interventions for training people to, for example, be better at inhibiting certain impulses and wanting to do something that might not be good for them. However, I would argue that despite their importance, we tend to, with survey research at least, we tend to emphasize more what is happening, who is engaging in particular behaviors, and less so why particular people might be engaging in behaviors. So the question, asked by most survey research is what is happening, and to a lesser extent, why things are happening. Obviously, we can use some of the information to look at gender differences or age differences, but it's primarily what, not why, I would argue. We also rely on retrospective accounts of substance use behavior. So we know, for example, when people are under the influence of alcohol, their memory might not be as accurate as it would be if they weren't under the influence of alcohol. And so therefore, actually, the cognitive task of recalling one's consumption of alcohol, or in fact other drugs, might actually be impaired by the very activity we're trying to measure. We also know that there are issues with self-presentation. So we've known this since the 1970s, when quite a famous study conducted in Scotland basically asked school children how much alcohol they drank. And what the researchers found, this wasn't the aim of the research, they found that basically when children completed the questionnaire in school, the responses were very different to when they completed the questionnaire under the watchful eye of their parents in their own homes. So when these children completed the questionnaire in schools, they reported much higher alcohol consumption than when they completed the questionnaires in their own homes, because basically the researchers hypothesized when they were in school, they were trying to portray themselves as tough and into alcohol when their friends were watching them fill in the questionnaire. And obviously the motivation was maybe slightly different when the parents were watching. So I think there's an issue there with questionnaire type studies that assume that beliefs are immutable, unchangeable, and somehow fixed. In a similar way, laboratory studies, whilst might be useful in sort of understanding the psychological processes that are implicated in substance use behavior, they tend to be conducted in quite sort of sterile laboratory settings that are usually far removed from the actual context in which people take substances. So I think dominant research, runs the risk of perpetuating an incomplete picture of substance use behavior. And another thing that I think a lot of research doesn't do, we sort of tend to speak to people when they're not under the impact of substances, and this might ignore the impact that this intoxication might have. So we know, for example, that if you prime people with a little bit of alcohol or other substances, the motivation often, best intentions might go out the window, and people will start consuming a lot more substances because of that initial hit that they've received, as it were. So we've been trying to address this by going into the field and actually doing real world assessments and observing alcohol behaviors in the environments in which people take substances or take alcohol in this case. We've also addressed this in some of our laboratory research, where we basically test people not in a sterile, boring lab, but we've actually created a bit of a bar lab, and we can also test people individually and socially together to see to examine the impact that the social environment has on people's responses. But again, I'm just going to run you through a few studies now, just to give you a bit of a flavor before reaching my conclusions. So this is just an early study that we did that just shows that essentially when and where you ask people about their alcohol behaviors. So in this case, we asked them about their outcome expectancies, which I mentioned earlier. What do you expect to happen when you drink alcohol? We asked them about their drink refusal self-efficacy, so their ability to say no, to decline a drink, and we asked about normative beliefs. And as you can see here, essentially, positive expectancies when you ask people in a bar lab at the same time of day are much higher than if you ask them in a lecture theatre. And similarly, people found it much harder to, reported that they found it much harder to refuse a drink in a bar setting as opposed to another setting. So again, a bit of a hint that maybe in our interventions, in our research, we actually need to make context a key issue and always ask, where are you completing this measure? And this obviously has implications for how we might treat people as well. So another thing that we have is in our university, so this is a picture of Edge Hill University. The medical school is opposite through the window. This is our bar laboratory. And this is basically, you can see on the ceiling, there's a camera, and it's kind of a halfway house because it offers a more realistic environment. And you see when people come into the bar lab, they will relax a little bit. They will start behaving differently than they might do in a university. And what we do in this research is we obviously have a more immersive experience to sort of see how that impacts people's responses to tests. But we also actually give people alcohol and, make them intoxicated. And when we do this, it's important to tease apart the intoxication effects or the effects of the alcohol from the anticipated effects from the alcohol. So we know that when people think that they're going to drink alcohol, they will already start behaving a little bit intoxicated. So what we have to do is essentially we have to sort of pretend to give people alcohol. The way we do this, to cut a long story short, is we use tonic water and orange juice to disguise the taste of alcohol. All participants have to eat a really strong minty sweet before they drink either the placebo or the real alcohol. And then we also, over the placebo drink, we will spray with a little mist of alcohol just to sort of make that illusion perfect, so that we can basically tease apart what is due to the alcohol and what is due to the anticipatory effects. And then we can do the usual type of studies that we would do in other ones. But just to illustrate the importance of context, I'm not going to actually talk about alcohol administration research. I'm just going to talk to you about how the smell of alcohol, at least, seems to have an impact on people's ability to suppress these dominant responses I was talking about earlier. So in this study, we basically put masks of alcohol, which were either soaked in vodka or in citrus oil, on people's faces, asked them to complete the go-no-go trial procedure, which I outlined earlier. And we found that basically when people were smelling alcohol, they found it much harder to suppress their responses to alcohol-related stimuli. So again, when you're in a pub or in a bar and there's a smell of alcohol around you, or you go somewhere where people are smoking weed, even the smell, I think, this study indicates, will have an impact on people's behavior. Another strand of research that we've been doing is using smartphones to conduct ecological momentary assessment. So this allows us to assess behaviors in real time, and we can measure where people are, who they're with, and then see in real time, how they think about the substance use behavior in question. So here's just two examples of this. The first one is we've basically asked people these classic, alcohol cognition type questions, and essentially we find that actually the context seems to be more important than, for example, individual level, such as gender effects. So context seems to be more important at predicting how people respond to alcohol related questionnaires than gender or other socio-demographic factors. Similarly, being the context, the physical location where people completed these measures on their smartphone was a significant impact. So being in pubs, bars, or clubs, and within social groups increased both, interestingly, positive and negative expectancies of alcohol. And positive and negative expectancies both increased depending on the amount of alcohol consumed, but only negative expectancies were predicted by quantity. Another study, just to sort of illustrate this issue which we might have with survey researchers. So in this study, we compared real-time consumption reports with retrospective reports. So after a day or after a week, we asked them again, what did you drink over the last week? And we also asked them every day when they were out drinking, what are you drinking right now? And we basically find that participants reported more alcoholic drinks during real-time assessment when they were out and about and they had to respond on their smartphone what they were drinking. That seemed to be higher than when we asked them just in a questionnaire at the end of the week or at the end of the day, what did you drink? We also found that when they were with 2 or more friends versus alone and drinking, that the self-reports were more similar to the real-time assessment. And we hypothesized that this may be because, people might discuss what happened during an event, and this may aid memory recall. And we also found significant impacts of where people completed the assessment to impact the reports. Final slide. So I hope to have at least a little bit convinced you that we need to make context a more central aspect of our research. And I think it's also really important for treatment. So it's no use just developing an intervention in a sort of sterile environment. We need to actually consider, that people are going to go out into the real world again, and we need to prepare them for that shift in context. I think our research does suggest that theory might need to be more sensitive to the real world drinking context, and we need to also take account what happens to people when they are under the influence, and maybe we need some theory refinement that is more sensitive to the context. So basically, we need to always think about the context in which people fill in questionnaires and how that might impact their motives, and also be sensitive to intoxication. And I think this can help us develop more context-sensitive interventions that survive the shift from the laboratory into the real-world settings. Thank you very much for your attention.
Thank you, Derek Haim. Perfect timing. Thank you very much. You just finished on time. Dear participant, as you follow Dr. Derek Haim, he highlighted the importance of context and intoxication in alcohol or any other substance use. Conducting any research about alcohol or any other substance use is, of course, very difficult, as Dr. Derek Haim stated. And they found out at their department by opening up a simulation lab to keep their contact with the context. So it forces the researchers to find out some creative ways, creative methods to conduct any research about substance use. There are lots of questions, Dr. Derek Haim. At the end of the session, I will direct you the question. Thank you very much for your contribution. I will immediately switch to the third speaker from Nepal. So from UK, we move to Nepal and having dear Poojan Sharma. She is not connecting online at the moment, but we will share with you the recorded video of her presentation. Before moving to the presentation, I would like to inform you also about the background of Poojan Sharma. Ms. Poojan Sharma is the founder of Manosamayik Shayata Nepal. She has 8 years of experience in mental health. She is a full-time psychologist at Manmohan Memorial Medical and Teaching Hospital at Kathmandu, Nepal since 2019. She has earned training in psychology counseling training, suicide prevention training, marriage and couple counseling, and trauma counseling. She is certified CBT therapist. She has completed her master's in clinical psychology, and she has another master degree in psychiatric nursing. She's a member of the Rotary Club of Kathmandu. Floor is yours, Pujan Shamara. We will watch your recorded video all together.
Golden opportunity. So today's presentation topic is the changing face of psychoactive substance use in Nepal, trends, challenges, and solution. Psychoactive drugs are substances that, when taken in or administered into the one system, affect mental processes, perception, how we perceive and interpret the stimuli, consciousness, cognitions, higher mental function process like attention, concentration, decision making, problem solving, or mood and emotions. Psychoactive drugs belong to a broader category of psychoactive substances that includes alcohol and nicotine. Production, distribution, sale, or non-medical use of many psychoactive drugs is either controlled or prohibited outside legally sanctioned channel by law. The focus of psychoactive substance use and laws in Nepal has evolved significantly over the years. Historically, Nepal has dealt with issues surrounding the use of substances like alcohol, cannabis, and other drugs, which have cultural and historical context. Commonly used psychoactive substance in Nepal: cannabis, which is called gaza in locally our language. Widely used for recreational and medicinal purposes, it has long-standing cultural significance in Nepal. Alcohol, a commonly consumed psychoactive substance with various traditional and commercial beverages available. Upwards, this includes substances like heroin, which have seen increased use and associated health issues, particularly in urban areas. Methamphetamine, known locally as Java, its use has risen especially among younger population. Prescription medication. There is growing misuse of prescription drugs, particularly benzodiazepine and painkiller. Cocaine. While less common than the others, cocaine use exists particularly among affluent individuals, khat or quad. Although not widespread, it is used in certain communities for its stimulant effect. Other stimulants, various local herbal stimulants and energy drinks with psychoactive properties are also used. Prevalence and trends of psychoactive substance use. Alcohol. Prevalence. Alcohol is widely consumed across various demographics. It is socially accepted in many communities with both traditional and commercial forms available. Usage trend. Increased consumption among younger adults and urban population has been noted, along with concerns about the binge drinking. Cannabis. Prevalence. Cannabis use is prevalent particularly among the youth and in rural areas. Its cultural significance contributes to its widespread acceptance. Usage trend. There is ongoing discussion about potential legalization for medicinal and recreational purposes, which may influence future usage pattern. Opioids prevalence. Opioid use, including heroin, has been a growing concern, particularly in urban areas. There are reports of increasing addiction rate. Usage trends. Rising prevalence linked to the availability of illicit drugs and the misuse of prescription medications. Methamphetamine prevalence. Increasing prevalent, especially in urban areas and among younger population. Non-locally as Java, its use has raised significantly public health concerns. Rapid use in popularity, particularly among students and young adults. Cocaine. Cocaine use is relatively low compared to other substances but exists primarily among affluent individuals in urban centers. Limited but growing awareness and availability is the trends often linked to international trafficking. Benzodiazepine, increasing prescriptions. There has been a rise in benzodiazepine prescription, particularly for anxiety and sleep disorder. Concerns about the dependence. Long-term use can lead to tolerance, dependence, and withdrawal symptoms, raising concerns among the healthcare provider. Comorbidity with opioids. Co-prescribing benzodiazepine with opioids has become a significant public health concern due to increased risk of overdose and respiratory depressions. Current trends highlight the need for careful prescribing, patients education, and consideration of alternative treatment options to mitigate these risks while ensuring effective pain and anxiety management. Government of Nepal has established Department of Drug Administration in 1979 to implement and fulfill the aim of Drug Act 1978 and various regulations under it. The National Drug Policy 1995 focused on establishing coordination among government, non-government and private organizations involved in these activities related to medicine production, import, export, storage, supply, sales, distribution, quality assessment, regulatory control, rational use and information flow. Recent trends indicate that synthetic drugs are now replacing the natural and semi-synthetic drugs that have been abused over decades. The emergence of new psychoactive substances have posed a difficult challenge for the government as well as law enforcement agencies in the region. The information on the new psychoactive substance trafficking and its abuse patterns and trends is very limited and not widely of high level to policymakers for taking informed policy decision. Nepal has promulgated the Drug Act 1978 to prohibit the misuse or abuse of medicine and allied pharmaceutical products as well as false or misleading information relating to efficacy and use of drugs, and to regulate and control the production, marketing, distribution, export, import, storage and utilization of those drugs which are not safe for the public use, efficacious and of standard quality. To implement and fulfill the aim and objective of Drug Act 1978 and various regulations are made under it. Legal framework. National Narcotic Drugs Control Act 1976. This act regulates the use, sales and distributions of narcotic substances. It includes prohibition for both penalties and rehabilitations. Drug policy. The government has been working on comprehensive drug policies aimed at reducing substance abuse and promoting public health. Treatment and rehabilitations. Public health initiative. The government supports for various rehabilitation centers, often in collaboration with NGOs, to provide treatment for substance use disorder. Community-based program. There are programs focused on harm reductions, including needle exchange and education on the safe practices. Awareness and education. Public awareness campaign. The government along with NGOs conduct awareness campaign to educate the public about the dangers of substance use. School program. Initiatives are often implemented in the schools to educate young people about the risks associated with the drug use. Policy development. Interministerial coordination. Various ministries including health and education coordinate to develop comprehensive strategy for drug prevention and treatment. International collaboration. Nepal collaborates with international organizations like United Nations Office on Drugs and Crime UNODC for capacity building and policy development. Law enforcement. Drug enforcement agencies. The government has a specialized unit for the enforcement of drug laws focusing on trafficking and illegal trade. Balanced approach. Efforts are made to balance law enforcement with public health approach, emphasizing treatment over punishment. Research and data collection. Surveillance and research. Government along with academic institutions conduct research to better understand substance use pattern and to inform policy decisions. Challenges. Despite this effort, challenges remain, including stigma. Social stigma around addiction can hinder individuals from seeking help. Limited resources, rehabilitation facilities, and treatment programs often face resource constraint. Access to service in rural areas, access to treatment and preventive service is limited. Nepalese government continue to evolve its approach to substance use, emphasizing a more health-oriented perspective while balancing the need for law enforcement. Factors contributing to substance use. Socioeconomic factors, poverty, unemployment and access to education, cultural influence and peer pressures, mental health issues and trauma. Stigma. Challenge in addressing substance use. In this, stigma and misconceptions surrounding the addictions, limited access to treatment and rehabilitation service, especially in rural areas, inadequate law enforcement and regulatory framework. Conclusion. Overall, psychotherapy is an effective component of the management of psychoactive substance use in Nepal. For the curative management, its success largely depends on the supportive environment, accessibility, and the integration of culturally sensitive practices. Continued effort to raise awareness and reduce stigma are essential for maximizing the impact of psychotherapeutic intervention. Thank you so much for hearing me. Thank you so much and namaste.
About psychoactive substance use in Nepal and some prevention methods adopted in Nepal. So we ended up the presentations. Now it is time for the question and answer session. We got several questions from our guests. Around 369 listeners are with us today. So they are following us and directed some questions to our respectful speakers. The first question, there are several questions for each presenter, but I need to also manage the time. Because of that, I will ask one question for each presenter first. Depending on the time usage, I will add the other questions as well. For Hande Çelikay, we have 3 questions listed on my computer. The first one, how can we psychologists help family members, relatives of clients in such extreme cases of violence?
İlk olarak şeyden bahsedebilirim. Çalışırken psikoeğitim bu
First
anlamda
of
çok
all,
etkili
in
oluyor.
terms of psychoeducation,
Psikoeğitim
psychotraining,
içerisinde iletişim becerilerini geliştiren
communication
oturumlar oluyor.
skills.
Bu oturumlarda
There could be different sessions to improve
doğru
communication
iletişim yöntemlerini
skills.
öğretiyoruz.
Right communication
Ortaya
skills
çıkma
will be
olasılığını
taught.
azaltan bir yöntem.
And of course, this will
Aileler
decrease
doğru
their
iletişim
attention
yöntemleriyle
for some other
yaklaşımlarını
focus points.
sağlayabilmelerine. Şiddet olaylarının görülme ihtimali zaten düşüyor ama bunun haricinde
In
atıyorum
addition,
suç noktasına varacak bir durum söz
maybe it
konusu
can go up to
tabii ki daha farklı
crimes, and
yaklaşımlar
then
var.
of course
Yönelme
there is a need for different behaviors, different approach. And of course we need to protect the relatives, the families as well.
bahsettiğim vakada
For example, I mentioned the
psikoza ilgili bir
case,
durum vardı.
and there was
Sonuç ne kadar
psychosis,
ve
and
psikozunun
we
günler
know what
süre
happened at the
etkilediği
end.
var
During the
bir
treatment of psychosis,
ama
that happened.
her zaman bu tür olaylarla
Of
mı
course,
karşılaşıyoruz? Hayır.
this would not be the
Eğer
case
doğru
all the time.
tanımlanırken bağımlı tedavi sürecindeyse
If
hem aile tedavi sürecine
there will
dahil
be the
ise
treatment, and if the
bildiğimiz
family is also
yıllardan
included within the scope of the treatment, according to the statistics, the probability of the patient to be clean is going to increase if there will be psychotraining.
meydana geliyor. O yüzden de ailenin
For
tedaviye
this
katılımı
reason, contribution of the family to the treatment is so essential. When we start talking to a client, of course, we have structured psychotraining and we recommend them, the family members, and we try to follow them. I hope this answer will be sufficient.
Thank you, Dr. Çelikay. I will direct the second question to Dr. Haim. How do types of behavior vary culturally? Can we consider behaviors that may vary from country to country in a universal cluster?
That's an interesting question. Thank you. So traditionally, there's been big divides between cultures. So, for example, in alcohol consumption, we tend to distinguish between Northern European drinking styles and Southern European drinking styles. And similarly, obviously, we've got different substance use behaviors in different countries. So in Iran, for example, substance use behavior where alcohol is and Turkey, I imagine, is less prevalent, will differ obviously very strongly. I think that the one thing that is happening though, and I think the internet and social media and everything is partly to blame for that, is that actually we're seeing a homogenization of cross-cultural trends. happening. So actually, use patterns are becoming more similar across cultures than they have been in the past.
Okay, thank you. We have still time, so I will direct another question for Dr. Haim. Is it possible to reshape the individual's perception of the context instead of changing the context for tackling addiction? Which techniques would you recommend for this?
Okay, I think essentially, if you think about what psychological treatments do, essentially they're all about changing people's perceptions. So, for example, if we do cognitive behavioral therapy and someone comes to you and says, "Oh, Billy at school, Billy, the nasty boy, Billy is bullying me," you might say to the child, maybe it's because Billy is unhappy. So I think all types of therapy to an extent try and persuade people to view the world differently, to interpret the context differently. And we know, for example, that many contexts are ambiguous. So it's not always clear whether, for example, uh, um, I am watching Piami watch me at the moment, and it's a bit ambiguous as to whether or not he finds what I'm saying interesting or not. And so I suppose another task that therapy can do is try and shift or shift perceptions to sort of encourage people to, focus on the smiles, focus on the positives. So to sort of try and interpret what are mostly ambiguous contexts in a way that's maybe more healthy.
Okay, thank you, dear Derek. I will direct another question to Dr. Çelikay. How do you think the treatment course for methamphetamine compares to other substances?
Metamfetamin grubunda birazcık daha zorlayıcı bir süreç olduğunu düşünüyorum.
It could be
Çünkü
challenging
bütün
for
maddeler
methamphetamine
değil ama bazı
because we
maddeler
cannot say
özellikle
all the
ağırlığı
substances,
özellikle
but for the
kalp tedavisinde
treatment,
çok daha iyi
of
noktalara
course,
gelinebiliyor.
sometimes it can be better
Dolayısıyla
with medication, but
toplum
for
ya da
psychotherapy,
insan
there could be
müdahalesi
kind of
metamfetamin
withdrawal,
kullanımı
or
birazcık daha
for
zorlanılan
methamphetamine,
bir durum var.
it could
Sebebi
be a little bit more
bağımlılığa
challenging
hızlı bir gidiş olması.
because they
Yani
the
birkaç denemede
patients are
bile
having
bağımlılığın geçişi hızlı
awareness,
olması, nükslerin daha yoğun
and
olması.
relapse
Bu
can be
süreçte
higher,
aile desteğinin diğer bağımlılık türlerinde de mutlaka var ama
and
çok daha önemli olması
family
biraz
support
zorlayıcı
will be
olduğunu
much
düşünüyorum.
important. That's
Bunun
why it's
yanında da
challenging.
sosyal
In
tehlikelerinin
addition,
yüksek olması, örneğin suça bulaşmanın diğer
for
madde türlerine
example, crime
kıyasla daha
rates
sık
can be
gözlenebilmesi,
higher when there is the use of
ya da
methamphetamine,
hırsızlık,
or
yağma ve diğer suçlarda
theft
maalesef
can
metamfetamin
be seen.
kullanımlarında
I
daha
mean, some
yüksek
other
şekilde
crimes can be
gözlenebiliyor.
seen when there is the
Bir de baktığımızda
amphetamine
psikiyatrik
use.
rahatsızlıkların
For
semptom
psychiatric
grupları
disorders,
metamfetamin
also the
kullanımı
hidden
yıllarında çok daha
symptoms
hızlı ortaya çıkabiliyor.
can be
O
seen
nedenle çok da
faster
örgütlü hareket
in
etmek
those
gerekiyor
users. For
metamfetamin
this reason, you need
hastalarıyla
to be well
çalışırken.
organized if you're working
Ve
together
benim
with such
gözlemim,
patients. And according to my
sayıda olmayan bu kadar
observation,
bilimsel
of course,
verileri de
based on
söylemek
figures,
lazım ama
based on evidence, of
ekonomik
course,
anlamda
I
çok
may
daha
express together with
geniş bir
scientific
örnekleme
evidence, but
yayılmış durumda.
first, we know that there
Yani
is a
hani
wide
geçmişte
spectrum of sampling. In the
mutlaka birçok
past,
maddede eğitim
we
düzeyi
know
daha
that
yüksek, sosyoekonomik düzey daha yüksek
socioeconomic
kişilerle daha fazla
level can
kullanımı
be higher
karşılaştırılsa da
for
metamfetamin
substance use,
kullanımında
but for
suçu
methamphetamine
olmadığı
use,
kadar benim
we
karşılaştığım
know
hasta
that
grubu eğitim düzeyi
the
yüksek olan bir
patients
grup,
that I
sosyoekonomik
come
düzeyi yüksek
across,
olan bir
they
grup.
have higher
Tedavi
socioeconomic
olanakları anlamında
level. And for the
olanaklara
treatment
erişim
opportunities,
olanağı
they
daha
have
yüksek
much more
olmasına
access
rağmen
to
yoğun yaşayan bir
to
grupla
those
karşı
services,
karşıya
and
kaldığımızı
they
düşünüyorum
still
ama bu
come
beni
across
takip
with
ettiğini
the
düşünüyorum.
relapse at a higher level, but this is my personal
O yüzden
opinion
de
though.
çok
For
daha
this
etkili tedavi
reason,
yöntemlerine
there
mutlaka
could be much more effective treatment methods.
bu
Motivation
anlamda da
can
kendimizi
be
psikoterapist anlamında da geliştirme anlamında daha
highlighted more,
yoğun
and
hizmetlere ihtiyaç
also
duyduğumuzu düşünüyorum.
we will be in need of much more different practical approach.
Okay, thank you, Dr. Çelikay. We have still time, and I will ask, if you don't mind, Dr. Haim, the third question coming from our listeners. Do you consider self-report scales sufficient in the context of substance abuse studies?
I think they are probably the most easy way and to assess. And I think if they're used correctly, they're probably just about sufficient for everyday use. However, I would urge people conducting research to try and, wherever possible, supplement self-report scales with other measures, for example, observations or peer reports. And I appreciate it's not always possible to have a smartphone app and to collect data in real time. So I think they are probably sufficient for a lot of what we do, but they're not perfect. And I think we need to be more, we need to move away from thinking about responses to questionnaires, and to be fair, also responses to interviews that these are completely context free and that people don't have motivations and want to present themselves in a particular way. They're not exactly summaries of truths. We just need to be sensitive to the fact that people want to present in particular ways for particular reasons, for particular motives, and we need to better understand how people might change how they present themselves, I suppose. So it's a bit of a yes and no answer, I suppose. I apologize for that.
Okay, okay. Thank you very much for your answers. We concluded this session with the question and answers. I would like to thank all the presenters coming from the UK, Nepal, and from Turkey, and also all the listeners, around 370 participants joined us today. Thanks for contribution as well with the question. And I leave the floor to Rumeysa.
I would like to thank our esteemed session chair and the distinguished speakers for their valuable contributions and the valuable insights shared with us in the last session of the Congress. It was great to hear from you. And after concluding the question and answer part, we have now reached the end of the first day of the Congress. Distinguished guests, I would like to thank once again to all of our professors and participants for being with us at the Congress today. International Congress on Psychoactive Substance Use Disorders will continue to address many challenging issues with invaluable participants, guests coming from different parts of the world on its last day tomorrow. Have a nice day and hope to see you again tomorrow. Esteemed participants and distinguished speakers, Green Crescent continues to tackle addictions that threaten our future for more than a century. It continues its prevention and intervention activities both nationally and internationally with great devotion to bringing good and healthy living habits to society. In addition to the addiction prevention activities it carries out, especially for children and youth, Green Crescent also makes its presence felt strongly in the field of intervention in 107 Green Crescent counseling centers and 2 Green Crescent rehabilitation centers in Turkey's all 81 provinces and the Turkish Republic of Northern Cyprus. Welcome to the second day of the International Congress on Psychoactive Substance Use Disorders. On the first day of the Congress, we'll listen to presentations by many valued speakers from leading institutions and organizations on current practices in psychoactive substance addiction, impact of the psychoactive substance use, and the studies on tackling addictions. And we were informed about the current development. As yesterday, valuable speakers in their field will be also with us throughout the day, and I hope the second day of our Congress will also be very productive. Today's program consists of 1 keynote speech and 3 sessions and one closing session that is 5 sections in total. Each session will last approximately 60 minutes to 75 minutes. Your questions will be answered at the end of the session under the supervision of our session chairs. Please do not hesitate to send your questions to us through the chat section. Before we proceed this session, I have a few reminders. The first one is about the participation certificate. These certificates will be accessible through the Get Participation Certificate button on the conference website. Please do not forget that only registered participants and attended the live broadcast will be able to generate an e-certificate using their registered emails. And the second reminder is about the language of the Congress. The Congress will be both held in Turkish and English. You can set the language you are aiming to follow the Congress by using the language button on the screen. Today, our program starts with the second keynote speech of the International Congress on Psychoactive Substance Use Disorders. Dr. Hamaz Al-Ghafri, who is president of International Society of Addiction Medicine, will deliver a speech chaired by Professor Rabia Bilici from Istanbul Ticaret University. Dr. Hamaz Al-Ghafri will be with us today with his speech entitled "Implication of Public Health in Addiction Science." I would like to welcome our esteemed session chair and the distinguished speaker. And without further ado, I kindly leave the floor to the session chair, Professor Rabia Bilici, to kick off the second day of the Congress. The floor is yours.
Thank you, Rumeysa. Ladies and gentlemen, esteemed colleagues, good morning and welcome to the second day of the International Congress on Psychoactive Substance Use Disorder organized by the Green Crescent. It is my great honor to introduce our keynote speaker for this morning, a distinguished figure in the field of addiction science and public health. Joining us from the United Arab Emirates, we are privileged to have His Excellency Professor Hamad Al-Ghafri. Dr. Hamad Al-Ghafri has over 30 years of experience in public health, service planning, and management in the UAE. Until his retirement, he was the Director General of the National Rehabilitation Center Abu Dhabi, a WHO collaborative center for substance use prevention and treatment of substance use disorders for 13 years. Internationally, he is currently the chair of the International Society of Addiction Medicine, past chair of the global think tank Expert Dialogue on Drug Demand Reduction, and was the vice president of the Arab Federation for Drug Prevention until 2005. He is also a board member of the International Consortium of Universities for Drug Demand Reduction, ICUDDR. He is an emeritus professor at the Faculty of Medicine, Jordan University of Science and Technology, and an adjunct professor at the College of Medicine and Health Sciences, United Arab Emirates University. He was the chair of the commissioners of the Global Center for Credentialing and Education of Addiction Professionals, GCCC, of the Colombo Plan. In recognition of his contributions, Dr. Al-Ghafri was awarded the Sheikh Rashid Award for Science and Culture in 2 different times. And also he received the honor of lifetime membership of the American Society for Addiction Medicine. On a personal note, I had the honor of working with Professor Al-Ghafri at ISAM, and thanks to his great support, we organized the ISAM Congress in Istanbul this year under his leadership. And I also know that he loves Turkey very much, which made this collaboration even more special. Today, Professor Al-Ghafri will discuss the implication of public health in addiction science. This important topic will help us understand how to create effective strategies for addressing substance use disorders. His knowledge and insights will inspire us to consider the vital role of public health in our work. Now, please join me in warmly welcoming His Excellency Professor Hamad Al-Ghafri to our virtual stage.
Well, thanks a lot, Professor Rabia, and thanks first of all, for inviting me on the Green Crescent conference. Honestly, you know, the great presentation of the ISAM Istanbul, you know, earlier, and the presence of the Green Crescent, the presence of our colleagues from Turkey, the presence of professionals, people that we learn from their experience, was adding up to the base of knowledge. And today, you know, with your help, Professor Rabia, I'm trying to, you know, had that concept of public health and its relation to addiction, you know. On my presentation, I'll be going very smoothly, but please, you know, feel free to have your own question being ready for asking any time. So I'll be going on our learning objectives on what is the international status, what is the public health approach, if there is any public health approach, what kind of social determinant and harms and benefits for this approach, what is the society's approach in general, and what is the continuum of care that we are doing everywhere and we are working within. One of the most important things that we need to concentrate in our field is the importance of having a capacity building and evidence-based training programs for our professionals and where we are going towards the future. So basically, if we start with the international reports, again, the United Nations General Assembly special session on drugs on August 16th, it recognized drug addiction as a complex multifocal health disorders, which is chronic and relapse, have got, the characterized being chronic and relapsing condition, but it is preventable. And this is one of the most important things that we need to concentrate on the public health point of view. It's a treatable and not the result of molar failure or any chronic behavior or chronic bad behavior. And this is where we need to distinguish how we go in, dealing with our patients. It's a global health concern, yes. It's historically most nation, addiction strategy work on punishment, unfortunately. And this need to be required to be shifted to another approach, which is called the public health approach. There is a very good paper that had been produced from the Canadian Public Health Association, and it was discussing on managing an illegal MBS, it shows that there is a growing evidence, awareness, and acceptance that both prohibition and criminalization are not achieving their intended objectives and reducing the drug use and associated harms. And this is where we are, going to highlight our presentation in it this morning. Again, the U.S. Surgeon General, these are the major, report international, which, talk about the public health approach. And it shows that there is an evidence-based behavioral and pharmacological treatment can be effective in reducing substance abuse and improving the outcome of the criminal justice involvement. Again, and in the addiction science, unfortunately, our work is related also to a certain extent with the criminal justice system and involvement, and we need to make sure that we are, working in collaboration with our colleagues on those fields. Integrating programs, programs like in prevention, treatment, and recovery. Most of the treatment programs that we are having, either treatment by themselves or recovery by themselves or prevention program by themselves, and they go on, unfortunately, on a parallel line. They don't interact with each other. So having this kind of combination of programs with the rehabilitation and integrating it into the larger health system would increase the access to care. And this is one of the most important things. As you know, all the World Drug Report tackle this point that the access to care is very low, almost 1 in 7 for male and 1 in 18 for females. And again, despite that there is no even a professional staff to treat and to provide that service. So having all of these within the health system will increase the access to care, improve the quality of the service being produced to the patient. And finally, having a proper recovery support services and programs also will help patients in sustain their wellness and decrease the relapsing rate. We know, all of us, that the World Drug Report and the last one that had been produced on 2023 for the year 2021, it shows that there is an increase in number of 5.8% from the global population. I remember, years ago that 5.8, it used to be 3.7. And God help when it's going to be even more. And it shows also that there is one in every 17 people, they use drugs over the past 12 months, which is there is an almost 23% increase all over. So an estimated of 13.2 million people were injecting drugs. And when we said injecting drugs, we are going towards hepatitis, we are going towards HIV, and there's a huge complication out of it, and that will lead to increase the mortality, the morbidity, the mortality. At the end of the day, it will increase even the cost of treatment, and it will affect on the economy of each country. Cannabis continued to be the most drug used internationally, with a percentage of almost 4.3% from the global population. And again, the MBS, there is no control on having that number to be, even controlled or stopped. It's going up and up. And unfortunately, again, I always say there is an imbalance on the, control on that strategy between the prevention, treatment, and rehabilitation programs, and unfortunately, the drug black market on that line. Again, there is a growing evidence use of the internet and other digital means of communication, including the dark marketplace. We'll be talking about it today. Social media platforms. Nowadays, we need to educate ourselves. We need to, almost work in equality with the new modalities of unfortunately, illegal use of the proper service that's been available internationally, like the internet, digital means of social media. And again, despite the significant challenge, the availability of reporting data, there is again a huge treatment gap. And this is one of the most important things, almost where 1 in 7 for men and 1 in 18 for women only received proper treatment. And there's an international. When we go to every, international World Drug Report, when we go to every regions, even the percentage increase, because some of the countries, and I'll be mentioned later on, that they don't have even a professional service being provided for those patients. WHO Sustainable Development Goals specify, the goals of universal health coverage, and one of the most important things is to increase the treatment coverage of substance use disorder. And in order to do that, we need to have a proper training programs, proper education system, proper professional development system for our personnel in order to take them forward. When we'll be going to the public health approach, there is no as such definition for that approach, but there is, a lot of papers been talking about that approach. And that approach, we can have it within a combination of history of political ideology, culture, religion, economics, health, social consideration, pharmacological category of substance being managed. It's an approach, again, when we say public health approach, we have been in the disaster of Corona. And the public health at that time show the importance of having, the combination of the multidisciplinary teams being working together in such a work. And this is where we are going towards, I'm always, relating, the epidemics of Corona to the epidemics of addiction. Do we have an addiction epidemic? Yes, and it's continuous. We don't know yet the number of people that have been died from addiction problems all over these years. None been done, but in Corona it's been almost known. If we compare both strategy to each other, we'll find even addiction is much more worse. So the public health approach, it's provide an organized, comprehensive, multi-sectorial effort directed in maintaining and improving the health of the population. Again, it's aimed to the health and wellness of all population members and reducing the inequities between the population. We know very well that there are some marginal peoples, some marginal categories of individuals. They don't have even the access to not a proper service, but at the minimum level of service. The public health approach, it's based upon the principle of social justice, attention to human rights, equity, evidence-informed policy and practice, and underlying the determinant of health, which we are going to talk about it. The approach also could include the following strategies, but it's within the health promotion, the health protection, prevention, harm reduction, population health, assessment, disease, injury and disability surveillance, evidence-based services to help people who are at risk of developing problems with substance use. Again, it's a combination. When we say a public health approach, it's a combination of holistic model from a holistic model surrounding the individuals, surrounding the family, surrounding the community, and a larger space going towards the nationwide. The World Health Organization approach, again, they define the public health approach on the WHO. It's organized across 5 domains: governance, and this is one of the most important things. The laws working on that field have to be, helping and supporting. At the first line is the patient towards having his own, service, treatment, rehabilitation, and prevention, and so on. The health sector response, so we are talking governance on general, the response for our health sector and supporting that kind of sector and providing that service to the people. Again, the promotion and prevention, this is a huge programs that we keep talking about it, but it's need a lot of resources, resources in terms of manpower, in terms of financials, and so on. Monitoring and surveillance, and this is one of the most important things, especially in our part of the world, where we may do a proper monitoring system, but the surveillance is not. Most of the countries, they are lacking a proper monitoring and surveillance system. So unfortunately, the decision-making process won't be clear on the magnitude of the problem, distribution, and where that problem is and how to tackle it. And lastly, within the WHO, it's decide on the international cooperation. Our field does not work alone. It does not need anybody to work alone. It's a combination. It's a help. It's a collaborative work being done all over the world, and we learn from other people's responses and from the international agencies. This is how we progress within our field. The next slide is about what is the facilitators and the risk to the public health response. On the facilitators and the barriers, we do have values and principles. So many people's, so many values within communities. They work on having, helping, supporting, that line principles. If the public health approach has been, approved in certain countries, so it's going to be more. Economics, again, nowadays we do have, and I'm going to talk about it in a minute, we do have, the economical part where there is a regulation been added for the industry in some countries, taxation, some other countries, infrastructures, laws and regulation, and this is one of the most important things which help, facilitating these kind of programs internationally, the programs and the projects, international convention, leadership, evaluation, and research. So all of these could be applied towards having facilitating the public health approach, or another way could be a barrier. It's at the end of the day, it's the nation decision on where they would like to be, where they are going to be held, and what is their situation now, so they can decide upon. Some people, they go for the public health approach on all over, and this is going towards something called the commercial interest. So there is a commercialization from that approach where they will be having that kind of businesses open and legalization and decriminalization of utilizing certain substances, which lead to an increased taxation. And again, this is another income for countries. So basically, on having such approach that need to be done, it requires continuous vigilance concerning this risk and comprehensive regulation to avoid profit-driven production. At the end of the day, we are serving the community, we are helping the community, we are not doing business, we are not having an income from those things I'll be talking about, the decriminalization, legalization of cannabis and its results in certain countries. But again, there is, a huge gap that we need to make sure that we are doing it in a proper way. The social determinant of harms and benefits. The social determinants of harm of health, such as poverty, homelessness, unemployment, lack of social support, it's play an important role in determining the health consequences of any substance use. We need to make sure that, in every country, having poverty, homeless, having this kind of high-risk factors, it may lead to, yes, substance abuse, and the consequences of it may lead to the severity of it, as have been mentioned by, our colleagues, Professor Tom McLennan. But again, we need to make sure that, every country have got its own way of approaching the problem itself internally, an internal level as first, on an external level, a second line. Again, substance abuse is mediated by the interaction among the supply and demand. This is a business, unfortunately, and we know very well it's the third income after the oil and the oil industry and the other industry, which is unfortunately the military industry. So the third one, it will come the drugs, unfortunately. So the supply and demand, whether it's available or not, accessible or not, context, social norms, laws and regulation that activate these activities, and the interaction of these determinant on the consumption, use, and pattern result in the harms and benefit. Again, if I know very well, maybe it's first time being introduced. By the way, this is a presentation I should did it in ISAM Istanbul, but I delayed, and thanks that I'm doing it again on the Green Crescent Conference. So all of these determinants lead to the severity and the harms of where we are heading towards the current situation. So we need to control on the supply. We need to make sure that there is, decrease the supply, decrease the demand, make sure that, and this is actually, by the way, where other colleagues, not only from the health sector, from the criminal justice system, from the drug enforcement agencies, and other colleagues have to work with us and have to interact with us. The problematic substance use and dependency is strongly associated with the history of the early physical and psychological trauma, unfortunately, such as mental and physical distress, peer influence, dependency, physical and sexual abuse, abandonment, and comorbidity involving mental health and substance dependence. We know very well that, in every society, they do have some kind of, we don't see it a prerequisite for substance use and leading to a problematic use, but there is some kind of an early indicators that we need to identify in order to make sure and to prevent the substance use disorders and dependency and its complication. So the scientific understanding of those determinants of problematic use associated with harms consistently to the interaction of genetic, psychological, and social factors. Society's approach. Again, we know very well that most of the societies, they go towards punishment, they go towards the legalization. Some other societies, they go to a public health approach. Over here, I'm going to talk about over here, I'm going to talk about the paradox of prohibition, and we see from that society's approach, if there is a public health approach, there is a good market regulation. But when we go to the X and Y column, we'll go towards the health and social problems. When we have the illegal market, the extremes of every approach on the prohibition and the legalization and the free market, it leads to an increased level of harm on both sides, unfortunately. So there must be some kind of a controlled approach and the public health within the government. Again, this is what we are talking about. And it's a combination of laws, regulations, policy, strategy, and so on. So the prohibition approach, it's aimed to deter and prevent all substance use through the formal and informal sanitation, including criminalization and interaction. This approach lead to, unfortunately, the prohibition approach lead to fuel the growth of illegal markets, organized crimes, violent injuries, and the death of user, dealers, and police, and so on. So this is, again, the last, unfortunately, the drawback of the prohibition approach. The public health approach, or the commercialization approach, is less restrictive, but again, it's leading to a free market availability of those drugs, and it's lead to also a complication of those drugs later on. None of them is effective, by the way, in preventing substance use-related mortality and morbidity. This is a very important thing that we need to highlight it and make sure that it's a matter of weighting up the things together. Our friend Robin Room, in one of the books that he talked about something called the public health, the public good, and the drug policy. And over here on the second part of the presentation, I'm going to talk about very quick on certain aspects that need to be highlighted, and the decision-maker process need to be involved with us in it, which is the first of all is the economical impact of addiction, the policies, and then I'll be talking about the cannabis and the ways of positive and negative of it, the internet nowadays, the clear web, dark web, the deep web, unfortunately, morbidity, and the barriers to treatment. From this slide, I think drug abuse costs 2 to 4% of the GDP. This is the only things I would like to highlight it in this presentation. And I took 2% from that GDP in one of the countries. Actually, a study, I did it in the UAE, in the NRC. And I took that 2% in 1 year, and a study had been done with the UNODC, and it showed that there is a huge number of costs, unfortunately, have been lost. And I compared that 2% to the current status of the project in the UAE. And it was very highly shown that the 2% is, I compare it with the current project that, our decision makers, our economical policy makers knows exactly and recognize that big problem that we do have. And it showed that there is a huge, loss. And the majority of that huge loss was due to mortality, morbidity, mortality, loss of productivity. And by the way, the health and the social sectors, the criminal justice system, and the whole drug enforcement agencies working that we are doing is nothing compared with the loss of productivity and the mortality of individuals. Again, that's, you'll have your time in reading it in order to just to save the time. I'm seeing my time is going on. Policy interaction. On this slide, if we go to number 1, the risk factors, this is where we are. We have to work on breaking that cycle. And this cycle of marginalization and drug use disorders, we break it with, policies need to be interacted and need to be done and need to be, inserted on every type of, for example, the risk factors, employment, low level of education, homeless, violence, sex workers, incarceration. We need to have a policy being inserted over here into modifying these kind of risk factors, working with it. Again, drug use disorders, we need to have a proper treatment care, proper treatment rehabilitation care need to be inserted and modified on that time. On that sector, if there is any additional risk factors or tertiary problems with the patient, like comorbidity and other problems, we need to also to work on that kind of additional factors and provide the service that being provided in. So the policy, this is only an example that had been produced a long time ago by the NIDA. Nowadays, that margin is, and that circle is being bigger and bigger, and it's lead to increase, the level where the policies are interacting with each other. Legalization and decriminalization of cannabis. There is a positive view, and over here I'm not saying my own opinion in it. I'm just having the views that have been done on the literature, and the countries that have ended the criminalization of drug use and have generally been better able to cope with injection drug-related HIV and AIDS. They say from their own side, decriminalization bosses and investing in treatment and harm-related services, and it can provide a major benefit from the public, including reducing the number of people incarcerated, increasing the uptake of drug treatment, reducing the criminal justice system costs, redirecting the resources from the criminal justice system, redirecting the law enforcement resources, and so on. So they see things from their own side, on the papers that have been produced by Hughes and his colleagues, on that it leads to decrease the economical costs and so on. And this is from their interaction and from their own views. The other views, which is on the negative point side, cannabis legalization in the North America appear to be increase the daily cannabis use. Yes, especially the potent cannabis. There is with that use, there is an increased level of production. There is an effect on the public health. There is an effect on the economy. There is a lot of effect on the driving, and we do have, but we don't have any problem by itself. It's always coming on interaction. There is an increase of illicit market. There is, harassment. There is a lot of arrests, a lot of criminal justice system and crimes. So plus, which is, there is the carbon footprint. So there is a lot of production now for indoor cannabis that we need to make sure that we don't reach, in our countries and our part of the world, we may not reach that level of, that level of problems. But, we don't want also to reach it. We don't want to have that in our mind, that we don't want to reach it in order to prevent our societies. So legalization has also increased the tax revenue and generally reduce the arrest rate of cannabis. So this is both sides. This is, again, our colleagues, Professor Targa Gawad presentation, and I took it from him in a way that, he summarized that line of negative legalization and decriminalization of cannabis. Internet, all of us, we interact with the internet. We work on the internet on that side, which is the infrastructure consisting of our standard data that we are reaching it. Again, there is other side, which is the clear web, the surface web, where we are working with the social network, public pages, profiles. But on the time of Corona, there was something called the dark web, dark net. People, they have their own, networks where they can interact, and having a specific software and configuration where they can often reach the those protocols. They can reach their production, their producer and their distributor, unfortunately, and it come directly to our homes. The deep web is another process which have been utilized nowadays by the online banking, social networks, restricted page profile. But nowadays we need to make sure, and we need to educate our colleagues from the drug enforcement agencies about, that new modalities of having, delivering, unfortunately, the drugs to our homes through the internet. Comorbidity, we know very well that it's comorbidity. Substance use have got a high comorbid rate with anxiety, generalized anxiety disorder, panic attacks, post-traumatic stress disorders. Also, it occurs with other mental illness and disorders such as depression, bipolar, and so on. So we need to make sure when we treat our patient, it's, data show that 56% of our patients, they may come with comorbid. From the 20.3 million adult substance use disorder, there is 7.9 had a mental illness. And from the 42 million people adult with mental illness, we do have 18% also have substance use disorders, and this is from the World Drug Report 2023. One of the most important things we mentioned, who get treatment. So again, internationally, there's 52.5% they receive neither mental health care or nor substance use disorders. 34.5% receive only mental health care. 9% receive both mental health and substance use treatment. 3.9% they receive substance use disorder only. So again, one of the most important things about that is that slide. So we need over here to know what is the barriers, why people they don't come. So 52% they cannot afford the cost. So again, this is one of the most important things. We need to make sure that governments could allow people to access to treatment free of charge, and if there is a charges, it will be within the acceptance limit. 23% they did not know where to go. Awareness. We need to make sure awareness that please come for help, come for treatment, and the law have to support that. 23% could not handle problems without treatment. Handle problem. Again, this is a disease, so it's have to be treated. People have to come either to at least for a consultation. So 13% fear of being committed. Again, some countries within the laws, the people, they may get fear going there, and they may be, for example, reported to the police, to drug enforcement agencies. So again, this is another awareness problem need to be raised. 12.4% might cause, nightmares, have no negative opinion, did not think that treatment would help. All of it's, it's within the raising the level of awareness. Lastly, 10% concerned with the confidentiality. One of the most important things in our services is confidentiality. Surveillance, I talk about the surveillance. This is the passive and the active surveillance. I'll keep it for your own. I think, I'm almost done in time, but I'll be moving very well. But this is a very, very active tools for policymakers in order to know what is the problems, where it's been going. This is a continuum of care. Again, we are in the level of the prevention, talking about universal, it's for all, selective for certain type of groups, or indicated for a certain types of groups on a certain substances. The treatment, here is where we are almost working on the treatment point of view. We are almost lacking the recovery, and we do not concentrate on that line, and the promotion. So basically, it's a continuum of having comprehensive determinant of treatment health system, and this should be done in the whole system of treatment and rehabilitation, and starting with promotion, prevention, proper prevention programs, evidence-based prevention programs, and proper treatment services towards the recovery, and assessing that kind of recovery. Normally we had our patient, we take them out from the treatment centers towards the outpatient clinic, but unfortunately there is no any kind of follow-up later on. So that's, this is actually the details which I already mentioned now, promotion and prevention, the types of programs and its indication. Again, the treatment system, we know it very well. This is one of the most important triangle that we do have, which is about the quality of service needed. So basically, this is where most of the countries are in the informal services, and this is where we need to reorganize our effort in arranging and educating and credentialing those individuals working on that line. And this is actually, unfortunately, this is actually where the cost is low. And this is where the self-care, and unfortunately, it may have a lot of problems raising up towards the community that we don't know. Primary healthcare services, generic social welfare services. This is, again, our colleagues on the health system that also need to be educated, need to be highlighted in working with them, because most of our patients, they either go to the emergency rooms or the primary healthcare physician. And most of the studies shows, unfortunately, little of those our colleagues on primary healthcare services, they knew about addiction, or they're being trained on addiction itself and what to do. So basically, this is where we are working on the specialized drug dependency service. And this is talking about a high cost in this manner. At the same time, the frequency of needed is low. So what we are doing is we are utilizing very highly specialized service with a high cost for a huge number of people. So basically, we need to concentrate on that area of having the first line of first line of having patient on primary healthcare services and the emergency room to be very highly trained and sophisticated. So the filter towards having a tertiary and secondary and tertiary level, it'll be only for those who need that kind of service. That's the level of cares that we do have, and it's been almost disseminated all over the places. Again, having those kind of services is great, but they all need to be followed up. They need to be trained. They need to be people need to be certified, and they need to be recertified from the policy and the governance point of view. This is a clinical care. This is one of the models. Actually, we have been using it within our colleagues in the past days, and then by hands and the NRC, servicing the patient within the patient preference, research evidence, and clinical expertise. Treatment, we know very well about the programs. I'll be going on it very quick with the recovery and capacity building. You can't do all of what we did without a proper capacity building. So basically, we always go on to that session. We need to a full mapping of the workforce. We need to know exactly what we do have, what kind of specialties, what is their numbers, what is their distributions. Are they only psychiatrists? Are they only psychologists? What is the number of them? What's also their distribution and their specialty within the addiction science? And what is their training and education? What is their current status? Again, this is one of the most important things in remapping the workforce, first of all, knowing what is their current status and how to move forward. Credential is an important thing, and Professor Rabia mentioned about the global credential programs that is available internationally now. And later on, we move from credentialing towards the international professional associations. This is where, the role of the Green Crescent and the international agencies working on that field and having that homework. This is I always can say this is a homework that need to be done, but it's a huge work. So what is the available resources international? Colombo Plan, one of the major things, and I'm almost running my time, but there is a full programs, curriculums. Those curriculums that have been, we've been working on it since a long time ago, and it's been translated in so many languages. I hope that, with the help of the Green Crescent, we could always do it in Turkish language. Those curriculums for the prevention, treatment, and recovery, and every for the family, we do have programs for them, curriculums for them, school counselors, workplace, community. All of them there is an available programs, available curriculums, and those curriculums for treatment and rehabilitation and follow-up, we do have for non-drug users. We do have when we go to a drug users level, unfortunately, and lastly, for the secondary prevention for person with substance use disorders. Those programs and those curriculums are available, and they are distributed, and they are free of charge. We worked with them a long time ago with our colleagues, and as you see over here, there are so many languages that have been adapted and translated. Recently, we had the Arabic language being done by our colleagues in the NRC, and this is all the countries that work with us and all the countries that we, had that kind of curriculums being available and available for distribution. A recommendation, again, revising the policies, plans, legislation. It's always good to, see where we are. What's helped, what's not, and having it with the international standard. Again, it's a culture sensitive, religion sensitive, and law sensitive. So all of our things have to be revised. And one of the most important things, we need to allocate specific budget. There is nothing without budget, unfortunately. There is nothing without, a commitment from our colleagues on the decision-making policies point of view. I think that will be all. I hope that I did it on the proper time. I'm a little bit more in time, but I'll be more than happy to have your questions here. So I'm seeing there is a lot over here, but I'll go through.
Thank you very much, Dr. Hamad Al-Ghafri, for your insightful presentations. I really listened to each of your sentences very carefully and learned a lot. We have several questions in the chat box, but first I'd like to follow your recommendations and ask a personal question first.
Yeah.
You recommend us to revise policies, and during your presentations, I understood that for great efforts, we need to work multidisciplinary, so we need strong policies. As you know, prevention works need time to see the outcomes.
Yes.
However, policymakers are not very impatient. They want to see the outcomes quickly. So how can we involve them in the policies of prevention? It is I think, very important part of the prevention because, for example, as a medical doctor, as a psychiatrist, Rabia Bilici, no matter how hard or my friends work hard, if we do not have strong policies, what do you recommend for involving the policy makers in prevention side? Thank you.
Well, thanks a lot. First of all, policymakers at the end of the day, they need to change. And we need to, think on their own mind. So one of the most important things, as I mentioned before, is the economical impact and the cost. Over the years, by any means, in any programs, anywhere in the policies and anywhere in the world, there must be a budget. And that budget, we need to compare. We need to, first of all, educate them, raise the level of awareness about the problem that we do have and the magnitude of the problem and where things could be done and could be low-hanging fruit, so we could work it out. And what is the short-term and long-term? So the public health programs on prevention is a strategy. It's not a single day of work. It's not a very quick. Some of them, yes, we may, because we are aiming at the end of the day is to raise the level of awareness. If we educate people, we raise the level of awareness, we change their beliefs. If we change their beliefs, we change their behavior. And if we change the behavior, we need to maintain that positive behavior. And this is what they call it, we call it promotion the other way. So this is what we call it as a promotion, maintaining that positive health. And every programs, unfortunately, again, the problems of prevention, it's been done by so many people that are not, specialized in, not certified by. And the program itself, again, some prevention programs may harms and communities. They may not only reduce that, benefit. There is a good intention doing these programs, 100%, sure, from all our colleagues. But again, we do it sometimes, we do harm individuals more than serving them. When people are not specialized in that field, they may do it and they may also teach patients how to do things. We know very well some of the media production programs, it's costly, yes, but at the same time, it's instruct people how to do it, and it's been banned and advised to be banned by the WHO. So basically, we educate our policymakers, we decide on what is the priorities we do have. Every nation have got its own priorities. There is, a huge regions priorities and substances. And we need to, by any means, there is something called situation analysis. So in order to know what is the problem in this country or in this region, we need to study the region itself. What is our problem? Is it alcohol? Is it drugs? And if it's go to drugs, what kind of drugs? Is it, prescribed medication? Based upon that problem, if we identify the problem, we can tackle it by itself and having special programs for it. Again, prevention programs by itself, it's a knowledge. So we need to define who's the target group, first of all. What is the problem? Magnitude of it. What is the target group? If the target group, for example, is youth, the language is different. The ways of media reaching them is different. I cannot do it, with a newspaper. I cannot do it in the TV. I need to go to their own mind. I need to go to their own utilization of media that they reach to, their access to. So this is the means of media, and this is a cost. All over this is a cost. And then at the end of the day, I'm going to do a pre-testing for that program. Am I doing it on the right side? If there is any changes within the pre-testing, then I have to change and go back and do it again and correct. And after having that program being implemented from the proper people, again, every program being implemented, unfortunately, sometimes they do it not the proper service, not the proper people. They don't have the proper background. So they may have the right information, but the transferring this information is wrong. By the proper people, I have to go later on for post-testing. Am I did right? Am I change the level of awareness? So it's a continuation of level of services for that prevention programs. And there is, by the way, a new standard being produced by the UNODC on the international prevention programs. But again, I always say that this is highlight programs. We need to go more specifically to our community, to our culture, and adapt those programs to ours. I hope I answered your question, bro.
Thank you very much for this great answer. And I'll try to go to question in order.
Yeah.
The first question is, in your presentation, you mentioned that while women's substance use rate is increasing, their access to treatment is quite limited. What should be done to include women in the treatment system?
Well, again, the treatment system, it's a combination. We do have the governance laws. We have the service being provided, a professional service being provided by a professional people, and then the accessibility of that service to individuals. Again, they said over here in the question, what should be done to include women in the treatment? Women are, over the past decades, all the World Drug reports, if we see the 2023, it shows the information on 2021. Again, the percentage of women to men, the problem with men is higher than women. But again, the accessibility to treatment is important, especially in our culture, in our world. So this is where I mentioned that we need to have some kind of a training for emergency doctors, for public health, public health. By the way, physicians in Canada, they do now work and see patients, primary healthcare physicians. So the early access need to be encouraged. We need to educate those people more in order to see a wider range of people, wider range of services to be provided for people, plus the confidentiality. In our part of the world, it's people, they may have it as a stigma. They don't go for treatment, and they may have problems, especially with women more than men, and its complications. So we need to make sure that those accessibility is there, and we need also to educate our colleagues from the social department, social care services all over the world. They started seeing patients now and referring it to treatment centers or to a primary care physician. So accessibility, confidentiality, plus training is the key. And then we'll go to education and awareness. We mentioned that, there are so many people, they don't go because of stigma, because of laws, unfortunately, because of they don't know where to go. So that's an important role need to be highlighted. So that's, I think, the first point. The second point in World Drug Report, you mentioned that increased substance use following an increase, this increase is there is a global roadmap to reduce the drug or prevent. Well, this is again, what we are doing, within the UNODC, there is a lot of, rules, regulation being done and being approved every year on the Commission on Narcotic Control in order to help to reduce that and to prevent. But again, there is always, I'm seeing here, there is always a highlighted international and there is a small road maps within countries. If we would like to work on our situation, we need to know what we have again. If we know what we have, we know how to tackle it, and then we know how to move as a group on that line. When we say as a group, as a multidisciplinary team within the government to help. It's not, by the way, the work of the Green Crescent, it's not of the Ministry of Health alone. It's a combination of all the people in the community. And by the way, one of the most successful events that we had is the involvement of the community itself. So we do have the multidisciplinary teams from the governors, from the laws, but we need to involve the community. We need to involve the people. We need to listen to them. We need to listen even to the specific target groups, patients.
And we are at the end of our time, Hamad. We have several questions, but it will not be possible to answer all of them. On behalf of each audience, on behalf of everyone here, I want to express our deepest appreciation for your contribution to this Congress. Thank you for your inspiring presence and insights, and we look forward to continue this important dialogue in the future. Thank you, Mr. Hamad.
Thanks a lot, Professor Rabi, and thanks for the Green Crescent. Thank you for you also, Misa, for the nice introduction. And I'll be more than happy to answer the question on the chat room. So anybody would like to have access to be more than happy. And thanks for having me also. Regard to all our colleagues in Tokyo. Thanks a lot.
And I would like to thank our esteemed session chair, Professor Rabia Bilici, and the distinguished keynote speaker, Dr. Hamad Al-Ghafri. Thank you so much for your great contributions to the Congress. And now it's time for a 15 minutes break. Right after the break, we'll continue with the fourth session of the Congress. Hope to see you again in 15 minutes. We are back with the fourth session of the Congress. This session will focus on innovative policy, action plan, and intervention program recommendations in the fight against substance addiction. Our session chair is Mr. Stig Erik Sorheim, who is president of European Joint Program on Radioactive Waste Management. And the speakers who will be with us in this session with their valuable speeches are Dr. Marika Ferry, who is head of sector support to practice of European Union Drugs Agency, Dr. Wadi Malouf, who is Program Officer at Prevention, Treatment and Rehabilitation Section at United Nations Office on Drugs and Crime, and dear Giovanna Compello, who is Chief of the Prevention at Treatment and Rehabilitation Section at the United Nations Office on Drugs and Crime. I would like to welcome our esteemed session chair and the distinguished speakers for being with us in this session. And this session, Dr. Marika Ferry will be with us with a pre-recorded video. Her speech entitled European Union Drugs Agency, Opportunities and Challenges for Evidence-Based Decision-Making in Drug-Related Issues. Dr. Wadi Malouf with his speech entitled Global Landscape of Drug Prevention Responses, Needs and Priorities, and dear Giovanna Compello will be with us with her speech entitled Updates on Evidence-Based Practice on Drugs Prevention and Treatment. Our session will last approximately 75 minutes, and to kick off the fourth session of the Congress, now I kindly leave the floor to our esteemed session chair, Mr. Sorheim. The floor is yours.
Thank you very much. Welcome back from your break, everybody. I hope everybody got the chance to stretch the legs and maybe get a cup of coffee. We're here with a very distinguished panel of speakers. And I think that we will have a chance to have some interesting discussions afterwards. But I think we'll just dive right into it. Our first speaker is Marika Ferry. She is an expert in the field of public health and epidemiology, and she's particularly known for her work in substance abuse prevention and treatment. She works at what used to be known as the European Monitoring Center for Drugs and Drug Addiction, which has now been rebranded as the EUDA, the European Drugs Agency, where she works as a head of sector for support to practice at the European support for practice. Sorry. Before she joined the agency, she was at the Cochrane Center working on drugs and alcohol. Ferry has had a prominent position at the European Monitoring Center for many years, where she's contributed to the monitoring and assessment of drug-related issues across Europe. She will join us in a video presentation, and if the technical team is ready with the presentation, the floor is yours.
Good morning, and thank you for having me today. My name is Marika Ferri. I'm the head of support to practice sector at the European Union Drugs Agency. Today, I'm here to explain what is our new mandate, what are our challenges and opportunities for collaboration. As many of you may know already, starting from July this year, a few months ago, we have been given a new mandate by the Commission. In the picture, you can see the unveilment of our new name with our director, Mr. Alexis Gustil, and the Commissioner for Migration and Home Affairs, Ms. Ylva Johansson. So what's in this new agency? We changed our name, but not only. There are three pillars in our new mandate. The first one is monitoring, the second is preparedness, and the third one is competence development. But what's in? Some of these activities were there before, but there is a substantial change in the expectations. For example, we will move from evidence dissemination to recommendations to the countries, from sharing of knowledge to assessment of measures, so impact, and then from training to competence development, meaning making a change in the life of people that is trained. Now, where do you come from? Where do we come from? We were the European Monitoring Center for Drugs and Drug Addiction, based in Lisbon, as we are today, with the tasks of developing monitoring of patterns of drugs use across the European countries, monitoring the mortalities and overdoses, the spread of infectious disease, the use of substances. So our colleagues in the beginning of the 90s developed the agency by creating 5 key indicators. So, prevalence and patterns of drug use, problem drug use, treatment demand indicator, drug-related deaths and mortality, and drug-related infectious disease. These are still the 5 key indicators, although there are many other data collection and innovative methods that are applied to triangulate the data coming from these indicators. This is the list of the partners, countries that are collaborating with us, and you can see Turkey has also a special agreement with our agency. During the last, at the time of this celebration, were 25, now are 30 years, our organization has been active in many different activities, including, as I highlighted there, the establishment of collections of evidence-based recommendations and practices for sharing. I highlighted that activity because it's the reason why I joined the agency after the recast in 2006, the first one, asking the agency to develop and disseminate best practice. So we first created a portal under which, in collaboration with many excellent organizations, we started collecting data and information from the scientific world on recommendations for action. Best practice, excellent implications in the countries, and quality standards. These are some of our early publications on systematic reviews on the evidence we developed in collaboration with the Cochrane Drugs and Alcohol Group, of which I was and I'm still a member. Recently became a senior editor of this group. And then the development of the quality standards, including collaborations with other international organizations, such as, for example, the UNODC and the WHO. Here we can see the development of several European finance projects, of which we optimize the use of the outputs for our agency activities. Another example of our dissemination is the so-called European Responses Guide. This is a modular publication that we keep updated and addresses several issues, including the type of people addressed, the type of intervention, and the settings where these interventions are given. These are examples of collaborations we have on guidelines with other international organizations. And this is our main output in terms of training and capacity building. You can see the students of our last summer school participating in the ceremony for the opening of the new agency. So we deliver every year a winter school only online. This year will be in February 2025, and the main theme will be crime prevention. While during the summer, the end of June, beginning of July, we will have the face-to-face summer school in collaboration with Lisbon University, as you can see in the picture, and this year will be dedicated to synthetic opioids. We also have an important curriculum on prevention. This is the results of several European finance projects that is delivered in different format according to the needs of our clients. So from an initial phase for beginners to becoming trainers, the train of trainers for master trainers. And this is a training we developed for treatment based on the publication I mentioned before, the Responses Guide, again in modular format to train. In that case, it was a collaboration with Georgia, but this model is applicable to many other requesting countries. So there are lessons that are facilitated by local specialists and delivered by European experts. In many interactions and working groups, we reach a common knowledge about some of the most important problems. The selection of the problems is made initially by the recipients of the interventions to make sure we are really satisfying their needs. This is another product that we have, is an e-learning platform called Plato, after the Greek philosopher, and where students can follow synchronous webinars, so with a teacher that is really there for them, and answer a series of quizzes, questions, doing some homeworks until they obtain their final certificate. And then we have our popular series of webinars more or less monthly webinars on different topics. And with the collaboration of external speakers, we entertain our audience for 1 hour and a half lunchtime. And we have many participants also from your organization. Towards the end of the webinar, the audience is engaged in questions and answers. So we also get inspiration for other webinars according to the feedback we receive from our audience. What is coming next? Where are we with the implementation of the new mandate? So the previously seen platform that was mainly dedicated to prevention will host training from very different subjects, including, for example, training for people working in the migrant centers, people working in prison, people working with professionals working with women, and etc. And then another is the UCOMP, so-called, and this, the idea is to create a collection, an inventory of curricula coming also from other organizations and countries for adoption or adaptation for the European public. So these two projects have been launched. There was a competition, and in shortly we will sign the contracts and start working with external contractors. But there is something more to come, and this is the most interesting, from my point of view, project, because it's really a transversal project, including all the agency, which will also take the advantage of the opportunity given by artificial intelligence to provide decision-making aid support. So the idea would be that the final clients will be able to ask questions and receive answers that are based on real data coming from our group and networks. And the final one will be called U-Quality and will be a collection of quality standards and guidelines to support the countries to implement their quality assurance systems, starting from where they are. We have countries that are already well advanced and probably will only need to evaluate and update what they have, others that are at the stage of considering where to go and will be guided through the options available and their implementation. And with this, I concluded my presentation. As you can see, there is plenty of new challenges in front of us, but also opportunities for concrete collaboration. At the time you will be listening my presentation, I will be traveling for another mission, but I would be delighted by receiving any possible questions from the public to answer online. Thank you very much.
Thank you, Marika. The UDA is a very important resource for everybody who works in this field, and I hope we all are familiar with the agency and use their resources. Our second speaker is Dr. Wadi Malouf. Wadi is team lead for the prevention program in the UN ODC Prevention, Treatment and Rehabilitation section, supporting the coordination of the prevention response globally for the United Nations Office on Drugs and Crime. He's been working in the field for over 25 years, 19 years with the UNODC. In his latest UNODC function, coordinating the global program on prevention of drug use, he has been supporting a change in culture in policymaking, implementation, and research in prevention. Wadi holds a PhD in mental health and drug addiction epidemiology from Johns Hopkins School of Public Health, and he will speak today about the global landscape of drug prevention responses, needs, and priorities. Wadi, the floor is yours.
Thank you very much, Stig, for the introduction and for being there. And big thanks also to the organizers, to Green Crescent, to always be thoughtful to have such podiums in place to share knowledge. We're more than honored to join them. With that being said, just to complement where Marika ended, for us as UNODC, we maintain a very strong partnership with EUDA.
We changed our name way before, but our partnership with EUDA remains the same. So I will just go ahead and proceed with the global landscape in terms of priorities that we are engaged in as UNODC in the field of prevention. But just to focus the attention of the audience is the population I'm talking on, because prevention can be broad, depending prevention of what in what population. I'm talking about prevention of drug use, which is prevention, which is the population that's currently not using drugs. It could be these resolute non-users. It could be those contemplating use. It could be those that early experimented with these substances. But this is for that population that we're talking about, that we want to, especially in the young age groups, where prevention is being done as part of a comprehensive set of responses. When initiation of substance use happens, there's another set that we continue from a comprehensive set, where our Chief of Section, Giovanna, is going to present on in terms of how to deal. But I'm just reflecting the fact that this is a very big part of the population that we're addressing, but where also further to the scientific tools that are needed for responding to actual drug use, there is a science that needs to be put in place for preventing it from happening in the beginning. And this is where I'm going to reflect more in terms of the contemporary issues that we are following on in order to ensure that that science, that culture is provided to that population. So the first issue that we've always been concentrating on, and we continue to concentrate on, is reflecting that prevention is a science. And this is where, in the political sphere that exists globally, for us, whether it is from the General Assembly of the United Nations, where there's a roadmap for joint commitment, a roadmap that also is reflected by the Commission on Narcotic Drugs in terms of focusing a balanced approach between demand and supply of drugs that is health-focused. This roadmap includes the fact that prevention is key, and actually mentions the fact that this prevention should be aligned with science. But it is that science that needs to be understood by these policymakers. And also the fact that parallel to the focused groups that are working only on the drug response, it is important to reflect that within the Sustainable Development Goals, there is a specific target on strengthening prevention and treatment response to drugs and alcohol as well. But now we're reflecting the fact that this is part of sustainable development as well, really working as a scientific approach for prevention. For us, at this core center is always the prevention standard that is available from 2018. We're reviewing the evidence as we speak. There's not enough evidence now to change the content of it. Its content stays. But also, we have sectoral-based tools that exist. And of course, there are other tools that are available through other agencies like the EUDA, and we have the UPC. These tools are becoming more and more available to really support every single sector to understand that prevention is a science, there's something behind it, and not anything that is labeled prevention is prevention. It is important to rely your investment and build your investment on what works in the field of prevention. This is just like to highlight the fact that within the joint commitment of the General Assembly response to a special session on drug use, the standards have been mentioned. It is that articulation to understand what these standards are is key. So that science is an important thing to reflect for policymakers. But within that advocacy that we're doing, we move to the second issue that is important, reflecting the fact that prevention is a developmental response. Meaning that the international standards that we're talking about reflect the fact that when we absorb that evidence, by the way, evidence that we have applied WHO standards of reviewing it, really announces the fact that prevention can start as early as when the child is the embryonic stage of the pregnant mother and onward. So basically, prevention intervention are not focused on the drug and discussing the drug issue, but supporting every milestone of development. In every single stage of development, there are evidence-based practices that can put in place. So basically, this is a different way of working. And probably this is, not probably, but this is exactly why working in a scientific approach to prevention is part of the Sustainable Development Goals. It supports that development beyond just the field of drugs. So this is where we also reflect the fact that not only by ages, but working in this spirit of prevention, it is a component of prosperity and reaching your sustainable development goals on more than one level. This has been more and more highlighted with the fact that the same strategies that the prevention standards in terms of drug use prevention articulates are also common to many other strategies related to child and youth development. May it be the Ending Violence Against Children, like the Inspire Interagency Initiative. There are lots of commonality where the activities that are put in place are similar to those that are needed for preventing drug use. Violence prevention by the WHO prevention guiding tools, preventing and promoting mental health intervention in adolescents, there's a lot of commonality. That mode of action is really sort of supporting a really different connectivity of sustainable development goals. That approach is key. The third issue to highlight is the issue of research and prevention. We need that culture of research not to be only kind of unidirectional, but it's important that policymaking, funding, monitoring, evaluation really takes in that science. But also, we need more research to be availed by low and middle income countries to really add to the scientific evidence, particularly for those countries that are, for those populations where maybe not enough science exists in countries that are producing science. Registries, transferability of evidence, monitoring and evaluation of implementation, scalability, sustainability, and cost effectiveness, these kind of research are really needed to kind of further boost the agenda forward. The fourth issue that we're working on is moving in more focused on early prevention. As you see from the prevention standards, there's a lot of work that's being done in the age of adolescence and late adolescence where actual substance use occurs, but there's a lot of evidence that starts in terms of activities to prevent that from happening way earlier in the developmental ages of children. And this is where we need to focus more efforts. And this is where we're advocating with our policymakers that we're engaged with to really put more efforts there. And actually, this has not went into vain because our policymakers in the Commission on Narcotic Drugs in 2022 took a resolution on promoting more comprehensive and scientific evidence-based early prevention responses, which is a key development moving forward. Not early prevention in the sense of early time of substance use, but focusing more on that age from 0 to 10 years, what can be done in terms of really moving that trajectory forward in a positive way earlier than the age of initiation starts. The fifth issue is really leaving no one behind. So as you see from the set of tools, prevention has several layers, and I showed it in the beginning, but I didn't go and dwell to it. But there is universal prevention. Any child at a specific age can benefit from interventions, but also that's in green. But there are other interventions that really are tailored for a population that is really living at a different level of risk compared to the rest of the population. These are selective-based intervention. They need to account for the context these people are in. But there also are interventions that are, that was the population in yellow, but there's also the interventions in yellow. But there's also intervention in red. This is for the population that is symptomatic. They only have a symptom already that need to be addressed before it moves into more problematic circumstances. And that is in red, the indicated double prevention. So leaving no one behind really accounts that you have different layers of risk that you have to account for. This is, for example, what we've done in our family skills intervention, where we have worked for Family United in terms of, because it's a core social institution of development. Family could be any family that is raising a child at a certain age and requires these skills of bonding, Family United being universal, but we also tailored another set of programs like Strong Families for families raising their children in the context of stress. That's a different way of dealing with raising a child. Also in crisis situation where we cannot do interactive modalities of training. You have to provide them basic tools, the context of COVID-19. And this is where we have also a set of tools now with the unfortunate situation of growing number of humanitarian settings and displaced population. We started moving into leaflets, booklets that parents can read in those circumstances until we can move to more interactive session work like Strong Families or dealing with the trauma that is caused by the certain incidents and then rebuild these parenting circumstances. So these are key learning processes in terms of moving forward to really leave no one behind. The sixth issue, which is key for us, that also was mentioned in Marika's presentation, is improving the quality of prevention. It's not only the intervention itself that needs to be evidence-based, but the population, the human resources that's providing these tools need to be also better qualified. More training, specific training in terms of working within this context, finding more growth for this population, the human resources doing work, professionalizing the field of prevention is a key component that is we're moving forward in terms of its advocacy and our programmatic approach moving forward. There are a lot of tools that's not only UNODC is doing in place, but EUDA, ISAP, ICUDD. There are lots of entities that are providing several tools that are on the pathway to actually providing between the kitchen really and serving that dish that provides a professionalization of that chain of command so that dish is provided in an appropriate way, if I can use the term, as a service provider. That analogy, if I can. So there are lots of tools to improve the qualities, like the quality standards, the prevention standards, the prevention standards that I mentioned for UNODC in the beginning are also one of those tools moving forward. The seventh and very important issue that we're also focusing on is implication of youth in prevention responses. This population of youth is not the normal population of youth. These are active youth that have really a strong role in changing policy and being implicated in policy. For us as a UN family, in general, youth is our key, but within the UNODC strategy, across all the mandate of drugs and crime that we're implicated in, we're really supporting meaningful participation and empowerment of children and youth. So that meaningful participation is key. Not any participation, but something that contributes positively, that they be part of the response. We have a youth initiative where we advocate for youth themselves to be engaged in driving the policy at the national level. We have the youth forum that comes in every year that meets youth from all over the world, come and speak to the commission when they're there with the message of nothing about us without us when you're making these policies. We have grant mechanism that is the DAPC grant that is generated by youth to provide grants to youth that is directed for youth as well, which is a very interesting modality of working to this effect. And we're currently developing a new tool, which is peer-to-peer, youth to youth, exchanging information, youth themselves being agents of prevention, providing this resilience, this message of life and social skills of resisting peer pressure, changing normative belief, critical thinking, through youth themselves being trained to pass that knowledge to others. That's Friends in Focus. And I will end on the most important issue that is really sort of bringing all of these issues that I previously discussed in one melting pot. It's development of systems of prevention. Everything I mentioned before was really supporting every single sector to do what it's supposed to do in an appropriate way with evidence-based approach, with a kind of a specific North Star. But this is really to bring all of these North Stars together. We know that in order to be effective in doing prevention, you need evidence-based policies, but everything, these are maybe let's call them the softwares. But we need supportive structures. That hardware that kind of assimilate all of these programs together need to function in an effective way. The legislations we see from the prevention standards, chapter 3, we mentioned about the delivery structure that exists, whether it is at the local level or at the national level. The legislation that exists, the support for sustainable resources to maintain the processes moving forward, to qualify these the people that are providing prevention, the proper legislation, all of these things that exist in order to, for these programs to be put in place are key in order to have structures that is, when coupled with every single prevention intervention that's there, provide a system of prevention that are key. We have new tools that have been developed, namely the REPS tool, which is now a tool that is a that can be applied in any country for any policymaker to understand the landscape of the resources that exist in terms of supporting development or supporting responses, maybe at the policy level or the service level at every age of development, and contrast it to the standards as well. And by doing so, kind of color coding it, I cannot go into the details of it, but it can also showcase in every single structure that you have, what are you providing, at what level of risk, maybe it's universal, selective, or indicated, but also assesses how is that system functioning, how comprehensive it is, how much do delivery structures are providing with their support, how much regulations are supportive to the work, how much research is being done to drive the agenda forward, how much coordination exists, how sustainable are your efforts. And this is culminated in us calling for a program called CHAMPS, Children Amplified Prevention Services, that I really invite you to learn more about, where we're working with our member states to really establish these systems at the local level, showcasing that when you work on a systematic approach, bringing all your tools together around an agenda that's supporting child development, children, meaning by till the age of 18, you can really make a change in the trajectory of these kids over a course of 5 years, changing not only prevention of drug use, but mental health, violence against children indicators, school delinquency, crime indicators, and beyond. Showcasing that you will have effectiveness, you will have cost effectiveness, and you have a higher return on investment by doing this modality. And this is where you can go to our CHAMPS initiative. This is a QR code. It's available currently in Arabic and English, soon in Spanish, when you can learn more about this initiative moving forward. We really invite as many member states as possible to join us on this venture to really showcase that prevention works, and prevention can work on a large scale, changing the lives of children. And this is where I stop, and I invite you to Google UNODC prevention. You'll see the website, all the tools that are there. Thanking also the Turkish Green Crescent, not only for this intervention, but many of the tools that have been mentioned, including those that are caregiving in crisis situation. The Green Crescent has been very key in terms of providing these tools to many people in need, and these are free, and I invite you to do the same. Over back to you, Stig.
Thank you, Vadi, for this very comprehensive overview of the drug prevention work, both globally and on national level. I think it's important to sort of see these two main points, I think, from your presentation. On the one hand, to increase the evidence base, to do the research, to increase the quality of the work, but also the structures, the supporting structures, which I think is often ignored. We focus a lot on the scientific studies of this particular intervention, and we forget about the structures that are there that are needed to support the work. I know my own country, Norway, has done one of these reviews to look at how the work is organized and structured, and I think that has been a very useful experience for Norway. So I hope other countries will follow suit. Our final speaker today in this session is Giovanna Campello. She is Chief of the Prevention, Treatment and Rehabilitation Section at the United Nations Office of Drug and Crime. Her presentation's titled Updates on Evidence-Based Practice on Drug Prevention and Treatment. Giovanna, the floor is yours.
Thank you so much. Distinguished chairperson, dear Stig. Let me share my presentation. It should be on the screen. Can you see it? Yeah, I can see myself in the screen. Wonderful. And thank you so much. I'll pick up from what you were saying about the review of the prevention system in Norway. I happened to have had the honor to be involved in that review, and rest assured that that experience will inform all of the systems experiences that Vadi was mentioning. In fact, that has been very much an inspiration for us. And thank you for giving me this opportunity. I will cheat a little bit because I titled my presentation Updates on Evidence-Based Practice on Drug Prevention and Treatment, but our updates, the updates on what's new and how we are, the new thinking that we are doing on drug prevention, but he just presented. So although, let me see how to move this thing. Yeah, although our section works on 3 pillars, so you have heard about prevention. You see the standards on the screen. We work, of course, on treatment of drug use disorders, and the last icon is represents our work on our 3rd pillar, which is promoting the access to those controlled substances that have medical purpose, so controlled medicines. Because we all know that the situation globally with access to controlled medicines is really, really tragic in reality, with more than 80% of the world populations living in countries where access to these medicines that are very necessary, think about pain medications and surgery or palliative care, and they living in countries where this access is not assured. But for my presentation today, I will focus very much on treatment. And let me start by saying that although the standards talk about treatment, we are really thinking about the entire range of services that are needed to protect and promote the health and well-being of people who use drugs and people with drug use disorder, and support, if they so wish, everything should be voluntary, their recovery. So really we are covering from very basic needle syringe exchange, outreach, harm reduction kind of services, to more structured psychosocial or pharmacological therapy, to recovery support, inpatient, outpatient, and so on. Everything is covered by the treatment standards. And look at this. This is all actually it's not even all, but it's our main tools that we have at your disposal to improve your treatment system, like Steve was and that you were mentioning for us. There are many, many, many. And I will use this time to bring to your attention a few that I think are particularly important, but if there are other things that I've not covered, I will have my contact details at the end. You will have at the end the way of how to get to our publication. They are all online, they are all searchable, and you might find things that are of use to you beyond what I will present in the next few minutes. I want to start from our basic data. All of the data that I will present come from the latest edition of the World Drug Report. So the one that came out in June 2024, where we noted a 20% decrease over the past decade of the number of people who use drugs, mostly attributable to global population growth, but the prevalence did go up a little bit. So it is true. And we have here the most important data, which is the number of people with drug use disorder, the people that really need our care. And I think that this is the most important analysis that our colleagues presented this year. And they have often presented data about the so-called treatment gap, right? The fact that only a minority of these 64 millions, only a minority of people with drug use disorder actually are in treatment. And in the latest World Drug Report, is minorities like 1 in 11. Which is bad enough. But I think this analysis really brings to life the urgency of our work, of the need for an expansion of our work. the percentage of people in treatment actually decreased in the last 5 years, in spite of all our efforts. And we don't have data on whether the quality of the treatment provided increased or decreased. That would be a very difficult but very, very interesting research project that we have at the back of our mind, and but we haven't done yet. But for now, even look at the crude numbers of people in treatment, this percentage has gone down. Yes, it has increased in absolute term, of course, because we have an increase in the number of people with drug use disorder. But really, we are not making any indent. And this is something, I think, the most important issue that we need to think about collectively. And this is especially the case for some regions like Africa and Asia, where we see that the treatment coverage is even lower than the global average. And it's not like we don't have the tools. We have the international standards. I was mentioning them before. These have been published together with WHO. There you find there all that is known at the moment with regard to what to do to address drug use disorders. And we have even developed many tools for any member state or any community that is interested in taking a critical look at their treatment system, at their treatment services, and say how much are they in line with the treatment standards, and therefore create a system of improving and assuring quality in the long term. And in fact, a lot of the methodology that we used in that critical review of the prevention system in Norway, which we hope will be of relevance to all of the world, was very much inspired by the methodology behind this kind of work. So we are actually active in many countries with quality assurance, and we are developing a methodology to assess whether the quality is improving and whether this improvement is reflected in actual better health, better well-being for the people with drug use disorder that are in the services. It's not an easy process, but I want to assure you that we are undertaking this, and you can find in our website many papers on the different dimensions of quality, what the science tells us. We have run a couple of systematic review of the evidence to really see which dimensions of quality are linked to better health and better outcomes for people who use drugs, who are in treatment. And therefore, because we hope that this will help us in developing this methodology of evaluation that I was talking to you about. In the meantime, we are connecting to many countries, and we are always happy to consider to connect to more countries. I will also underline that, where are we? The treatment services, this one, Drug Use Disorder Treatment Services Quality Assurance Toolkit, a lighter version of this has been published as key quality standards together with many other organizations, including, of course, EUDA. And that's what Marika was mentioning in her presentation. Another new development that I want to talk to you a little bit about is stimulant use disorders. So here I don't have immediate data on how much of the drug use disorder and drug use worldwide is due to stimulant use. But we know that it is very significant and sometimes increasing. For example, there are data about the dramatic decrease in the production of opium in Afghanistan, and there are stockpiles, so there are delayed effects on the actual market. But we are all very, very worried because we know what happened last time. There was a dramatic decrease in opium production. There was not an increase on treatment services. So people that had an opioid use disorder could not get the services they needed. They still needed to use, and therefore they moved to more harmful patterns of drug use, such as injecting, or they moved to synthetic drugs, including stimulants. And therefore, I think that the fact that the issue of stimulant use disorder has been a bit on the back burner because, let me see, we still know that most overdose deaths is linked to the actual use of opioids. So it seems almost a bit less urgent, but it is there. And what is particularly dramatic in the context of stimulant use disorders is that unlike opioid use disorder, we have very few evidence-based therapy options that can be used to scale. First of all, nowhere there is a medication, no country has agreed to any medication as registered any medication for the treatment of stimulant use disorders. And there are some evidence-based psychosocial therapies, but their use is very limited for different reasons. So we said we need to do something. And that's why this CND, we have launched Scale Up. We launched CHAMPS, as Vadim was mentioning, on prevention, and on treatment, we chose to focus on stimulant use disorder and launch Scale Up. And this is an initiative by which we want to bring together all of the research groups that are scattered around the world and that are doing research. There are different groups doing research on either pharmacological or psychosocial treatment, better treatment for stimulant use disorders. We have been convening them and bringing them together, and we are, with the help of member states, what we are hoping to do is to make sure that all of these research groups coordinate their research enough for the results to be comparable, and therefore together really start creating a stronger basis of evidence for options for the treatment and care of stimulant use disorder that can actually be used to scale. And I will add also that it can actually be used to scale in all over the world, in low and middle income countries, high income countries. We don't want to find out a solution that is only that is very expensive, that needs sophisticated structures of delivery. We need to find solutions that are relatively cheap and easy to implement, still effective and safe, of course, so that we can really support the health and well-being of people with stimulant use disorders. Now, we have just launched this initiative in March. We will have some technical consultations next year. I think that the best way to stay connected, if you do know of any experience that might be relevant, do get in contact with us, and do stay connected through our Twitter account, because that is where we will let people know how things are progressing and how you can connect. So we just be connected, because we feel that this is a very neglected and important thematic areas of work. I'm looking at my watch and seeing that I have some 4 or 5 minutes more. So I think that I will be going a tiny bit faster on the other updates that I have created for you. The first one is about opioids. It's not so much an update, but I would like to underline how we do have very good tools to prevent and to manage opioid overdose death that is connected to opioid. First of all, in terms of prevention, of course, we have opioid agonist maintenance treatment with methadone and buprenorphine. This is very clearly stated in the standards. We have very clear evidence that for people to be in a psychosocial, especially psychosocially assisted opioid agonist maintenance treatment, really lowers their the prevalence of opioid overdose. And let us always remind ourselves that opioid agonist maintenance treatment is not only about preventing overdose and HIV. It is great at that, but it's a very strong therapy option. We know that psychosocially assisted opioid agonist maintenance therapy reduces drug use disorder. It shrinks the illicit market. It decreases crime. It reduces arrest. It reduces reincarceration and costs less than probation, than incarceration, and it costs less than doing nothing, because doing nothing also has a huge cost to society. So we have a very strong option, and it just needs to be implemented better. And if somebody does, for whatever reason, we will not manage to prevent all of instances of opioid overdose, we have a powerful tool to reverse opioid overdose and to manage it. And that is naloxone. And that is, I invite everybody to consult the data and the experience of our SOS initiative. SOS stands for Stop Overdose Safely. This is an initiative that we undertook together with the World Health Organization. And what we wanted to do was to demonstrate that it was possible to reach 90% of a relevant target group, train them in the safe use of naloxone, and train them in bringing naloxone always with them, and that they would, 90% of these trained and equipped would actually use the naloxone correctly. And we did manage. Here we have the report, and we were implementing in Kyrgyzstan, Kazakhstan, Tajikistan, and Ukraine. And we in 6 months, we reached 14,000 people likely to use an overdose. This means people who were using themselves, their peers, their family, first responders in the police, first responders in the health departments. We trained them and we equipped them with naloxone. And we studied these samples, a representative sample of these, and we could show that 90% of those that we had trained and equipped with naloxone carried it correctly, used it correctly when faced with an overdose, suspected opioid overdose, and therefore potentially saved many, many lives. This was the first time the feasibility of take-home naloxone was demonstrated in low and middle income countries. We have the reports, we have the guidelines, we have the study protocols. Any country who is interested in repeating and using this experience and using this material is very, very welcome indeed. We know it works. I am already over my time, so I will just very quickly skim through the fact that we have, there is a very strong treatment gap for youth. They use drugs, especially adolescents. They use drugs with drug use disorder. And we have a new tool, which is called TreatNet Family, that is evidence-based as recommended by the World Health Organization and the standards, and that we have successfully studied and implemented in many countries in the world. So you might be interested in that. And the same is for women who use drugs and women with drug use disorders. We have many tools that need urgently to be implemented to fill the treatment gap. And finally, people in contact with the criminal justice system. And I just want to quickly remind you of some of the data that I've just presented about how evidence-based treatment reduces arrest, reduces reincarceration, costs less, reduces crime, and therefore how it could be evidence-based treatment a really, really strong possibility to be offered as alternative to conviction and punishment, a possibility that benefits everybody, and that can be offered at all stages of the criminal justice process. Maybe another time where there will be more time to go in detail about this. And for this, let me thank you very, very much for the opportunity, and I'm at your disposal for any questions, comments, or if you want to contact us, to be contacted at the details that you see on the screen. Thank you very much.
Thank you very much, Giovanna. I hear some of the same themes as with Wadi's presentation. You know, there are a lot of evidence-based interventions already. There's some need for more research, some, for instance, in the area of stimulant use. But there's also a need for structures that can deliver these services at scale. And so it's both the evidence and the structures are needed in order to close the treatment gap. Okay, so we've had several questions for the speakers. I think I'll begin with one of the questions for Wadi. The first question I got is, in your prevention work on the family, you mentioned that the first stage of child protection is pregnant women. Can you give information about prevention activities in this area? And do you also have prevention activities for disadvantaged groups? Wadi, do you have any comments?
Yes, I actually invite the person asking the question. I mean, the prevention standard goes a bit into the details of it, but essentially, this is a very critical period of development. The first 4 months, actually 3 years of life, are key. So basically, in terms of services, in terms of generically speaking, we're talking about nurse visitation. All the services that are being considered are generally selective prevention, meaning for a population that are higher risk than the normal population. Of course, you cannot really reach every single pregnant woman, but at least those that are living in challenging circumstances like nurse visitation for these families, to provide them with the nutrition that they need for their kids, healthcare, housing support, and the like. You will see them within the standards in terms of more details. Also, any pregnant woman, really, especially in circumstances where there are challenging access to healthcare, providing a pregnant woman with advice on not using substances during pregnancy, especially with those that have in socially disadvantaged context. And actually, women who are substance users themselves that are in treatment centers. In many cases, the treatment centers provide the care for the person in terms of dealing for the substance use disorder, but during their social rehabilitation or their integration, it's important to reflect on the fact that, they are also mothers, and they are, drug use can compromise parenting skills, and, engaging in terms of providing appropriate parenting skills during that period over and beyond what is discussed are key. So all of these things also provide an opportunity for policymakers to reflect on what they have. These programs might exist in many countries, but in many cases, they're not accounted for as part of their drug responses because that's an early age population The standards will tell them what works, what does not work, to fine-tune whatever services they have in line with the standards. Back to you, Stig.
Thank you, Wadi. And a question for Giovanna again. You mentioned that there are fewer treatment activities in Africa and Asia than in other regions. What do you think could be the reasons for this? And are there efforts to increase this or to reduce this gap?
It's very difficult to speculate. Those data are real huge estimates, and behind that simple data there is a lot of number crunching by our colleagues in the research and an analysis branch. So one of the problems is simply some of the fact that the health system is sometimes weaker in countries in Africa and Asia. Sometimes treatment is not even part of the health system. So that is already, and is therefore is not offered as for any other health condition. People need to pay out of their own pockets, and this obviously reduces the access. Sometimes it could also be that the treatment that is offered is not evidence-based and not of high quality, and people rather not go even if they would really need it. All of these things do not happen only in Africa and Asia. They happen all over the world, and it's important to bring it. So we really need to work on different fronts, like you were saying, Stig, right? First of all, of course, dramatically increase the offer of services. There's just not enough, but also increase the quality, of course. There's no point in increasing the offering of treatment services that do not work or they are punitive and abusive. But we have the tools to do it together. That's what I want to bring out as an optimistic message as well.
I'll follow up with another question for Giovanna. Sure. The question is, are there different methodologies for substance use disorders in Europe? Can we say that every country in Europe applies the same standard, or are there variations between the countries?
I think that the methodologies that work are the same all over the world. They need to be adapted to local circumstances, of course, like in prevention, like in everything. But what works is known. It's what is described in the standards. There might be gaps, but like in the case of stimulant use disorder that I was mentioning, but we have a good basis. And I think that if you look at the data, there will be higher coverage in Europe. And yes, some pharmacological options offered more often than in other countries where they might or might not be needed. I mean, if no point in offering a lot of pharmacological opioid agonist maintenance therapy in a country where vast majority of the prevalence is about stimulant use disorder, is just not the option that is needed. And I think that the quality varies. And at the moment, I cannot give you a good picture. Why? Because the tools that I showed on quality purposely stop shy of being comparable. We really want countries and systems not to feel defensive. We really want that they use these tools as a self-improvement tool, not to feel judged or anything. So the thresholds of quality under the quality standards are a bit variable. But they all refer to the standards. So I cannot give really a comparable. There is not good data. We just tried to do a comparative analysis on the basis of the data that the member states give us. Doesn't work. We're working on it. slowly. But I think that there is a lot that we can do in the meantime. We don't need to have this wonderful assessment at the global level to start working. There is a lot that we can do in the meantime.
Thank you, Giovanna. We'll go back to Wadi. The question is, what are the standards for the prevention of drug use? You mentioned that the activities carried out in this framework are similar to each other. Are there any countries that carry them out differently? And if so, could you briefly indicate what kind of differences there are? So in a sense, it's a similar question as the last one, just with prevention.
Yes, I mean, differently is, of course, as Giovanna mentioned, it's like that cultural aspect of it that needs to be accounted for in terms of adapting it. As you will see from the prevention standard, of course, the treatment component really takes into account the drug, and the nature of the drug will determine what kind of response you need. Prevention, we're talking about the population, and there's milestones of development, right? Every child, regardless where they are, require a certain program that assists that person during that age of development to reach their ultimate milestones. Now, you will see from the prevention standard, it's not descriptive in the sense of a catalog of necessarily brands of programs, but what kind of programs need to be put in place is key there, and what works and what does not work within this program. And this is key for the policymakers to understand what they need in terms of that age of development. That variability might exist. There might be some evidence-informed packages. There might be some evidence-based, but documenting if that program is working within that context, even if the program in its original development is an evidence-based, transferring it to another place, need to document that that transferability worked and is actually providing that child what it needs, what he or she needs during that age of development. So yes, there is a variability as long as there's a common compass of this is the science that is needed at this age of development.
Thank you, Wadi. I have another question for you, Wadi. And I think it's an interesting question for me because sometimes I feel that in the discussion about prevention, sometimes some people are happy as long as the intention is prevention, then it's good. They don't really care so much about what the content of the prevention is. On the other hand, there are some people who are really skeptical of the effectiveness of prevention at all. They really doubt that it's effective. So the question is, what are your recommendations for people working in the field of addiction so that prevention is perceived as a science?
This is a very important question. I'm glad it's being asked. First of all, there's so many ways of answering this question. The first and easy one is like the ethics of it, right? When you know that science exists and you have limited resources, might as well move your investment in the field where you know these resources are put in place to support the person that is receiving these services. But also there's evidence that some of these prevention is counterproductive, which means it might cause risk. So from a person working in terms of responding to addiction, this is a counterproductive measure, right? There's also the element in terms of not investing in prevention by itself, this is what Giovanna mentioned, and this is like also by itself a cost, right? So you have to invest in prevention, and you have to invest in prevention that is evidence-based. But there's also a very important component. The concept of the science of prevention for policymakers is a very important entry door for the policymakers to understand that biopsychosocial model that exists in terms of the vulnerability is not related to a personal choice that the person makes whether or not he or she is using drugs. And this is a key component to alleviate stigma, which really encourages people to access treatment. So I think moving with this rhetoric from the prevention perspective really facilitate the treatment response moving forward. And these are key things to consider moving forward in the field of, applying that science from a comprehensive point of view is not only this group of people who benefit from it, which is the preventologists and the people working on drug treatment are independent, right? This is a kind of a comprehensive thing that brings the elements together in a comprehensive response. And all of these things are key features to kind of reflect on nationally when it comes to operating and responding from a health perspective to drugs.
Thank you, Wadi. We are nearing the end of our session. I think we have time for one more question for Giovanna. And that's a question regarding recovery. The question is, there are many activities related to the recovery process.
Yes.
Is the effectiveness of these activities measured, and how can we assure that effective efforts are disseminated? Sorry.
Very tricky question. Very good question. So I mentioned in my presentation how the standards covers everything, including the support to recovery process. And in that section, we have a description of interventions that have been found to be effective based on the principles of addressing recovery as the recovery from a health condition that has a chronic characteristics, and therefore relapse can happen. It's normal part of the progression. It needs to just be prevented through a strong recovery support. And if it happens, no huge tragedy, it needs to be managed. It can be managed. So far, so good. Effectiveness, very, very difficult discussion, also because there is not a real consensus and strong definition of what the recovery is really. I invite anybody who is interested in recovery, particularly, to get in contact with me. I will not find the URL so quickly to put it in the chat, but I can send it to the organizer. Very recently, there was a global recovery network that was launched, connecting people in recovery and allies of people in recovery to promote precisely a stronger framework around what is recovery, what are effective intervention for recovery support. They very much see as also in the standard recovery as a process, sometimes a lifelong process that can be supported for the health and well-being of people that have gone through a more intensive part of therapy and have dealt with and have addressed their drug use disorders and related comorbidities. So I spoke a lot and I didn't really answer the question because there is not a real answer, but this is something that is important. And our member states just this year have noticed, and they have agreed on a resolution noticing that we need to pay more attention to this part of the process. And so there will be more activities around that I hope. I'm not sure we will manage to even to start evaluation, but evaluation starts with first steps. We need to define, we need to get a consensus on what outcomes we want to look at. And all of this is all very necessary to give that visibility to people in recovery and to show that it's possible and that we need more treatment and recovery support to have more people that have whose health and well-being has improved.
Thank you, Giovanna. I want to thank our speakers for their very insightful presentations and the good discussion towards the end. And I want to thank the audience for sending in interesting and stimulating questions. I apologize that we didn't get through all, but we did our best. Our session is at an end. Thank you very much.
Thank you. And thanks, the Green Crescent.
Thanks from my side as well.
And I would like to thank all of our esteemed session chair and the distinguished speakers for this valuable session and for your great contributions to the session. And now, after completing the question and answer part, we have now reached the end of the fourth session and the first half of the second day of the Congress. Now it's time for a 60-minute lunch break. Right after the break, we'll continue with the fifth session of the Congress. Hope to see you again after the break.
Bye.
Kongremizin 5.
Dear
oturumuyla yeniden
participants, we are here again with the fifth session of our Congress, and the topic of this session is current practices and research methods in the fight against tackling against substance abuse. The chair of this session is Professor Dr. Metin Bıçakçıefe, head of the Department of Public Health. And of course, we are going to have valuable speakers. And first of all, Head of Public Health, European Union Agency of Drugs, Dr. Jane Mantini, Istanbul University Cerrahpaşa Faculty Member, Associate Professor Selda Mercan, and Ankara University Faculty Member, Professor Dr. Nebile Dağlıoğlu. Professor Dr. Serap Anet Akgür from Ege University and Professor Dr. Mine Kadıoğlu Duman from Karadeniz Technical University. I would like to welcome our 5 distinguished speakers and Ms. Dr. Jane Mantini with her speech entitled Overview of Drug Trends and Development in Europe, Conclusions from the European Drug Report 2024. Associate Professor Dr. Selda Mercan and Professor Dr. Nebile Dağlıoğlu with their speeches titled Wastewater Analysis for Psychoactive Substances, and Professor Dr. Serap Anet Akgür and Professor Dr. Mine Kadıoğlu Duman will be with us today with their speeches titled Cannabis Use in Forensic Toxicology. And now I would like to give floor to our session chair, Professor Dr. Metin Bıçakçıefe, to conduct the first session. Please welcome esteemed professor.
Rümeysa Hanım, çok teşekkür ederim. Aslında bana da fazla bir şey bırakmadınız siz böyle.
Of course, you have said everything to be said. Thank you very much. So today we are here for the Congress of International Congress on Psychoactive Substances Use Disorders. Today the second day, and we are going to be together in the 5th session of today. Of course, before giving the floor to you, and this is a very significant event of Turkish Green Crescent Society. That's why we would like to thank them. Thank you for your invitation. And we know that there is a significant increase recently, and the youth has greatly affected. So there are different activities, events carried out. Thank you once again, Turkish Green Crescent Society. I'm not going to speak longer, and I would like to give floor to the first speaker. Before that, I would like to introduce her. First of all, drug tendencies and also general approach. So she is going to share the results of 2024 from European Drug Report, and coming from Belgium. Dr. Jane Mantini is going to be the speaker. It's going to be a video recording. Let me tell you about her, Dr. Jane. First of all, she is the head of public health in European Union Drug Agency, and also she has addressed various activities in terms of policies, implementations related to drug addiction, and at the same as a society, epidemiology, policies related to drug and the use of drug are 3 different topics that she addresses. And for many years, she also becomes one of the authors of the report, a very valuable researcher, speaker for today. Now, I would like to give floor to her video recording. Thank you very much.
Hello, and my name is Jane Mantini. I'm head I'm head of the Public Health Unit at the EUDA, and thank you very much to the organisers for an opportunity to present to you today. And it's going to be an overview of the latest drug trends and developments in Europe, results from the European Drug Report 2024. As some of you may know, we have recently been launched as a new European Union Drugs Agency, previously known as the EMCDDA. We have a slightly shorter acronym, so from Drug Monitoring Centre to Drugs Agency. And our mission is to help Europe respond effectively to a complex and rapidly changing drug phenomenon, and we will be supporting member states with a range of services with different focuses. Focus on anticipating new and future challenges, on alerting countries to emerging risks and drug-related threats. We'll help them assess needs and available responses to the problems and assist all of our stakeholders by evaluating, disseminating new knowledge and best practice. We won't be doing this alone. We have a range of important networks, the greatest of these being the RATOX networks of national drug focal points who we work closely with. Now, today I am going to present to you a few of the highlights from our latest report. We have an annual report providing an overview of the drug situation and responses to it. So, how are we approaching the situation? Well, I think our starting point is just the realization that drug-related issues can appear almost everywhere in our society. In fact, almost everything with psychoactive potential can be a drug these days, and everybody is affected one way or another, whether directly or indirectly. And if we go starting at the top level, I think what we're seeing now more generally is a high availability and a wider range of potent drugs on the market. We see, for example, from our seizure data, that availability remains high across nearly all substance types in Europe. Substances have often increased their potency or their purity, and there's a growing diversity of drug types and the ways that drugs are used. Cannabis is a good example, with edibles, with vaping. We see also that people who use drugs are at greater risk of experiencing health problems, often through consumption of these higher potency substances. So how are drugs getting to Europe, and what's the latest information here? Well, what we're seeing is increasing seizures in ports and the use of shipping containers, particularly for drugs like cocaine. There are a number of large ports, Antwerp for example, that are routinely targeted by traffickers, but also in some countries smaller ports are being kind of noticed and under threat. Traffickers are using increasingly sophisticated methods, both physical concealment and chemical concealment of drugs. And we note that there's exploitation of staff, intimidation, corruption being used. High on the agenda at the moment for many policymakers is drug-related violence. Certainly drug market-related violence and criminality does appear to be on the increase in some, particularly cities. And one of the reasons identified here is competition between criminal groups. Also, there's growing concern about recruitment and exploitation of minors, of young people being used in the illicit drugs trade. What we need in this area is good information. This is going to be key to designing effective interventions and responses to counter violence, corruption, and criminal exploitation. One of the things that we're noticing is just a consistent increase in the availability of cocaine on Europe's drug market. It's the 6th year in a row that the levels of seizures have gone up. It's almost, from our point of view, we can't keep putting the same headline, but the trend is continuing to increase. And this is having an impact on public health in European countries. Cocaine is used in many ways, but we're also hearing about the use of smokable cocaine products, crack cocaine, in many areas. We're picking up increases in the wastewater monitoring that we undertake, and 49 out of the 72 cities saw an increase in the latest data. It's also now the second most frequently reported drug amongst new entrants to treatment, and the second most reported drug in terms of presentations to hospitals for acute emergencies. We get reports of cocaine deaths. They're quite hard to pick up and will often be missed. And and most of those that are reported to us are in combination with opioids. In terms of injection, our latest estimate is around 500,000 Europeans actually injected a drug, an illicit drug, in the last year. And we're seeing an increase in the diversity of the substances that are injected, and that means a move away from the traditional model of heroin injection to a much wider range of substances. So we've actually seen a decrease in the injection of heroin and injection more generally, but an increase in the substances. So synthetic cathinones, quite popular in some countries, cocaine is being injected, as well as other opioids. In terms of responses and harm reduction interventions for people who are injecting, we monitor the needle exchange provision, and in relation to the targets set by the WHO, there is still inadequate delivery of syringes in most European countries. Polydrug use is now the norm for most people who have problems with their drug use. And the use of multiple substances does increase the risks to health. Polydrug use can take different forms. It can be actually substances have mixtures, and people who are using may be unaware of the contents, but it can be using a mix of substances in one session. I think a lot of the concern is that people are often unaware of what they're using, and we see many adulterated products. These can be cannabis products adulterated with the more dangerous synthetic cannabinoids. We've been registering MDMA products with synthetic cathinones. The most common polydrug use mix, I think, is alcohol and cocaine, which also, that combination increases the risk to the people who are using. In terms of harms and deaths, in the latest data, we had for Europe just over 6,000 deaths reported. Almost all of these were polydrug use. However, opioids remain the most common drug found. In terms of patterns of polydrug use, benzodiazepines are very typically found in overdose cases. We need, however, better toxicological information here to actually understand what's happening. We also need to expand our overdose prevention efforts. There are some interventions that we know have evidence of benefit. This is a diagram from a European Responses Guide, where we look at interventions to prevent opioid-related deaths linked to the aim and to the benefit. And you see here, for interventions, they can have different objectives. Interventions can aim to reduce vulnerability more generally, to reduce an overdose actually occurring, or to reduce a fatal outcome and death if someone overdoses. Here you see in the bold hexagons the interventions where the evidence is strongest, which is provision of opioid agonist treatment and provision of naloxone. The concern at the moment for many countries, we've been talking about synthetic drugs, synthetic opioids, and the appearance of highly potent nitazene opioids in European countries. The EU early warning system identified 16 nitazenes since they were first reported in 2019. They are very rarely bought for themselves, but they are sold in preparations that resemble heroin, or they're found in opioid tablets and missold as medicinal opioids. But they've also been picked up in smoking mixtures, for example, cannabis type products which have been adulterated. The risks are high. There have been outbreaks of poisonings in a number of countries with these substances, and there have been a relatively high number of deaths in the Baltic countries, particularly in Estonia and Latvia. Again, these are quite hard to detect in post-mortem toxicology due to their novelty. which leads to my point that I think there's a great recognition that we need enhanced toxicological and forensic data, particularly in this world that we're now seeing with polysubstance use and mixing. Also because of the growing number of synthetic drugs and new synthetic drugs. One of the things that we've had with the new mandate is the chance to open a network of forensic and toxicological laboratories in European countries. This has been launched this autumn and they had their first meeting just a couple of weeks ago. One of the questions we've also been asking for a while now is what are the possibilities of these new highly potent synthetic opioids coming and spreading and diffusing on Europe's drug markets? One of the reasons we've been particularly concerned is because we know when heroin is removed from the market, there's a gap which is typically filled by other products. We've seen it in the past. And we know also that there's been a Taliban opium cultivation ban for the last couple of years. This is likely to have a big effect on Europe's supply of heroin, as Afghanistan has been the main source. We know production fell by 95% in 23, according to UNODC. As yet, we haven't picked up a strong impact on the EU market, but the outlook is unclear, and this is an area where preparedness is important. And I will leave my presentation with this notion of preparedness and ensuring that we have got robust and resilient systems for identifying new problems and for responding to threats and to prevent these things happening. Two more of the new services for the EUDA, which we're in the process of establishing right now, is a new drug alert system linked to our early warning system and a new threat assessment mechanism, which we hope will be able to support countries to help to prevent and to combat these challenges. Thank you very much.
Completed our first speech. Dr. Jane Montany, thank you very much for this presentation.
Avrupa Uyuşturucu raporunun 2024 yılı sonuçlarını bize sundu.
Presentation about the results of the World Drug Report 2024. Of course, everything is not really in the positive manner, both for the use of such drugs and also for the mortality. We can see there is a significant increase, especially in Estonia, Lithuania. We have seen there is also an increase, especially for synthetic opioids. We have seen that. Thank you very much for the speech. Now we are going to proceed with the next speaker. So, wastewater analysis for psychoactive substances. So we are going to have two different speakers. First, Associate Dr. Selda Mercan, and then Professor Dr. Nebile Dağlıoğlu. And briefly, I would like to give information about esteemed speakers. Associate Selda Mercan, Istanbul University Cerrahpaşa Forensic Science Department.
2014 yılından bu yana
as of 2014, head of the toxicology lab.
Çalışmış. Aynı zamanda enstitü müdür yardımcılığı yapıyor.
Also the institute deputy director. As of 2024,
Uyuşturucu Bağımlılığı Ulusal İzleme Merkezi
National Monitoring Center TÜBİM, very valuable center by the way in terms of public health. We have been following this center, and also one of the scientific member of this scientific board. Forensic toxicology, epidemiology of wastewater, analytic toxicology, ethnogenetic, pharmacogenetics, and forensic science. Thank you very much. And the second speaker,
konuşmacımızdan da bahsetmek istiyorum. Profesör Doktor Nebile Dağlıoğlu.
Professor Dr. Nebile Dağlıoğlu.
Hocamız 2022 yılına kadar Çukurova Üniversitesi
Until 2022, working in Çukurova University in the Department to forensic science for forensic science and legal medicine. As of 2022, she is in Ankara University, Deputy Department Director, and she is also the member of different international societies, and once again, the deputy head of the Forensic Sciences and Legal Medicine Institute. Once again, we would like to thank our speakers in advance, and I would like to give floor to the speaker. Thank you.
Thank you very much, esteemed professor.
Mücadele alanında önde gelen bir sosyal kurum olan ve bir kuruluş olan Türkiye Yeşilay Cemiyeti'nin yapmış olduğu bu
We have
kongrede
gathered here for the congress organized by Turkish Green Crescent, and I will talk to you about wastewater analysis. First of all, I will tell you what wastewater epidemiology is and how long it has been implemented in Turkey. And right after me, Professor Dr. Nebile Dağlı Hoca will be talking to you about which substances are being tracked in the wastewater and what data they provide us with. Actually, we know about some parameters that are to be tracked in tackling with the addictions. This is a public health problem, and it is also a major problem for Turkey and for the entire world with its harms, and some evidence-based decisions have to be made and policies have to be developed accordingly. And for that reason, wastewater analysis have a complementary role. And also, it helps the decision makers effectively use the personnel and the resources. Among the complementary methods, we had the general population surveys, drug-related deaths and mortality treatment demand, and also the results of the cases that apply to the emergency units due to illicit drug consumption. And also there are data from the early warning systems that have been complementary and supportive methods. And for the last decade, we now have the positive findings that are based on the wastewater, and they also act as a key parameter. So what is wastewater epidemiology? It is actually an evidence-based monitoring tool, and it provides near real-time information, and it tells us about the drug analysis of a city in anonymous wastewater, because the foods that we consume or the drugs or the legal or illicit drugs are removed from the body through excretion and mixes with the sewer network. So based on those substances and metabolites, these methods carries out analysis, and it is not actually a very new method. It is going back to 90s, and it was originally used to monitor the environmental impact of liquid household waste. And at the beginning of 2000s, it was discussed whether or not it's possible to detect the illicit drugs. And in 2000, cocaine was detected in the surface water, and it then spread to the entire world. And it has been studied for long years, and because it is based on evidences, it is a very precious tool. What happened in our country with respect to wastewater analysis? In 2017, wastewater monitoring was included in Turkey's illicit drug action plan as a complementary indicator. And up on this, research were conducted, and in 2018, four periods of sampling were determined by the government and were planned annually. And currently, 71 cities and 136 treatment plants are being monitored in Turkey with the composite samples that are gathered every 3 months. And currently, we have 136 wastewater treatment facilities, and the samples are gathered 4 times a year. 24 hours composite samples are being collected, and this way we monitor the wastewaters. There are two laboratory pillars of this study. One of them is being conducted by us in coordination with Cerrahpaşa Medical Faculty, and Nebile Dağlıoğlu and her team have another analysis that they conduct at Ankara University, and it is now a routine examination, and there is a demand to propagate it to all the cities. And the annual 4-period monitoring project is conducted with the financial support of the Ministry of Interior and Department of Smuggling, Intelligence Operation, and Data Collection. And the Green Crescent is the nationwide project coordinator. Turkish Green Crescent is acting as a coordinator here. Formerly known EMCD, and the new name is EUDA, and it has an international monitoring system, and they have a community consumption map, and this study has multiple components in analytical chemistry, physiology, biochemistry, sewage engineering, spatial epidemiology and statistics, as well as conventional drug epidemiology, are carrying out this work with a multidisciplinary approach for monitoring the wastewater. And in 2007, this study was initiated with 19 European cities, and as of 23, Turkey is also included in this study with Istanbul and Ankara, and this study now covers 88 cities and 24 countries, and the samples are gathered for 7 days, and the results are reported to European Drug Agency, and this way they are contributing to this study. So which drugs are actually monitored? Professor Nebile Dağlıoğlu will answer this question. Thank you all for your kind attention, and thank you to Green Crescent for their extraordinary effort in tackling with the addictions. Have a nice day. Thank you very much, Professor Selda. You have already made an introduction. First of all, I would like to thank Turkish Green Crescent for organizing this Congress. This is a project that we have been carrying out for 5 years now. Selda has already mentioned about the details. Now I would like to tell you what calculations we make, because we receive various questions. Can you please speak louder? Thank you. This is now better. Okay, I will move closer. to the mic. Well, wastewater epidemiology is used for multiple purposes because it represents the urine of the people, and we are also following them in our projects, the new designed psychoactive substances. As you know, it is mentioned that there are 1,100 different psychoactive substances, but another one is defined every other day. And also, pharmaceuticals, sweeteners, antibiotics are being monitored, and this is used for multiple purposes indeed. During the pandemic, a group of people were indeed monitored for tracking the COVID pandemics. Also, it can help us see the public exposure to chemicals, pesticides, and other materials. Within the scope of the project that we conduct with the Ministry of Interior under the coordination of Green Crescent, we are following benzoyl guanine, which is the raw material of cocaine, THC, which is a raw material of weed, and also morphine is being monitored. While following morphine, you may think that morphine is also used in the hospitals for treatment purposes, and we indeed deduce the amount of morphine used for treatment purposes. Amphetamine and methamphetamine are also among the substances that we follow. And also we follow methylene dioxin, which is known as ecstasy. We also monitor for alcohol while calculating alcohol. The liter per consumed per capita is being calculated. Also, we can calculate nicotine for the amounts of cigarettes that are being smoked by the citizens of a city. As said before, pharmaceuticals can also be abused, as indicated in the reports. Pregabalin and gabapentin active substances are being monitored. In European drug report and also in our country, we have the ketamine data. Ketamine is also being sold across the world as pink cocaine, and we are also following the active substances. Also, there are new psychoactive substances, and there are too many varieties. There are so many more that are not being currently marketed or sold in our country. And while analyzing our parameters, we indeed list the substances that are being seized the most in our country, and also we still track the other ingredients with our devices. So new psychoactive substances, alcohols, illicit drugs, and prescription drugs can be monitored this way. So what is the methodology that we employ while carrying out our analysis? Composite samples are gathered for a week, including the weekends from the wastewater treatment facilities. We can also compare between weekdays and weekends. We can compare the seasons as well. We can see which substances are on the rise during the summer season or during the winter season. We have a software for that. We evaluate all the data and we report accordingly. All the wastewater is sent to the relevant analysis through cargo within 48 hours, and we have our lab, and the labs are special. The labs are being audited every year, and this way we conduct our analysis. And after the analysis is completed, the critical part is the calculation method. For example, there is a raid and the narcotic substances are thrown into the restroom, and that might be leading. Yes, it might be misleading for some substances, but for many others, we actually calculate according to the metabolites. So there is a main substance that enters the body, and then the body turns that into a metabolite. And because we are calculating based on that, misleading information is eliminated this way, and we calculate that using a software method. But this is the formula that we have. We use the flow rate, how much water was treated in the correction factor is taken into consideration. And also another trigger is the population living in the city. It is also very important for our formula. Population may also have its variables. For example, we could not collect water from the earthquake zones, or there was a very significant migration from the earthquake zone to the other cities, and they also affect our results. Therefore, the change of population is important. For example, population also changes in the summer season, so we take them into consideration for calculation purposes. There are also many restrictions, many limitations, but we also indicate those limitations because some of them are not very stable in the wastewater. For example, heroin cannot be measured. Therefore, we're based on the morphine calculation. And also the loss in the population is affecting us. And for that, we have population correction methods. We're calculating the mobile phone usage, for example, to see whether or not if that wastewater treatment facility is serving the same amount of people. The flow rate is also very important. So in the software program, we have to enter the flow rate as well. Some environmental factors are also included because a wastewater treatment facility in which industrial wastes are being thrown may also affect our study results. And as said before, the way of excretion may depend on the person, may vary. And in the most recent studies, we are now using the daily calculations and also how the substance is being used may be very effective for calculation of the relevant material. We mostly calculate the population between the ages of 15 and 64, and that corresponds to 70% of the city. So we cannot, of course, calculate which group of age is actually using substances more, but that is giving us an overall idea. So they are very important factors, and also the amount of active substance in the material that is seized is important. Wastewater epidemiology has many advantages, but we should also be talking about its limitations, because these limitations are often asked us. EUDA has organized the wastewater conference, and we attended this conference as well, and we presented our studies, and we also had a chance to see what the other countries are doing, and we made some joint decisions. We are also a member of the SCORE group, and SCORE group is reporting the wastewater results of Istanbul and Ankara to EUDA. The laboratory team of Ankara University, it is actually a very hard work, because you have to work with the sewage water, and you have to put a lot of effort for the scientific analysis. So this is the team we have been working with for 5 years, and there will be some alterations in the upcoming period. We would like to monitor it in all of the cities, but the wastewater treatment of each city is not representing that city. Therefore, we can only work with the wastewater treatment facilities which are meeting the criteria. Thank you very much. That was my presentation. Hopefully, I made use of my time effectively. Thank you very much, Selda Mercan and Nebile Dağlıoğlu. Thank you very much for your great presentations. I followed your presentation with a great attention. You indicated very significant information indeed, and also for the environmental health and public health. This is very important. In the next months, we will be visiting the wastewater treatment facility in the city of Muğla, and I will let them know about this information. And you have mentioned that you are sampling 4 times a year in 71 cities. This is a very big effort, and thank you very much for your presentation. I would like to move to the next presentation now. The next presentation will be the third and the fourth speakers presenting jointly, Professor Dr. Serap Enet Akgür. Hopefully that was the right pronunciation, and Professor Dr. Mine Kadıoğlu Duman will be presenting, and we will learn about cannabis use and forensic toxicology. The floor is yours.
We are going to start with Professor Dr. Serap.
Thank you for your kind introduction, Dr. Metin, and I am thankful to the organizing committee. Good afternoon, dear all audience. I am forensic toxicologist, and I'm working in Ege University at the Addiction Toxicology Laboratory. As you know, our topic is cannabis and forensic toxicology. We know that cannabis have 2 dimensions. One is medical dimensions, the other is legal dimensions. Therefore, we know that the cannabinoid analysis should be made with forensic requirements. Archaeological evidence shows that the use of cannabis dates back almost 10,000 years. The origin of cannabis is Asia. It's from Asia moved to the west part of the world. But now the legalization moved from west to the east part. This is life. I can say hundreds of compounds have been identified in the cannabis plant, a significant portion of which are unique to the plant are called cannabinoids. The psychoactive tetrahydrocannabinol delta-9 THC, the main psychoactive component of cannabis, is responsible for the euphoric effect, has analgesic, anti-emetic, anti-inflammatory, antispastic, and antioxidant effects. Cannabidiol is another cannabinoid, is secondary, and it's not psychoactive. We cannot get euphoric with this, but has anxiolytic, antipsychotic, and anticonvulsant effects. When we look the nomenclature, we see hemp, marijuana, cannabis. Know that cannabis plant is used as a fiber in industrial areas. Its seed oil is used as a food and cosmetics sector, and also its pharmaceutical preparations used for medicinal purposes. So we call this hemp when used as a fiber and oil, but when it's used illegally for psychoactive effects, we call them marijuana. About hemp, industrial cannabis, is characterized by low delta-9 THC content. The cannabidiol is high. But when we look, as you see in the figure, with time, the THC levels increased, but the CBD levels has not changed. Unfortunately, psychosis and paranoia now is much more common today, because the THC increase and the antipsychotic CBD has remained at the same level. Cannabis legalization and decriminalization have become prominent topics globally. When we look at our world map, you can see, because many various countries give permission for recreational purposes. The distinction between legalization and decriminalization is crucial. Legalization is the formal approval of the use of sale of cannabis, but decriminalization is generally the reduction of penalties. The safety profile for recreational drugs are difficult to determine. We know that with legalization, many cafes and shops are very common now. But we know that it took 70 years or more for the harmful effects of tobacco smoking to be recognized. Now, the consequences of the rapid increase in the number of such cafes and shops following legalization will be seen in the future. In 2015, cannabis addiction was defined for the first time in DSM-5. We know that different ways is for exposure, edibles, drinkable things, cosmetics, medicine, etc. For prescriptive drugs, we can say FDA-approved drugs have been carefully evaluated for safety, efficacy, and quality. But what about CBD, cannabidiol, sold over the counter in the form of cosmetics or dietary supplements? We know that CBD-based products have many unapproved medical uses in the form of oils, supplements, and are available online in highly concentrated extracts for treatment. The THC concentration and the effects are mystery. We also know that cannabinoids containing edible and drinkable is also growing. And as we know that these developments made cannabis analysis even more important. Here you can see from UNODC the guide for analyzes these substances. We know that in cannabis plant there is many compounds, more than 500. And also we know that the cannabinoid metabolism is very complicated. With the technological development, recent studies show that there are different THC isomers, and they have also psychoactive effects like delta-9 THC. Here you can see delta-8 THC. These isomers are a group of compounds structurally related to THC, but they are produced from cannabidiol. In plant is very small amount, but they can be produced from cannabidiol. We know that CBD is currently recognized as non-psychoactive, but the produced isomers, for example, beta-8 THC, has been shown to have psychoactive effects. It is certain that CBD degrades to psychotropic products in acidic environments. You can see the pattern of the conversion of CBD to psychoactive tetrahydrocannabinoids. So we should think about the storage stability of commercial formulations, and we should think about it. This transformation, this conversion will affect for justice. It is very important also for clinical approaches. Unfortunately, THC isomer are perceived as legal both by users and vendors. And so this allows for their sale in both shops and online. With more states working to decriminalization or legalization for cannabis use, drug screening deserves a closer look. We know that there is experimental evidence that cannabis impairs several cognitive skills and related to driving ability. What about analytical and interpretive challenges associated with other THC isomers? So, as many state laws have grown increasingly, permissive recreational cannabis use and so drug testing laws have also evolved. But now the most common question is, if cannabis or marijuana is legal, can employers drug test? We know in a workplace we should be free from drug and alcohol. For example, in New York, where recreational marijuana is legal, they prohibit employers from testing. They will not test it. But some other states, such as Georgia, they are still banning marijuana. So, in conclusion, problems that have developed with the regulations on cannabis in the world, recreational use, edibles, drinkable products, have become a cut cause. The long-term consequences of this practice in terms of public health and public safety, both on an individual and social basis, will be difficult to predict. Now, new analytical and forensic toxicological regulations and forensic awareness become more important for justice. In this session, we want to point out that the individual and social consequences that may arise by the use of recreational cannabis and cannabis products. Dr. Minevil, after me, will talk about the part 2. At last but least, I want to inform you, it's my honor to announce you that the largest society of forensic toxicology, TIAFT, 64th annual meeting will be in Turkey in October in 2027. Thank you for your listening.
Hello to everyone. First of all, I want to thank to the organizing committee and the listeners here with us. I am from Karadeniz Technical University Faculty of Medicine, Department of Pharmacology. I'm a pharmacology professor, and I will take the place for after Dr. Sarah for the passive and unintentional exposure. She told us before that marijuana-related pharmaceuticals are growing higher and approved in the USA are listed in the slide you see. They all have different indications for the usage. But is marijuana or cannabis really innocent to be just a drug or to be legal in the all over the world? If you take the chemicals containing the cannabis plant, the cannabis is the most widely used illicit substance in the USA. But the concentration, active chemical content has changed during the several years because of some cultivation processes, growing methods, and so on. And cannabis can affect the brain, or the related reports show that us. Cannabis can be used with several routes, and by inhalation and ingestion, there are some pharmacokinetic differences they have. So it's important how we get the cannabis to the brain. Because when we look at the pharmacokinetics profile, if we take the inhalated marijuana, the beginning of the psychoactive effects occurs rapidly, and the people feel to have the highest effect nearly at 15 or 13 minutes, and it can last up for 4 hours. These effects are related to plasma delta 9-THC concentrations. So it's nearly approximately 2 or 3 milligrams of inhalated THC is sufficient to have these effects in a naive user. But if an addicted person is the situation, it can change. Pulmonary bioavailability is also changing according to the inhalated dose. 10 to 35% is absorbed and bioavailably reached to the brain. And it depends on the depth of inhalation, duration of puffing, and breath holding of the person uses it. So it differs from person to person. A person can use use the inhalation method by several devices, as you see in the slide. If the situation is ingestion, ingested marijuana also differs from the inhalated one, because this time you have to take the products from the mouth, and it also has to pass through the gastrointestinal system and have to be absorbed. So the psychoactive effect won't be it won't be easy to get the psychoactive effect as easily as in the inhalated marijuana. So it takes 30 minutes to 3 hours for the person who eats the products of marijuana to feel the effects. And clinical effects also will last so long as 12 hours. So orally administered cannabis has low bioavailability, not as the inhalated marijuana, because of the gastric acid degrades it, and the substance absorbed to the blood will first pass metabolism in the liver. So ingested marijuana differs from the inhalated marijuana. In naive users, psychoactive effects occur with 5 to 20 milligrams of ingested THC. When we talk about the toxic effects in adolescents and adults, this is the problem, because recreational cannabis intake to achieve psychoactive effects can often result in adverse effects, because there isn't any clear demarcation mark which dose will be the best dose for achieving symptoms that the user want, and which dose will be the demarcation hat that the adverse effects will begin. So it differs from person to person, from the using time also. In adolescent and adults, the reported studies have shown that inhalated dose of 2 to 3 milligrams of delta 9-THC or ingested doses of 5 to 12 20 milligram of THC will impair attention. It will affect the motor coordination and badly affect short-term memory, and short-term memory loss will be seen. If the dose goes up as high as more than 7 to 5 milligram per meter square of THC, then the severe adverse effects will be seen, including nausea and vomiting, some cardiovascular effects, and also some neurological effects. And at the end, psychosis will be seen. And psychosis can be seen at the first use or several uses, and it changes with the higher potency or concentrated marijuana products. So it's really a dangerous situation for the users. Toxicity in children is also a deep situation, because children can ingest accidentally some food products or hashish resins, which will contain highly concentrated cannabis. And from 5 milligrams to 13 milligrams in pediatrics can produce so much symptoms. The symptom range will be such as mild sleepiness or some motor activity increase like hyperkinesis, and more severe intoxication symptoms will be respiratory depression or coma. So children are the most important people that we have to protect from the cannabis. Passive unintentional exposure is something different because the person don't want to take the cannabis products. Passive exposure to cannabinoids will be just being in the environment where it is smoked or where it is used, and occurs not only by inhaling cannabis smoke, but also by touching direct contact with contaminated objects. It is called second-hand exposure and third-hand exposure, this situation. And second-hand cannabis smoke in the air contains also very same toxic and cancer-causing chemicals like in tobacco smoke, and sometimes more higher in amount than in tobacco smoke. And also it contains THC. This is the responsible of the psychoactive effect of the marijuana. And it can pass to infants and children unintentionally because of the caregiver or the people around the children if they use it. And also second-hand cannabis smoke will be cause the psychoactive effects of the children. If a person, as you see in the picture, smokes in a closed room, a cannabis cigarette, and the air will be full of cannabis, THC, and it will also pass the other rooms from the air conditioner, and it will affect the people in the other rooms. And the cannabis content, the strains of the cannabis products will also be found in the furnitures, in some objects, and also in some food products. So if a child or a baby exposes these, it also will affect the baby or the child. Unintentional exposure is a big problem in the United States, where the legalization is now common. Recent studies have found a strong association between the reports of having someone in the house who smokes the cannabis, like a parent or a relative or a caregiver, and even a babysitter, if she uses or he uses a cannabis smoke, and the children will have detectable levels of THC. There are several reports showing this one. So our primary responsibility is to protect children and the babies. Second-hand smoke is not just problematic one, because in the legalization parts, in the European and the US part, the cannabis edibles are also a problematic usage because they are very similar of well-packaged brown known branded snacks and candies. As you see in the slide, Sour Patch in the bottom of the slide is a known branded snack, a sugar coated candy, and the upper side of the slide there is also cannabis containing, looking like the original one, a candy spread out in the US to be used by the children and adolescents. So children who takes the THC containing products, who exposed to THC containing products can become very sick, and this is a big problem seen as in USA. Some researchers shown that cannabis use during adolescence can impact the developing teenage brain, and it can be shown and supported by the MRI imaging. And teenage brain is really damaged from the beginning to the exposure, depending on the exposure time and the exposure content. And it causes problems with attention, motivation, and memory. So the school warnings are included in the advertisements. Edibles, food and drink products also be a problematic usage of cannabis because there are some cannabis infused products in the markets which can be easily get by the young people, and they contain different risks than smoked cannabis, a greater risk of poisoning and exposure higher than the amounts. And edibles can affect individuals so differently. Unlike smoked cannabis, edibles can take up 4 hours to the high. So when they eat a candy, they wouldn't be able to feel the highest pleasure with that candy. So the big mistake for the users will be continue to ingest edibles, eating cookies or candies more and more, and because they want to feel high, but the high will be hitting hard them because, as I said before, ingested cannabis will take so long hours to get to the brain, and also will last for several hours, longer than the inhaled cannabis. So with edibles, leading to poisoning and serious injury and causing some people to go to emergency departments are getting higher in US, where the legalization is nowadays supported. Intoxication effects may last longer than expected, so depending the amount of ingested, and if the person eats it on an empty stomach, it will change. If the person also gets some drugs and some medications or other illegal substance, it will also change. And if the person uses alcohol at the same time, and some personal pharmacokinetic factors also will affect the amount of cannabis ingested. The amount of THC and the concentration and strength is difficult to measure and often unknown and inaccurate as labeled on edible products. If you take a cookie saying 100 milligram cannabis containing, it won't be really the sad one. So many people who use edibles can be affected by their strength and long-lasting effects. So it is not an innocent thing to ingest cannabis by the gastrointestinal tract way. It's thought that inhalation is worse, but it can be worse by the ingested ones also. In 2021, FDA also wants the whole world. More than 250 calls were made to the National Poison Control Centers for Delta-8 THC among children. As Dr. Serap told us that cannabidiol is changed to Delta-8 THC. So we know that cannabidiol is not a psychoactive substance. It's just can be used for treatment of some diseases. It doesn't have harm effects, but if the person inside his body or her body changing the cannabidiol to Delta-8 THC, then the person will also feel the psychoactive effects of the edible or the product that he or she used. So FDA warns the THC-infused threats reaching children, especially during the Halloween season, as we are now in this season. So in the market, there are lots of problematic products. By the legalization, there will be several problems. Also, water quality will change, as we talked before in the beginning of this session, and excess water utilization will be problematic. And also, there are some problems with the legalization. The countries that legalized cannabis use states that increased marijuana use decreased opioid-related deaths, but the real data shows the opposite. And increased marijuana use will increase marijuana-related emergency department visits, such as intoxication, burns, childhood exposures, and childhood problematics. Increased cannabis use will also affect the environmental contaminant mixture and environment and the nature also. This must be kept in mind when the legalization is talked. For example, when you look at the slide, tamam. This advertisement is from a bakery who sells THC products, and the poison is given to the bees, and they forced to produce CBD containing products. And she talked about hemp oil and CBD oil. Regulations will be affected by these usages. I'm passing the slide, and this is my last slide. If the legalization cannabis containing cosmetics, foods, and cannabinoid drops and similar products sold out so easily, more people will be using marijuana than ever before, and this will affect not only the people, also the nature. Thank you very much.
I would like to thank both the speakers for their presentations. We have already exceeded the time allocated to us. We have several questions. I believe you have seen the questions. There are several questions for Selda Mercan. And Professor Nebile can answer the question. Go ahead, please. Well, the question is if the painkillers all have opiate, and not all of them have opiate. In the opiate analgesic group, which is also defined as narcotic analgesic group, there are synthetic and semi-synthetic opiates, and we can identify them with our methods. We can see whether or not they're non-steroid inflammatories or paracetamols. We can easily identify that. And what is the benefit of the analysis in our country? We share the results of our studies with the relevant units of the Ministry of Interior, and as a result, the law enforcement officers, the police, and the gendarmerie, the narcotic branch of the relevant cities and addiction units of the Ministry of Health, And at the end of the year, the data that is gathered from the Ministry of Justice as well as the material substances that are seized are considered for creation of a report and the relation between them and whether or not there is any difference in the seasons, in the periods, in the cities. So this gives us a lot of information and that comes in handy for taking action in different steps of addiction. It also helps us shape the short-term and long-term actions. TÜBİM is sending the relevant information to European Union drug agencies, and if there are any new psychoactives that are identified, if they are identified in the labs, the relevant labs statements are taken into consideration, and Turkey is providing EU with active information in this regard. Thank you very much for the questions. There are some questions for Professor Nebile as well. The labs that will conduct these analysis must be forensic toxicology labs, and the forensic toxicologists have to interpret the relevant information. Every lab can indeed carry out these analysis, but those labs have to be included in the score group, which is audited by EUDA. There are numerous synthetic materials, and at the beginning of each year, we are analyzing them, and we are also using early warning systems, and we are including the products in our panel, and we are also analyzing the former panel as well. There are changes depending on the season, especially during the summer season in the tourism areas. There are changes. And also we are now studying the treatment facilities in the touristic areas. Also, along with the winter season, the use of substance increases, as Zelda also indicated. We have the activities to tackle with the addictions in our country, and this also indicates that whether or not they are effective, and also intervention programs are developed accordingly. Thank you very much. Well, thank you. We don't have any time left, but I know that there are questions. Maybe we could ask Mine and Serapene to answer one question only because we don't have any time left. I would like to talk about the crimes that emerge as a result of legalized drugs. Even if we don't commit any crime, traffic accident is a crime as well. And we know that the traffic accidents increase by 50% in the legalized countries. That is a deterrent information, yet the legalization is still increasing. Thank you very much. The first question is about difference between respiration and ingestion systems. There are differences as indicated by the studies. Are the individual factors important when someone who has a disposition for psychosis will enter psychosis more quickly, of course, and second-hand cannabis use? The parent or the caregiver using affects the infant significantly. I am now adjourning this session, and I would like to thank the professors and the speakers for their presentations. These have been really great presentations. They have been very helpful, and because they are up to date. And I would like to thank the organizing committee and the scientific committee of the Congress, as well as all the other relevant people for their efforts into organization of this Congress. Have a great and fruitful conference. We would like to thank the chair and the speakers for sharing their presentations and time with us. Thank you very much. We have been honored. We will have a short break, and right after the break, we will be here with you with the final session of the day.
Dear participants, our Congress continues with the sixth and the last session. The session chair is Dr. Mehmet Güloğlu, who is Vice President of Turkish Green Crescent Society and Ambassador of the Republic of Turkey to Tanzania. Our speakers who will be with us in this session with their valuable speeches are dear Judith Tawala, who is member of the Recovery Alliance Learning Collaborative for Asia and Africa, Dr. Tajuddin Abiola, who is Secretary General at Green Crescent Nigeria, and Dr. Balkis bint Mohammed Qasim, who is Secretary General at Green Crescent Malaysia. I would like to welcome you all for being with us in this session. And Dr. Judith Tawala will deliver a speech entitled The Effectiveness of Drug Addiction Treatment and Rehabilitation Services, while Dr. Tajuddin Abiola will deliver a speech entitled Navigating the Complex Landscape of Addiction, a critical examination of evidence-based approaches and contextual challenges. And Dr. Balkis bint Mohammed Qasim will deliver a speech entitled Preventing Psychoactive Substance Abuse, Green Crescent Malaysia's Comprehensive Approach to Education and Community Empowerment. Now, to kick off the last and the sixth session of the Congress, now I kindly leave the floor to Dr. Mehmet Güloğlu, our esteemed session chair, to conduct the session. The floor is yours, Dr. Güloğlu.
Thank you very much, Madam Rumeysa. As Madam Rumeysa already mentioned, we have 3 guests now. And then without losing time, I just want to start from Madam Judith Tawala from Kenya. She's a certified counseling psychologist and currently the Deputy Director of the Public Awareness and Advocacy at National Agency for the Campaign Against Drug Abuse. I don't know if you can say NACADA in Kenya. Tawala holds a master's degree in counseling psychology from Kenyatta University. As a recovery advocate, Tawala has represented Kenya in both local and international forums. As we heard already, we will listen from her the effectiveness of drug addiction treatment and rehabilitation services. Madam Judith Tawala, floor is yours. Welcome, Karibu.
Thank you very much, and hello, everyone. I will not repeat my name. Again, our facilitators have already done that. I am going to take us through the effectiveness of drug addiction and treatment and rehabilitation case study of Kenya. An overview of the topic. We have a rising substance use in Kenya, and it has become a public health crisis. The key stakeholders that work within this area of addiction, treatment, and rehabilitation include NACADA, which is an institution under the Ministry of Interior and National Coordination that oversees prevention, harm reduction, recovery, and regulating all rehabilitation centers in Kenya. We also have the Ministry of Health, which works very closely with us because they are the ones who develop treatment protocols. We have the rehabilitation centers as one of our critical partner. Both private and public rehabilitation centers are run in Kenya. We also have community-based programs that supports persons in addiction and recovery, which includes the civil society organizations and also faith-based organizations that run rehabilitation facilities in Kenya. The purpose of this presentation is to assess how effective Kenya's treatment and rehabilitation services are in addressing drug addiction. We will look at the challenges, the effectiveness, and finally recommendations. The state of drug addiction in Kenya. As per the National Baseline Survey that was done by NACADA in 2022, it is approximated that 6 million Kenyans are engaging in harmful alcohol and drug use. These are people who have substance use disorders currently. There is increasing prevalence of cannabis, heroin, and prescription drug abuse. And we are seeing a rise in use of cannabis among high school students and also tertiary institutions in Kenya. It is very shocking that we also have a rise in prescription drug abuse in Kenya. There is an emerging trend of synthetic drugs where university students are sitting in their houses, doing some Google search and mixing different substances which are causing zombie-like effects. The populations that are rated highly at risk are the youth, the urban residents, and the unemployed individuals. This has brought an impact on economic burden because we don't have sober people who can really be productive in this country. Then health complications as a result of overdose and abuse of these substances. And of course, social disruptions because of the petty crimes, drug users engaging in petty crimes so that they can get substances of choice. What are the treatment and rehabilitation approaches we are implementing in Kenya? We have prevention and outreach programs. We believe that prevention is better than cure, but we still try to balance because we are aware that there are people who really need treatment and rehabilitation programs. We have inpatient and outpatient rehab programs. We have behavioral therapies. We apply CBT, that's cognitive behavioral therapy, motivational interviewing, among other approaches. We also have detoxification services, MAT centers, and drop-in centers because we realize that most people who are using drugs, they don't have the basic things like soaps, sanitary towels for women, and then these are achieved through the drop-in centers. We are also implementing the alternative to incarceration program because we realize that there are people who go to prison who are petty, maybe peddlers or drug users who should not be in prisons. Otherwise, they should be getting treatment programs. We also implement rehabilitation and reintegration services because we know once somebody has been discharged from a rehabilitation center or from an outpatient program, they need to be reintegrated back to the community. We also have support groups, that is alcoholic anonymous groups or narcotic anonymous groups, including community and religious support fora. We have some of the churches or some of the mosques that have offered their space to support persons who are in recovery or people who are in active drug use, meet in those forums to encourage each other, to motivate each other to stop drug use and live a sober life. The key providers for these services include public facilities. We have national hospitals that are providing treatment and rehabilitation programs. We also have county governments, other than the government-owned hospitals, we also have county governments who have already initiated these rehabilitation programs. We have the CSOs and the faith-based organizations that are running these facilities and making treatment and rehabilitation very affordable and accessible for all citizens. And NACADA comes in as a regulator for these facilities. Why has it been effective in Kenya? Our strengths include, we have borrowed from the national standards for treatment for persons with substance use disorders and developed, contextualized our own national standards and treatment protocols. We have also developed national aftercare guidelines and sensitized all the service providers on these aftercare guidelines and the standards, so to ensure that people who reach out to them get quality services in those facilities. We have also seen increased availability and affordability of treatment centers by initiating the public facilities and also the community-based rehabilitation programs. Incorporation of evidence-based therapies has been one of our best practice. We don't just implement programs, we draw from science-informed programming. We also do impromptu checks on the rehabilitation facilities just to make sure that these services, quality services, are continually provided to persons with substance use disorders. We continually capacity build addiction professionals and now recovery allies, recovery peers, to ensure that the people who are implementing these programs are well informed, they are well trained, they are not doing things from their own minds. We also continually community sensitize to reduce stigma. In Kenya, the stigma that surrounds alcohol and drug abuse addiction is still very high. So what we are doing, we are continually sensitizing and advocating for persons with substance use disorders to be involved when we are developing policies that affect their lives. And we believe there is nothing for persons with SUDs without them. So we are really advocating for their incorporation in development of policies. The main challenges that we have seen is the stigma that surrounds addiction and its management. We have had instances where people say that their people have gotten jobs in Saudi Arabia or in Qatar, yet they are being rehabilitated in the country. So that stigma has really been a challenge for people to seek for rehabilitation. Hence, we are really advocating, using the media fora, using the religious leaders, ensuring that every citizen in Kenya knows that addiction is a disease, and when somebody gets treated, they can be responsible citizens henceforth. We have very few facilities designed for women and adolescents. Therefore, most of the times, women who are struggling with SUDs, they find themselves mixed in a center with their male counterparts, which has been a challenge. This now makes it difficult for them to express their underlying issues and also to get effective treatment as they deserve. We do not have many adolescent-designed facilities, and yet our national survey for this year shows that adolescents are the mainly at-risk population that need help. So this is something we will continue advocating with policymakers to make sure that we implement and develop women and adolescent-specific facilities. Then lack of standardized costings has also made it very difficult, so that most rehabilitation facilities just charge as they wish. So we are really trying to work with the Ministry of Health to make sure that this costing is standardized and affordable for all Kenyans. Key recommendations under policy and regulation: increase funding for public rehabs to enhance accessibility. We only have 9 public facilities in the country against 192 private-owned rehabilitation facilities. So we want to lobby for more funding so that we have more rehabs that are public, making it accessible for Kenyans. We also need to enhance implementation of programs specifically designed for women and youth. I've recently spoken about this. Then we also need community engagement, more community, empowering the community to own these facilities, to own people who are struggling with the substance use disorders, and to treat them with the dignity that they deserve. And this will help reduce stigma, of course, through advocacy campaigns. And then we also want to leverage more on grassroots organizations for continuity and support. We have seen the strength of working with CSOs and FBOs. It is very, very efficient and effective. In conclusion, Kenya has made strides in addressing drug addiction, but faces critical gaps in accessibility, funding, and capacity. Call to action: collaboration among government, private sector, and communities is extremely essential. My closing thought: recovery is not just about sobriety. It is about restoring hope and dignity for persons with substance use disorders. Thank you.
Madam Tuvala, thank you very much. It was really very fruitful and helpful to see Kenya's experience, how Nakada is managing it. And you had very key and important message about restoring hope and suggested about how to increase the accessibility, funding, and capacity. I think in the populations like in Kenya, which there is huge young population and there's an increasing population, the key message that you said about recommendations, how to get easier funding and also to think about women and childhood, women and teenage group, I think is very important from your experiences. Thank you very much. After the speech, we will have the questions and answers, but now I want to pass to the second speaker from Nigeria. Dr. Tajuddin Abiola is an experienced psychiatrist and psychotherapist with extensive academic, clinical, and public health experience. He holds a fellowship certification in adult psychiatry from the National Postgraduate Medical College of Nigeria. And he has experience in different hospitals. And he is the Secretary General of the Green Crescent, Nigeria. Dr. Abiola, floor is yours. We will be hearing you navigating the complex landscape of addiction, a critical examination of evidence-based approach and contextual challenges. Welcome.
Best of the day, everyone. Thanks for having me on the event. I will be talking about the various challenges that the landscape of addiction, of course, and be making a critical examination of evidence-based approaches and the contextual challenges. What is the understanding of addiction? Because this is going to provide the context for what I'm going to be talking about. Addiction is a critical global health issue that affects millions of lives globally. Approximately, based on WHO 2021, more than 31 million people suffer from drug use disorders. This is not talking about people who are using, but people who are suffering from the extreme challenges, extreme sufferings from getting the disease of drug use. The impact on this individual is more than them. It also affects their families, the community, and the entire society. And this is because the drug addiction contributes significantly to global burden of diseases, because it's a leading cause of mortality rate, it's a spread of infectious disease, and it leads to a loss of economic loss. And they are intricately linked to other major global challenges like poverty, crime, mental health, and other health issues. They strain the health system and social services, and the law enforcement resources are also strained in the process. So substance abuse is a globalized nature, continue to spread globally because of the transnational concerns, where it can be easily moved from one area of production to another form, either through the sea, the land, or the air. I will try to be fast. I'm trying to navigate the complex landscape of addiction, of understanding addiction. And I've tried to say that in this slide that addiction is a major cause of suffering globally. Apart from causing the suffering as a disease, it also causes other sufferings, which affects economy, it affects crimes, and it causes other health problems, not only mental health challenges, it causes other health problems, physical illnesses, infectious illnesses, it contributes to it. So that's why it's one of the leading causes of death globally. And the widespread of the use of addiction is as a result of transnational ability, in ability to transport and move products of addiction from one area that is grown or cultivated or developed or synthesized to other areas where they don't have the capacity to do that. So this makes it available. It makes it more costly in those areas, but it spreads the arms from the addiction. And that's why it's crucial to address this. And that's why it has been a major focus of the United Nations Sustainable Developmental Goals to see that addiction is reversed, and so that we can improve health and reduce poverty and increase social justice. The tension between addiction are due to several challenges, and these are the category of challenges, categories of tensions that do come up. That's the socioeconomic group. This leads to challenges of poverty and unemployment, and also loss of access to treatment, because it has been found that only 10% of people who have access to qualitative advanced treatment for addiction are in developed countries. The people in developed countries, they don't have access to it. Despite the high rate of opportunity in developed countries, the opportunity to get access to treatment is also low. The other category are cultural and stigmatization, because use of that leads to high social stigma, which prevents people from seeking for treatment. And there are many other cultural norms which moralizes addiction instead of seeing it as a disease that needs to be tackled and be treated. There are other legal issues too, which the first presenter have talked about, issue of penalization, criminalization, incarceration, and all that, because we don't have adequate regulation that distinguish between a peddler, a drug dealer, from a drug user. A drug dealer should be penalized, they should be criminalized, and should face the full wrath of the law. While a drug user is the victim, is the one being utilized, is the one being exploited, and is the one that the Lord needs to look at and provide treatment for, so that they can get out of the hook of the danger of addiction. Then it also affects the health system in several ways. Apart from draining the resources of the health system, we don't have enough trained professionals who can offer qualitative service for people who have addiction problems. Then globalization also keep contributing to the problem. Technology has played a big role. There are now dark webs that provide avenue for people to have access to addiction substances, that people can buy it on the dark web and it can be delivered right there at their doorstep from anywhere in the world. So all this global trade, which have its own good parts, but the dark side, which is the dark web, provide access to this and contribute more to the problems and the challenges of addiction. Then we have the psychological and social dynamics, where they continue to be sources of causing other diseases and occurring with other diseases, and also creating more bad peer pressure instead of the good social influences that we needed to make the society great. And relapse and aftercare are difficult because there is high relapse rate, despite people having access to high qualitative treatment. And the cost of that is also difficult, because when people have addiction problem, they lose their sources of livelihood most of the time. So for them to be reintegrated, to be rehabilitated, to be able to get some other skills, to get job is more difficult and challenging. What are the tensions of the several approaches of treatment? That's looking at prevention, treatment, and recovery. This has been labeled as war on drugs, and one can look at it from these three perspectives: struggling against drugs, struggling for addiction, and struggling with addiction. Struggling against drugs are what the majority of the people in the community wants to do, because they view addiction as a moral failing or a criminal behavior. They may emphasize criminalization, not necessarily that people should be penalized, and they are in support of abstinence. However, the policymakers are doing this without often getting results to where the evidence is. Those who struggle for addiction are the people who, through social movement, wrongly labeled the social movement as harm reduction. So people get confused, try to understand what's the difference between the actual harm reduction and these people who are denying and who are promoting this addiction availability and surplus for people. And because they minimize the negative health and social consequences of drug use, they deny that abstinence is the ultimate goal of treatment or prevention. And they refuse to address the root causes of addiction, like the peddlers, where they are prepared for finding the right legislation, bringing policies that will encourage people to grow food crops or cash crops rather than addictive substances. So all the people here are struggling for addiction. They are promoting addiction. They are also there, and they are part of the people there that shout loudest that the war on addiction is failed and people should not look at it, and they now label it as harm reduction. People should follow harm reduction in quotes. But there are those who struggles with addiction because they have the evidences. They will follow through holistic approaches. And from me, they learn from medical, from the psychological, from the social and spiritual lenses to be able to have a comprehensive approach to help people who need to be prevented from it, people who need to be treated, and people who need to recover from it so that they can be full functioning member of the society along the line where they find themselves. And one of the main tension of the current world that we are in now is the tension of one size fits all, which, like I mentioned before, is wrongly labeled harm reduction as against harm denying. And the table below tries to show us the difference between actual harm reduction strategies and harm denial, which is a social movement approach. The danger with even the actual harm reduction is, yes, it's good, it's an approach, it's like a middle way of treatment to get people to the final end. But when this is overemphasized and not letting people get to that end where abstinence is, it just takes only one bad day that it makes the person to relapse because all the enablers are always available and the person begins to cycle all over again and the suffering all over again. So harm reduction, according to several authorities on it, I've seen it as one of those public health policy that help people to make a choice to live healthier, to be self-directed and purpose-filled life. So as against harm denial, which is a social movement, people are saying, which is the loud noisemakers around now and shouting harm reduction is the way. And these are the people that downplay all the troubles, all the challenges of drug use. And when we look under actual harm reduction, what is the strategy to promote? They talk about safer use, they talk about managed use, they talk about abstinence, they talk about meeting people where they are, addressing condition of use, and with the use itself. So this they never shy away from abstinence as the end goal of it. And that's why they understand harm reduction as part of the continuum of care from severe use to abstinence. And they do not minimize or ignore the real and tragic harm and danger associated with drug use. But for the harm deniers who are chameleonic in nature by calling themselves harm reduction group, they claim that all drug use is a personal choice and does not harm others, which is not true. It harms the individual and it harms the other people, the loved ones, and it harms the society. They promote the idea that drug use is a fundamental human right, and they reject the need for evidence-based treatment and harm reduction strategy. Actually, they reject it, and they are not promoting it because that will go against their goals of increasing the sales from harm reduction, of blaming people who are using it as the one who are calling the irresponsible users, or people who cannot reduce their use, and they rather blame the people they turn to victims and make them victimize them more, rather than looking at what is the root cause of the problem, which is the drug abuse. So how do we bridge the gap in this? And that is where the evidence-based come out, and this is to embrace the holistic model. The holistic model is a flexible delivery approach, which is based on several strategies that research, experience, all are be integrated together to meet the needs of the complex landscape that addiction prevention, treatment, and recovery all intertwined. So this talk about the personal treatment plans. It looks at combining elements of harm reduction and abstinence together to see that the individual can have a whole package from severe use to abstinence. And they promote community support and social integration to see that people who are suffering from drug of abuse can have the best treatment to see that they can become useful and helpful member of the community. And what is the GHI approach? That's the Green Crescent Development Initiative in Nigeria. Their whole approach is to use this holistic approach and look at by employing the following tactics and innovation. They look at the indicated population, they look at the evidence to base for it, and using the evidence, they approach it based on that. And that is what my earlier slide I've tried to look at, the holistic approach. And this is what we employ as a pro-life movement NGO in Nigeria who wants everybody to stay off the arms from addiction, all form of addiction to stay, whether it be drugs, whether it be a process addiction or behavioral addictions, thinking of gambling and the rest. So we are using this approach to see that we get the best and be able to reach people and be able to help them to see that they can become functional, useful member of the community, and also to become useful and functional to themselves. At this point, I want to conclude that the holistic model will help us to bridge the gap between the different evidence-based approaches. And this will help us to create compassionate addiction management programs, which often involve multiple pathways and require ongoing support beyond the initial treatment phase. Thank you very much for your attention. Sorry for the initial hiccup about my slide. Thanks. Next.
Thank you very much, Dr. Aviola. I mean, it was really informative, and especially the tensions and your comparison between harm reduction versus harm denying approach. Although terminology, it looks like very similar, but there are really big differences on the approach. And also to share about Green Crescent Nigeria's approach about evidence-based, and for holistic model can fill the gap between different approaches. Thank you very much for your presentation. There are some questions for you, but we will take the questions after Dr. Belkis' presentation. Dr. Belkis Binti Muhammad Qasim from Malaysia, Green Crescent, is a psychiatry trainee at Hospital Consular Tuanku Muhriz, National University of Malaysia, with a strong focus on mental health and addiction prevention. In addition to her medical career, Dr. Belkis is committed to community service. She serves as the secretary of the Green Crescent Malaysia, an organization dedicated to addiction prevention, and volunteers with Mercy Malaysia in various humanitarian efforts. Internationally, she has been previously nominated for leadership roles within the Vienna NGO Committee on Drugs, VNGOC, contributing to global discussions on addiction and substance abuse. Dr. Belkis' speech will be about preventing psychoactive substance abuse, Green Crescent Malaysia's comprehensive approach to education and community empowerment. Dr. Belkis, floor is yours. Welcome.
Thank you very much for the kind introduction, Dr. Mahmoud. I will share my screen. Good afternoon, everyone. Today I will be presenting on the Preventing Psychoactive Substance Abuse, Green Crescent Malaysia's comprehensive approach to education and community empowerment. Okay, so for the outline of my topic today, the first part is about the understanding about the psychoactive substances and also its concern. Green Crescent Malaysia's comprehensive and also preventive approach regarding the area of focus, some recent use of new psychoactive substances in our local setting, and also challenges and future goals. So regarding the psychoactive substance, we feel that there is the need to address for early preventions. So as we know, psychoactive substances are chemicals that can affect the central nervous system and eventually can alter the brain function, which leads to changes in our perceptions, in our mood, consciousness, cognition, and also behavior. So these substances can range from legal substances, for example, some caffeine, alcohol, nicotine, and also illegal or controlled substances such as cannabis, psychoactive substances, cocaine, and also heroin. Okay, so why is the use of psychoactive substances is a growing concern in Malaysia? It involves a lot of factors, and these are the important factors that I would like to share about. So we see, and our concern is there is a rising prevalences of the drug use. There is also a changes of demographics of the drug users, which previously we see that it's more to unemployed or poor socioeconomic status. However, now the recent trend is merging towards the highly earned professionals, university students, which they started to use the substances as a method of to cope with their life challenges. There is also a youth and early initiation, where we see that there is where the trend now is the youth and also the younger generation are taking more the new and also synthetic drugs among themselves. And they can start as early as 13 to 15 years old, which are the age that they are going to secondary schools. Apart from that, there is also mental health issues and also social impact. So we are aware that the link between the drug and also substance addiction, they can affect our mental health issues, which make us more prone to get any psychiatric diagnosis, such as anxiety disorder, depression, and also psychotic disorder. They also have played a role in affecting our social impact, where eventually people who take the drugs are also involved in drug or substance use, they can lose their jobs, they can lose their families, and eventually they become unemployed and lose their jobs, which make them drawn towards the poor socioeconomic status. Regarding the legal and policy implications, Malaysia actually practice a very strict no-drug law. So probably this strict law influence some people and prevent them from getting or seeking for help. So they know that they need to seek for help. However, because of the law implementations, and they are worried regarding the consequences of it, they did not get the help that they should. Apart from that, there is also cultural and social stigma, where people tend to isolate those who involve in drugs. They don't want them to be a negative influence towards others, towards those in the society. So these are the graphs showing the prevalences of psychoactive substances use by the age group in Malaysia. This data show about 10 years from 2010 to 2020. We can see that the trend from the graph that the new psychoactive substances, which is color-coded in orange, they actually showing an even distribution among all the age group. Which show us that all age group are involved in using the new psychoactive substances. So we also notice that as we progress, from 2010 to 2020, new psychoactive substances are being used more in view of its availability in online setting. So from this data and from these factors, we Green Crescent Malaysia take the preventive approach by focusing on the following area of focus, which are by community engagement, by education, and also by advocacy. So these are the programs that we conducted among the secondary schools, which we hope that by educating the youth, by educating the school-going children, school-going groups, that they will learn about the substance addictions, about the dangers of involving with them, and also to equip and empower them with a good coping mechanism so that they won't eventually ended up using substances as a method of coping, which can further deteriorate their life. So we are aware regarding the relationship between the connection for the psychoactive substances with mental health. Hence, we organize program which promote a holistic well-being by educating the public about the relationship between the mental health and also the substance. So we also collaborate with universities and also higher education institutions by organizing a workshop, which we call as peer support program, so that we train those who attend our workshops for them to be a support to their peers, because we believe that by training peers, that this will make them to feel more comfortable in sharing those who are the same age group with them about their problems, and those who they go to share their problems has a good knowledge and has a good coping mechanism, so that they can guide their peers, guide their friends, that they know that this is the problem that they have, and they know that when to seek for professional help. We also organize public campaigns, including organizing a webinar regarding the substances, and also addressing the issue on media such as newspapers. And also we organize programs which we call as Cycling Against Addictions, where we want to increase and also to educate the public regarding the dangers of the substance use, and also to make them know that there is the source and also the right place for them to seek for help if they need. So from here, we also engage with the parents and also older adults so that they can educate their families regarding the mental health and also addiction issue, which probably might not be addressed frequently among the family members. So when we feel that when we educate the parents, when we educate the older adults, they have the knowledge and also they have the information so that they can go back and return home and to educate their whole family members about it. So these are some examples of the recent news related to new psychoactive substances, which is in Malaysia. So we are aware that there is global challenges, which this news is from our Malaysian Deputy Inspector General of Police. So the challenges and future goals regarding the emerging trends in psychoactive substances is a lot. So we feel that there is need for more robust digital education campaign, which we feel that instead of blaming the digital or online platform as a matter for the increase of use of substance, we should use these available platforms to educate and also to empower our community about it. We also feel there is a need to create partnerships with technology companies to tackle online sales of illicit substances and also to collaborate with respective ministries such as Ministry of Health as part of our stakeholders. Thank you. That's all from me.
Thank you very much, Dr. Belkis. In fact, you really also touch on very important concerns. First, the first one, why it's increasing substance usage in Malaysia. And you shared your programs, awareness programs for different target groups. And I think it was important for promoting holistic well-being because fighting with addictions or treatment is not only limited with that one. That's why promoting holistic well-being can be really helpful. What I liked is also peer education, because we know peer-to-peer communication is very strong. That's why it can be really helpful for other countries, for other cases, and of course, public campaigns, how to use it. Now, distinguished participants, distinguished doctors, we have some questions from our participants. I want to start from Madam Tuwala. Madam Tuwala, there are some questions about your Kenya's experience. I want to start. It was mentioned in the previous sessions that women's substance use is increasing, but they have problems accessing to treatment. Do you have data on access to treatment in Kenya for women and adolescents? And there's one more question about this. You mentioned that there are few facilities for women and adolescents. What efforts are currently being undertaken to increase the number of these facilities as part of the struggle against addiction? This is, I can ask as the first question, please.
Thank you very much for the question. Yes, I agree that there's a rise in addiction among the women and adolescents in Kenya. And like I said, it's a fact that we have very few facilities that are designed specifically for the adolescents and the women. So what we are doing is to lobby with the government to locate resources so that we can establish women and adolescent specific facilities. Our efforts are bearing fruits, and on the other side, the private sector has also engaged in this discussion, and we have few that are already functional. So we are moving towards enhancing accessibility for women and adolescents in the country.
And thank you very much. And as a second question, you mentioned the problems of stigmatization in Kenya. Have you started to see the results of your campaigns on stigmatization? Are there any advocacy activities you can recommend based on your experience? And as the last question to you, Madam Tuwala, is do you receive government support for your prevention and rehabilitation works in Kenya? As I understood, NACADA is a government organization.
Yes.
Okay, but what about this stigmatization?
the stigma that surrounds addiction. You know, we are still advocating and sensitizing the communities that addiction is it's a disease. So initially, people didn't think that. They were looking at it as a moral flaw. So if you are addicted, nobody was concerned about you, nobody cared about you, because for them it is a problem of your own making. But with this continued advocacy, especially through the vernacular radio stations, whereby we are speaking to Kenyans in a language that they understand, we are speaking to their hearts. Using live examples and showing them people who have been active in addiction, people who have recovered and now living a responsible life, and saying, surely addiction treatment works. And we are also telling them they have a responsibility to support these people, to hold their hands through the recovery journey, and also to provide the warmth and the connection that every human being needs. And we have seen a lot of fruits, and this has been demonstrated through the number of persons that are seeking rehabilitation help. It is rising day after day. So there is hope. There is hope.
It's very important. It's very important to change the mindsets of the public and then the families is very important. Thank you very much for your presentation again and for your answers. For Dr. Tabiola, there are some questions also for you. Can you provide information about the burden of substance-related diseases in Nigeria? What are the studies carried on this issue? Dr. Abiola, can you hear us? Let me try again. Dr. Abiola, can you hear us? Maybe we can have a connection problem. Let me shift to Dr. Belkis. If Dr. Abiola connects again, we can continue. Dr. Belkis, also for you, do you have prevention programs, especially for disadvantaged individuals in Malaysia? And what are some of the reasons why substance use starts at a young age in Malaysia?
Sorry, for the first questions regarding the people with disabilities in Malaysia, do we have the system? Sorry,
Yes, do you have any prevention programs for disadvantaged individuals?
Prevention program for disadvantaged individuals. So for Green Crescent Malaysia itself, we don't have this yet because our focus is mostly on preventive measures. So it's more to aiming to the youth and also younger generation. That is for the first part. Sorry, for the second question.
What are some of the reasons why substance use starts at young age in Malaysia? Do you have any activities for parents? And if so, what kind of activities do you have for parents?
Okay. So I believe that the onset of substance in Malaysia we started to see the young people to get young to use the substance at early age is because we face a challenge with the e-cigarettes, which is the vape. So we don't have any illegal act about it yet, because actually it is the use is currently legal in Malaysia. However, I think some people have taken the advantage of it by selling the drugs as part of the flavors. Because initially, vape came as a method to reduce the need for cigarette use. However, it has been misused when they create a flavor which we feel that it is a drug, also a substance flavor, which and also the design of the vape itself, the pot that they are using is quite fancy. So if you see it on the first time, probably you won't see it as the pot of the vape. It's very cute, like it's very attractive to the young people. So I think it's one of the reason why we are seeing more younger people in the prevalence of using the substance. Regarding the programs with the parents, We don't have any specific programs with the parents at the moment. We are focusing a lot on school-going children and by conducting a peer program workshop. However, we had a chance to conduct a program that I have shown before. That is we collaborate with the organization of older adults, which they have a trip to our local universities, and we take the opportunity to educate them regarding the mental health and also addiction. But I think it's a good, I'm taking it as a good suggestion for our future programs on what to do with, on our collaboration with the parents in the future. Thank you.
Thank you very much. But you already replied some part of this question. But if there is anything to add, one question is, what is the reason of increase in the use of new psychoactive substances in Malaysia?
Regarding this, I feel that it is related to the flavor of the vape, which is not being, there is no law enforcement regarding its illegal, as an illegal drugs. And it's, and for myself, in hospital setting, it's quite difficult for us because these substances is not being detected in the common kit that we use to detect the drugs. So they are getting more creative about it. We are trying to go that we have seen that this carries a lot of medical and also psychiatric problem among our youth, and we are trying to we really hope that eventually that the government take some initiative for it to be an illegal substance to be used in our local setting.
Thank you very much. And what you are saying is not only for Malaysia, I think globally, for
Yes,
those new
definitely.
synthetic drugs, as Dr. Abiola mentioned, there are some tensions, there are new areas. It can be policy gaps, they can be cheaper. I mean, it is very dynamic area. I mean, fighting with addictions, treatment, rehabilitation, prevention of addictions are a very dynamic area because producers are also very dynamic. They are looking
True.
for new synthetic drugs. They are looking for new techniques, and they are very successful, in fact, from their perspective, unfortunately. But for the people who are working in this field, like all of us, I think we must be very active and dynamic. And by the way, thank you very much for all those participants for these good questions. Dr. Abiola, we have also some questions for you from our participants. Can you provide information about the burden of substance-related diseases in Nigeria? What are the studies carried out on this issue?
Okay, thank you very much. There are quite a large number of studies that find the range of substance use to range from that's across different geopolitical zones in Nigeria. You know, Nigeria being a big country, we are about 15% of African population. We are about 3% of the world population. So that gives us a lot of challenge. And we have 6 geopolitical zones with different challenges across it. And so based on the zone that one will be looking at it, for instance, if you talk of Northeast, that is where the statistics showing that the highest use of cannabis sativa, that's marijuana, is highest there. And surprisingly, it's even higher among the female than the male. Part of the reason is usually attributed to the ongoing insurgency in that area of Nigeria, where we have different international insurgent groups that coalesce and foment a lot of trouble in that area. So cannabis is very high there. It can be as high as about 10 to 14% in that area. Where other part of the country it's as low as about 5.something%. And when we look at other substances like the legal substances like alcohol and tobacco, they are as high as 40 to 60%. They range between that. because of the so-called legal status given to them. So this makes the prevalence to vary across the country. We know that the ingestion of alcohol is more in the southern part of Nigeria compared to the northern part of the country. So it's much higher there because of the permissiveness of it, where in the northern part of the country, the prohibition from religion, Islam, in a way limits the number of usage of it in that area. When we pick things like methamphetamine, the stimulants, cocaine, we find that it's widely more used in the northwestern part of the country, which is where the larger population in the northern part of the country, where the largest population are Kano, Kaduna, Katsina, which contribute a large chunk of population in the country. They will find that this area contributed to use of more stimulants. Of course, the reason were not far-fetched because of this economic availability. People can easily buy it. They are expensive to buy, but because there is economic activity higher in the area, so it's easily procured. And also because of the transnational movement of hard drugs. Like, for instance, cocaine is not produced in Nigeria. It is planted somewhere in Brazil and in those areas, the so-called the crescent, the two crescent, the Afghanistan and the Brazil area. But from those areas, they find it that it's cheaper to transport it through the sea and the land areas into the Nigerian that's especially through the West Africa. So it have access to the northern part of the country. So that also provides means for you to be domiciled there. And then from especially the capital city, where they can be trafficked down to the Western country, Euro-American country, where the value of it becomes more expensive so that they can get more profit from it. So the dynamics in Nigeria is more cumbersome. So the range varies across these geopolitical zones in the country. So that is why giving one value is difficult in Nigeria. So we have to look at those geopolitical zones. Of course, there are hospital data too. For instance, where I currently work, which is a teaching hospital, I'm in the drug addiction treatment and education rehabilitation unit. The place has been established for about since 2017. That's when it was established. And it has seen close to 100 people that have gone through rehabilitation. But because of lack of bed space, the facility have about maximum of 11 bed space. That's for admission, inpatient admission. And it has, over that period, you have seen more than 80 people within that period. And the experience is quite challenging because, of course, majority of the people seen are usually people who use in this area, unlike most other treatment centers. In this particular treatment center, majority of the people are people who use injectables, especially the pentazocine. That's the opioid, the injectable opioid. They are the ones that use it in this area. And that's the largest number of people that were admitted there. And they usually come in very bad shapes. They will come with so many ulcers. That's the wounds because of the injection they use. Some are so pathetic. You see some will come, all their lower limbs are full of wounds. Some, their trunks, their abdomen, everywhere, you just see wounds there. So treating those complications, but they were lucky because being a multi-specialist hospital, a teaching hospital, we were able to have access to people who are in maybe the bones unit, that's the plastic surgery unit. We have the wound unit. We have people also come with other comorbidity like hypertension, diabetes, which may come along the line. People may also have infection like hepatitis. So we're able to advise all these specialists for their services. And once they stay here, they love. But one of interesting findings is that we also have process addiction, gambling addiction. Over the year, 3 people have gone through treatment there for gambling addiction, especially they are due to e-betting, this online gambling source. And the minimum, when we look at it in terms of Nigeria currency, average that they've ringed in terms of money, it's about 30 million averagely for those 3 people. Even with the current economic hardship in the country, nobody will have that. I will still say it doesn't have money. And that is huge. Based on, if we want to look at a rough equivalent to dollar, that's more than $10,000 that these people have because of gambling addiction. So each hospital experience differs. Each treatment center is where I'm coming from, which is in the north, that's in Kaduna State, the Federal Neuropsychiatric Hospital, Kaduna. The treatment center is there, but the range of experience there is quite different from where I'm just now. Because where I was before, we have more of people who use cocaine, cannabis, alcohol. But we don't see more people who use injectables. They hardly don't come to this area. We have seen few, but they are not like in this area where more than 60% of the people that are treated where currently are more than people who are using injectables. So the experience in Nigeria is so cumbersome. It's so challenging that if you want to fix a value to it, it's so troubling, because by the time you harvest data across, you discover that they are just different stories, different picture that one is seeing. And that has made the effort very difficult. There are few people who are available to actually provide the right treatment. There are many charlatans treatment centers where
Doctor,
they change people.
just in this case, there's a second question which is very much related about what you're telling. Does Nigeria has a national strategy plan on addiction within your health system?
Yes, we have, but it's one of those that has been launched of recent, that updated form. We have the National Drug Monitoring Act. So we have that, but the implementation is challenging because Nigeria operated like a federation system. Even if the national have a policy, each state across the country have to adopt it, and in the process they modify it to suit their own needs. So that also contributes to it. But however, irrespective of that, because of the scarcity of actual available space for treatment, that makes the implementation of the National Act difficult. We also have what we call the National Mental Health Act, which has not been used to look at all mental illness generally. Of course, substance abuse disorder is also part of the mental health that being treated. So we have those laws that should help us in managing this, but in a way they were more difficult to implement because of some of the peculiarities in the law. Because for instance, the National Health Law can give people who need treatment to say, I don't want treatment. You cannot enforce it on them. There are some limitations, there are some legal loopholes, there are some ways that they can challenge when you say this individual actually needs treatment. There's those loopholes. So often the treatment center often adapt it is only when you want treatment we give you. If you say you're okay, you go. So that's also true. But despite that, you hardly find space available in those standard treatment centers where they're evidence-based. People will come and be begging, yes, I need treatment, but there's no bed space because they are few and they are almost always occupied. So the challenge is large. Yeah.
Thank
you. I hope this helps.
I have one question to Madam Tuwala and Dr. Abiola from African perspective, because I'm also living in an African country. Dr. Abiola mentioned about the religious maybe differences, but I want to ask from tribe differences. We know that in Kenya, in Nigeria, there are different tribes are living. Did you see any cultural effects or the tribes' effects on addictions, on the positive and also on the negative way? Madam Tuwala?
Thank you very much for that question. In Kenya, we have around 42 different tribes. Each tribe has its own practices, beliefs, and of course, approaches. And like I said initially about, there are some cultural practices that really, really encourage substance use, especially the initiation. During initiation, when the boys reach puberty and they get circumcised, in some communities, like in the western part of Kenya, people drink beer. The boys are encouraged to experiment with beer as a sign of adulthood. It's like entry, being ushered into adulthood. And of course, with the ignorance, some of these communities do not know that some kids could be genetically predisposed to addiction. So when they initiate these substances, some of them continue drinking into dependence, others do not. So some of the cultural practices like those ones really encourage people to use. And like I said, we are really doing a lot of public education and advocacy to enhance their knowledge on matters addiction and substance use. So yes, I agree, some of our cultural practices can lead into that. The other one could be during wedding ceremonies where people are encouraged to drink, and even during birthday parties where a party is not complete without alcohol or other substances. And we have not given up in sensitizing Kenyans on the strength of protecting our children from substance use and even experimenting. And I remember initially you had asked about Malaysia, if they have any family-related programming. In Kenya, yes, we have positive parenting program whereby we are teaching the parents their role in bringing up kids that are protected, kids that are warm, kids that are responsible, and kids that will say no to alcohol and drugs. So we are really engaging with parents, and it's a very big program in Kenya whereby we are looking for these parents during school meetings, in the churches, in the mosques, in the women meetings, and even men meetings. So we are looking for parents in all forums to make sure that they understand that parenting is a lifelong process. We have also noted that when kids go to tertiary institutions, it's like parenting stops. Once I have paid the school fees for my child, I no longer care the people they relate with, the places they go to, even their school performance. I have paid the school fees, I am done. But we are telling them that parenting is a lifelong process. You cannot stop monitoring what is happening with your children in your children's life, and even their school performance is very critical in this positive parenting program. Thank you.
I see. And thank you very much for your efforts. Dr. Tabiola, what do you say about this tribes effects on positive or negative about addictions?
Tribes, if we look at it across tribes, where there are, like she politely pointed out, we have some cultural practices that actually idolize drug use. For instance, there are even some proverbs that use that to show that this actually is welcome. For instance, among the Igbo, they have a proverb, which is one of the major 3 ethnic groups in Nigeria, that who brings cola brings life. We know the major source of cola nut, that's cola nuts. The major active ingredient in it is caffeine. So often it is the caffeine in it that people might be referring to. So then that is one. Then another cultural norm that also do that due to the traditional practice generally, like people believe that if there is any occasion, irrespective of the occasion, whether naming ceremony, marriage,
I think we have connection problem with Dr. Abiola's connection. Yes, we have something.
My apology, my network.
Yes,
but I don't know if you can hear me now.
Please conclude your last sentences. We are in last minute.
Yeah, well, what I'm just saying that the ceremonies also permit it and also promote it. That people believe that if they are doing graduation, whether from school, whether from learning as artisan, if you don't use alcohol like a libation to call on the gods of that trade, the individual might not succeed in the trade. Then there are also people that try to use scriptural, that the first miracle of Jesus Christ is to turn water to alcohol, to wine. So the people use so many things that they don't even understand what those scriptural contexts are, what are their meaning. So they misuse it, they misapply it, and they use that to promote it. And also the government doesn't have rigid law against that. So that keeps spreading far and wide. Like even like the betting, the government only law is about for those people to use percentage of what they get as profit for social goods. That's what they're about. But the arms that come from it, they are not forcing them to treat people. They're not forcing them to repair. So that challenge is there. In the northern part of the country, yes, the religion is there that specifically prohibits drinking of alcohol, especially among the Muslim, where majority are in the north. The religion plays a role there, which is akin to culture in a way there too. But however, it also promotes the use of cigarettes, because people only thought that because it's specifically mentioned, it's only about alcohol. They are not saying that it's about arms, anything that can be harmful. So they also neglect. It's like they trade one for the other. So they trade drinking for smoking. So they smoke cigarette, they smoke cannabis, Then they also have other flavored smoking that they do, like shisha. And there are also different forms of smoking that they can lace all these cannabis leaves with cocaine, with any form of thing they want to lace it with and drink it. Then they also have smoking parlor around. So the challenge is across, and their cultural promotion of it. And also the affluent also have their own way of promoting it. They see it as a thing that of status, that it is when you belong to us, then when you join this club, you behave this way. So that also play a role, and peer pressure and the affluent works in that area, that they keep making, that even people who are poor, for them to feel that, okay, I too am successful, they will waste their meager resources to try and behave like the rich. So that challenge is there. So those culture around. Thank you. Sorry.
No problem. Thank you very much. I mean, it was very fruitful, I think, session. Madam Tuwala from Kenya, Dr. Abiola from Nigeria, and Dr. Belkis from Malaysia. Thank you very much. About fighting and with addictions, I think our geography, our professional is not matter. There are a lot of things to learn from in each other. Developed country, developing country, Africa, Asia, Europe, America, it doesn't matter because it's a really global problem. It is a growing problem, nearly in all age group we see, and it is very dynamic problem. That's why these kind of sessions are really useful to learn from in each other, to support, to encourage in each other, to share experience in each other. Thank you very much for what are you doing in your countries on behalf of all humanity and on behalf of the Green Crescent Society in Turkey. Hope to meet you in another occasions. Dear participants who are watching us from their computers, from their networks, I hope you also learn and share the experiences. Thanks for the questions. Hope to meet you in another scientific or congress about addictions. Thank you very much for all.
Thank you.
Hope to meet you in face-to-face also.
I would like to thank our esteemed session chair and the distinguished speakers for this valuable session and for their great contributions. The participants, after 2 days of the Congress, were national and international speakers whom are experts in their field, discuss critical issues, each more important than the last. The International Congress on Psychoactive Substance Use Disorders draws to a close. I would like to extend our sincere thanks and appreciation to all of the distinguished speakers, session chairs, and country Green Crescents for sharing their valuable knowledge with us and talking on the new solutions in the field of tackling substance use disorders. And I would like to thank you, our esteemed participants, for taking part in this Congress. We hope you had a very productive and fruitful Congress in the past 2 days and looking forward to meet you next year to happier and healthier generation. Take care.